eye is injured along with the polytrauma. That's why the whole day CME. And I like to invite my...
We are going to launch off on the CME on polytrauma and trauma, ocular trauma and polytrauma. This is an interesting concept, as we are going beyond the confines of ocular trauma and involving polytrauma to see what kind of care has to be given to people who develop injuries other than the eyes. Of course, the eyes cause a lot of difficulties in quality of life, but it is compounded when there is a polytrauma which is associated with this. We are fortunate to have a lot of sort of leaders in trauma and surgical care of trauma, and we have people who have traveled far and wide, like Dr. Redak, who has come all the way from Poland to be here with us. And we have Dr. Subodhi also, who has come from far. And also, we would like to welcome our non-ophthalmic colleagues like Dr. Vinod Kumar and Shubha Matal, who are in their own fields prolific, and they would add a new dimension in the field of... I hope you enjoyed the proceedings. Thank you so much. Thank you, Dr. Natarajan, for giving me the occasion to chair this thing.
So I'm happy to introduce my co-chair, Dr. Sunil Morekar. Sunil Morekar is an oculoplastic surgeon, and he's I call him as the best man with a clinical acumen. So I would like to request him to say a few words as co-chairman and his role in CME and what is the other one? CPD. So he will tell, because the whole thing is, even though the audience is less, but we have the it will be online in docplexes and YouTube. Idea is, the whole idea of this program is to encourage young ophthalmologists to repair the eye event, not only anatomically, to get vision also.
So I have been in medical education since the last 30 years, working first with medical education in Mumbai and now in Mumbai with medical colleges, and then worked as a professor in DMV in charge for Dr. Natarajan, and that's where I actually started looking at medical education in terms of undergraduate, postgraduate and fellows. So that's the first time he told me that you have to progress from doing a soft cataract, which is an undergraduate brain, and then you have to go for a semi-soft or grade 2 cataract, and then go to the fellows and the PhDs who are the hard cataracts. So when we talk about this, we talk about we do not finish our medical education as we get the degree. We continue to learn because many things will keep on occurring, and COVID has shown us that a lot of things have changed. So we look at not just CME or continuing medical education, we look at what is called a CPD. CPD is something which is very prevalent in Europe, but in its nascent stages in India. And we talk about various aspects of the CPD, where we talk about risk management modules, we talk about medical legal cases, we talk about how you would manage time management when it comes to trauma, triage in trauma, and so many things there. And that is where we are headed in terms of CPD, which is a bigger and a larger dimension than just CME. So this is a very wonderful CPD event, and I think we should start.
So welcome Dr. Chaya Shinde, Head of the Department of Ophthalmology, Lokman Medical College in Sion, and I'm happy I'm working with her as Emeritus Professor of Ophthalmology in Sion Medical College. So we hope her students will join. Madam, can you say a few words and we can start? Dr. Saili Shirodkar is here.
Hello.
Madam, Dr. Saili is from your department, right?
Hello.
Okay, sorry.
Good morning, all. It's a wonderful morning, and we all are here to learn a lot about trauma. Nowadays, road traffic accidents, railway accidents, so many accidents are occurring, and very aptly, sir has designed this program along with Karopillari madam. So we will learn a lot during this session. I am very proud that we have a team of eminent surgeons like Dr. Natarajan is here, and he is always is striving hard to pass the knowledge to everyone around, and he is a renowned international surgeon. Karvilari madam is there. He has taken hard efforts to plan this program. I wish all the success to this program. Thank
Madam,
you.
can you introduce Dr. Vinith Kumar? He is the first speaker now. Dr. He is here from SAM.
Hi, good morning. Yeah, Dr. Vinith Kumar is a surgeon in Lokmanya Tilak Municipal Medical College, and thank you, Vinith, for accepting the invitation for your talk.
Sir, you can hear. So his talk is on polytrauma, managing polytrauma. The reason we have him is that we want, when polytrauma is happening, Sion is a trauma center of Mumbai. Apart from the one in Goregaon where Bala Thackeray is named, we have a municipal hospital.
Good morning to all, and good morning to all the eminent faculty, the organizing team. I'm very grateful to be on this non-general surgical platform. It gives me a great privilege to speak for a few minutes on management of polytrauma in a platform where more facets of ophthalmic trauma is being discussed, and I hope I can share a few tenets with all of you. In 1982, Donald Trump said that there is a trimodal distribution of death after trauma. The first peak comes within a few minutes. That is almost the accident which causes the death at the scene itself. This is generally because of injury to high spinal cord or major blood vessels like aorta. These patients are usually non-salvageable. The second peak comes within a few minutes to a few hours, and this is where all of us come in, where immediate intervention or action within what is called as the golden hour. It's not actually 60 minutes, but it is the period of time where your intervention can save lives. These patients usually have something like tension pneumothorax or intracranial hemorrhage, where we have to intervene to have a good outcome. The third peak comes weeks and months later after the trauma, where the patient is in long-term in the ICU, causing sepsis, coagulopathy, deep vein thrombosis, and these outcomes can become better basically because of good ICU care or nursing care. Now let's start with a small case report. A 24-year-old male, as madam said, road traffic accidents are most common in India and across the world. So he has a motorcycle accident, and as you have seen so many places around Bombay, most of them don't wear helmets. They are driving two in one on one vehicle, sometimes three. Yesterday I saw four adults on one two-wheeler, no one wearing helmets. So he has a head injury and he is minimally responsive. His pulse is 140 beats per minute, his respiratory rate is 40, and his blood pressure is 80 millimeters of mercury systolic. He has a left thigh deformity with a bleeding wound. Now, this patient has got a polytrauma. How do you proceed? And that's what I'm going to cover in the next few minutes. So the plan of treatment is to identify and treat the most life-threatening conditions. Okay? And the target is that the oxygen has to reach the tissues. Now, how do we do that? The concepts of initial assessment were prescribed by the Advanced Trauma Life Support. This is an American College of Surgeons course which runs across the world and in India and in Mumbai in Sion Hospital as well. We have been doing it since 2012, although the first ATLS course started in the US in the 1980s. So what it says is that you have to start preparing before the patient comes in. You have to do a primary survey, you resuscitate the patient, you use adjuncts, and you re-evaluate the patient. Once the patient starts improving, then you move on to a detailed secondary survey. Again, you continue to resuscitate the patient, you use more adjuncts to help you diagnose the problems and help you treat the patient, re-evaluate the patient, and now the patient goes for definitive care. So what is this primary survey? What is this terminology? This basically says A, B, C, D, E, which you learnt in your nursery. We're coming back to that. So airway with cervical spine control, breathing and ventilation, circulation and hemorrhage control, disability which is neurological, central neurological disability, and exposure and the environment control. We'll be delving into this in a little bit of detail. You simultaneously resuscitate the patient. That means you give extra supplemental oxygen to all patients irrespective of their mental condition. You give fluids, which is isotonic fluids, 1 liter bolus, and then accordingly you can keep increasing, or requires, the patient has got hemorrhagic shock, he may require blood and blood components. In pediatric patients, of course, you have to give the fluids based on 20 ml per kg or blood as per 10 ml per kg. You do certain investigations like grouping cross-matching. You put adjuncts like nasogastric tube or an indwelling Foley's catheter, and you monitor this patient using a pulse oximeter or a cardioscope. Once you've resuscitated the patient, you have reevaluated the patient, then you can move on to the secondary survey, which is ample history. Now, what is ample? It's a mnemonic for allergies, medications, past medical history or pregnancy, last meal, and events leading to the injury. Now, you do not want to know whether the patient has had an appendectomy 20 years back, or his father had diabetes, or something like that. No, you want to have a very specific history which is ample. Then you do a head-to-toe examination as well as a front-to-back, which means that you need to do something which is demonstrated in that picture, which is called as a log roll. And then you do certain special investigations for diagnosing further injuries. If you are shifting the patient out of the ICU or out of the casualty or out of the ED for any investigations, check ABC before the patient goes and after the patient comes back. When do you start the secondary survey? After the primary survey is complete. So if you have a patient who is hypotensive, that means ABC, the C component is what is the problem in this particular patient. If that does not improve, you cannot go to the secondary survey unless you finish the primary survey. It is not like an MCQ that you can go back and come back later on. No, you finish A, go to B, finish B, go to C. Like that, you finish your primary survey and then go to the secondary survey. So ABCDs are reassessed and vital functions are returning to normal. Re-evaluation is for basically less severe injuries, unrecognized injuries, and underlying medical problems. If at any point of time the patient does not progress in the way that you anticipate, you need to go back and start with ABC all over again. When we come to definitive treatment, there are polytrauma, there is multiple injuries with competing priorities, and you have to decide which injury has got a higher priority to be treated first. Now, this was actually the summary of the talk. Now to go into a slight bit of detail. How do you actually start evaluating or assessing the patient? Very simple. Ask the patient his or her name, ask what happened. Okay? There are only two options which will happen. Either he will answer or he will not answer. Okay? So if there is no verbalization, if there are foreign sounds, if there is a husky voice or is a facial maxillary injury, you may have to consider that the patient is in airway obstruction. And you need to do certain interventions which may be temporary, like clear secretions, chin lift, jaw thrust, put an oropharyngeal airway or a laryngeal mask to take care of the airway. If the patient is in a higher risk of airway obstruction, you may need to put in an orotracheal or a nasotracheal tube for securing the airway. If you are unable to secure the airway, you may have to go for a needle cricothyroidotomy or a surgical or a stab cricothyroidotomy as a measure of a surgical airway. These cases of difficult intubation, facial-maxillary injury, laryngotracheal injury, tracheal foreign body may warrant a surgical airway. Remember, you have to assume that a cervical spine injury may be present in all these patients, and hence too much of extension of the neck should be avoided and manual inline stabilization can be done. During transport of this patient to say CT scan or MRI, you need to immobilize the entire spine using hard cervical collar, side blocks, spine board, and strapping the patient to the spine board. Now, once we finished A, we come to B. So is the patient breathing? Is it adequate? If it is not adequate, the patient may need ventilatory assistance. Is the chest expanding? And we have to look for certain life-threatening injuries in the chest that cause a cardiorespiratory embarrassment. Something like a tension pneumothorax or a massive pneumothorax or a flail chest or an open pneumothorax. So how do you treat these breathing problems? For tension pneumothorax, you have to do a needle thoracocentesis followed by a chest tube decompression. For open pneumothorax, you put a 3-way flutter valve dressing, which temporarily gives you some time, before which you can put a chest tube as well. If there is a massive pneumothorax, there is a breathing problem as well as a circulation problem. So you need to put a chest tube to decompress the chest as well as give volume replacement for the blood, SOS surgery if needed. And for flail chest, the main problem is the pulmonary contusion, which is the underlying problem. So chest tube may or may not be needed, but adequate analgesia is the mainstay of treatment in flail chest. Now after B, we come to C. So we do circulation. So we check for peripheral pulses, then we check for central pulses, then we check for the heartbeat. If the patient is in shock, which is generalized hypoperfusion, which is causing tissue, poor tissue oxygenation, then we need to resuscitate the patient accordingly. So you have to assess for organ perfusion not just by the pulse and the blood pressure, but also by the level of consciousness, the urine output, as well as the peripheral, the warm peripheries, or it is cold. Treatment of shock. If it is hemorrhagic shock, you have to control the blood bleeding source and give the replacement. If it is obstructive shock like tension pneumothorax or cardiac tamponade, then you treat it accordingly by pericardiocentesis or needle thoracocentesis. If it is neurogenic shock, then you need to give fluids and maybe add vasopressors. Common sources of bleeding, 1 on the floor and 4 more. That's the way you think about it. So 1 on the floor is the external, the other 4 are chest, abdomen, pelvis retroperitoneum and long bones. That's why X-ray chest, X-ray pelvis and FAST are considered as adjuncts to the primary survey. FAST is focused assessment by sonography in trauma. So if there is external bleeding, you control the external bleeding, you give compression dressings. If there is something like this, you can just tie a tourniquet or give a good compression dressing. If there is a pelvic fracture, you can put a pelvic fixation device. If not so, you can just tie a plain bed sheet around the pelvis and reduce the pelvic volume so that the tamponade effect causes the hemorrhage to get controlled. After we finish C, we come to D, and this is where we calculate the level of consciousness using Glasgow Coma Scale. So the eye response, the motor response and the verbal response. This is something that we read in the MBBS textbooks as well. So we calculate out of 15, a minimum of 3 and a maximum of 15. So 13 to 15 is mild head injury, 9 to 12 is moderate head injury, and 3 to 8 is severe head injury. The problem with severe head injury patients is they are unable to control their airway, hence they need a definitive airway or an intubation. Then we completely expose the patient to identify all injuries and cover them to prevent hypothermia. We can use adjuncts like a nasogastric tube, but if the patient has got base skull fracture, as you can see on your left, the patient has got something called the raccoon eyes or a battle sign, where there is a base skull fracture. On the right side, you see the Rice tube, which is coiled up in the brain or in the cranial cavity. So then you can put an orogastric tube instead of a nasogastric tube. When you want to put a Foley's catheter, if there is a suspicion of a urethral injury, then you should not put a Foley's catheter. Instead, think of a suprapubic cystostomy instead. Pain management, please give adequate analgesia, give tetanus toxoid. All these things are important, and monitoring is always also important. Now that you have done your primary survey and your secondary survey is yet to begin, you need to think about whether you have the capacity to treat the patient at your center or not. If you don't, you need to transfer this patient to a higher level of care within your institution or to another institution. Now, what patients require a higher level of care? These are usually polytrauma, multi-system, complex injuries, patient with age extremes like a pediatric patient or a geriatric patient, sometimes even a pregnant patient. These patients will require a higher level of care. So when do you transfer? Please remember, you don't give tetanus toxoid and one diclofenac injection and transfer a gasping patient to the next center. You have to treat the A, B, C. Once that is done, then you can start thinking about transferring this patient. So, to wind up, polytrauma, what are the competing priorities and in what order will we start treating the patients? The first priority will be your airway management. That takes precedence over any other injury. Then we come to injuries in the chest that cause cardiorespiratory embarrassment. These have to be treated second. Then we have to control the active severe hemorrhage Okay, so hemorrhage control is of third most priority. Then we come to decompression of the intracranial cavity causing mass effect. And after that we come to the reduction and stabilization of the cervical spine. Now we come to injuries of function loss. Now remember, what I am talking about is in priority for the life saving of the patient. I agree, ocular injuries, ENT injuries cause a lot of function loss and a quality of life loss. Yes, but in terms of saving the life of the patient, we have to go with the A, B, C, D, E in that order. The last priority will be closed fractures, dislocations and small soft tissue wounds. To summarize, I would like to say that an organized approach is important in an acutely injured patient. We have to take out time to train our team for the management of trauma. We cannot blame for what things we do not have. We have to use things that we have at our disposal, and even small methods or simple methods can help change the outcome. Thank you.
Dr. Vinishma, the reason we are doing the meeting on ophthalmic trauma and polytrauma, what I found is that I represent all the trauma societies of the world. And when I went and attended the American Society for Ophthalmic Trauma in Houston, and they have a manual or SOP for military trauma, but not for the civilian trauma. So my reason, I spoke to Dr. Mohan Joshi and Dr. Chaya Madam, we want to create a protocol. When there is a polytrauma, we have I think 25-30 residents in Sion Medical College, and every medical college has. So why not have a ophthalmologist call? In US there's going to be a problem because they want money for going and seeing a patient. But we at least in medical colleges and places like me, we do so many doctors come at a time, and we want to propagate this multidisciplinary approach, one for polytrauma, and even in ophthalmology, we have like him as oculoplasty, we have neuro-ophthalmologist, we have retina surgeon, we have cornea, and we have a protocol where what to do when. One is we want immediate repair, and second is within 3 days they should go to a tertiary care, and within 6 days the secondary or the tertiary vitreoretinal surgery should be done. And that's for ophthalmic trauma. But in polytrauma, why not Sion Hospital along with AIMS Delhi? I met not AIMS, the polytrauma person when he had our Ophthalmological Society conference in BHU, Banaras Hindu University. So I suggested to them that we three should create the protocol for the world. The world doesn't have the protocol for polytrauma, calling an ophthalmologist. There's a question, why should we call? But I know patients where 30 days the patients, you people are struggling to make the patient live and give oxygen and whatever. He was in coma, and the eye was not neglected totally. We had a open globe injury, and the eye went shrunk because nobody took care of that. Because even the nurse doesn't open the eye. So I am suggesting like delivery, when Dr. Kervaleri is a ROP specialist, it's mandatory now that when a newborn is born, when a premature, we need the neonatologist to call the retina surgeon, not the ophthalmologist. I'm clarifying. Same thing here. Every ophthalmologist should have this idea, and Sion Hospital should take the lead in India.
I think in Sion Hospital, madam is been there for a very long time. Most of our patients are definitely referred to ophthalmology within 24 hours.
No, I'm telling the ophthalmologist can come to because we have doctors on call.
Right.
So injury happens, you people are doing the orthopedic, making the person has to live.
Right, absolutely.
So doing all that in few minutes. Somebody can open the eye and check and interrupt somebody. You should be ophthalmologist.
Yeah, we can have that because we definitely do have the ophthalmology residents on call every day, 24/7. They are available in campus. So, and our trauma ICU receives about 7 or 8 patients on an average. It can go up to 20 and it can come down to 3 as well. But on an average, 7 to 8 patients in the ICU every day is what is there. And I'm sure that we can develop some kind of algorithm or a place where the ophthalmic residents can come and at least evaluate so that we can prevent further damage to the eye.
Dr. Vinit, let me congratulate you on the very nice lecture that you gave us. It was very crisp and it was good hearing you. Thank you.
Thank you.
So, madam, you and I already told Dr. Mohan Joshi, no, we should write the protocol, and the protocol should be published in all journals across. And we have Dr. Robert Reda, where he runs an Ophthalmic Trauma Institute for the last 50 years. Not him, it was started by his teacher's teacher, and it's a beautiful brand, old historic building, but now it's renovated, and April he is inaugurating, and I'm glad he invited me, so I'll be there doing some surgery.
Definitely, sir. So we would like to learn from you also, sir, and we'll develop some kind of system which will help the patients more and more.
So just wanted to add a couple of things here. Like since this is a CPD event, and CPD goes beyond CME and goes into the risk management modules and medical legal issues. So in ROP, we started getting, the patient gets better. 14 years later, somebody has made a claim of 14 crores because one of the twins lost eye and the other twin became a doctor. So he would have earned this much, so you have to pay that much. So in terms of, like ROP, in terms of ophthalmic trauma, you're right now talking to a doctor, an oculoplastic surgeon who's suffered 12 head injuries and 12 traumas. I have been injured in the eye a couple of times. There has been one crack fracture. So the medical legal aspects, I am very thankful for the general surgeons who saved my life. But if they had missed an ocular trauma, I would definitely file a case and seek compensation because I would not be able to operate. So the fact that you said that, so the trauma, what they're talking about is that the trauma protocol has to definitely compulsorily have ophthalmic referral for every patient, because it may not be possible for the polytrauma guys to know what is happening in the eye. The second thing is that there's another case 2 months back where a polytrauma patient, and like he said, a globe rupture, they saved the patient. The patient had an open lobe injury. It went into endophthalmitis. The endophthalmitis went into panophthalmitis. That led to sepsis later on, 7 days later. So maybe it's a time that an ophthalmic reference should be compulsory for every single trauma patient.
Agree, sir. And it's just to prevent the catastrophe from happening.
In injury, the first surgery, that's why there's a joke saying that the man is semi-coma with multiple injury, and the nurses and the surgeons are talking something, hey, did you go for the movie, or did you have lunch? And that fellow suddenly gets up and tells, hey people, please operate on me as though I'm going to live. Don't think that I'm dead. So that like that, people think that what is going to happen. So people like us are operating where we want the patient to not only anatomically get, and we are one small boy, I'm operating 6-7 times now. I look little smaller. Most of the hospitals, including Boston, has given up, but I'm not giving up. So the patient total cornea is wide. We have done multiple retina surgeries, and retina is attached with endoscopy we found. So we are going to do a penetrating keratoplasty. Till the last, I mean, we'll do, sometimes, I remember when I came from Shankar Natarajan to Bombay Hospital, people told me that, claimed that I'm doing multiple surgeries to earn money. That was the fact. Because most of the patients did not see, because they came late, 1 month late, but I operate. And trauma is the only place where, when there's no perception of light, we operate. And world over, that's my talk, all over I talk, please do the surgery, even if there's no PL, in an eye with the, because earlier, in 80s, we were removing the eye for preventing sympathetic ophthalmia. Now we know we can treat sympathetic ophthalmia, we don't want to remove the eye. So anyhow, so you to take the lead for making the protocol, and Dr. Chashinde, we all can have a club with AIMS and BHU and make a protocol for the whole world.
Sure.
Thank you.
Thank you.
And Joseph, you have the memento ready?
Yes. Thank you.
Okay. Can I request Dr. K. our Chief Organizing Chairman, to, because I don't know whether he will stay for the whole day. So in the meantime, Dr. Saili, are you ready? Yes. Yeah. Dr. Saili, come to the center. Get over here. You have to go to the center. Dr. Saili, yes, you can introduce yourself. So. take the opportunity to welcome Dr. Preeti. Dr. Preeti Kamdar is a glaucoma surgeon. So all subspecialties of ophthalmology are merging in managing ophthalmic trauma. Yeah, oh, I already welcome. No, I know. I only made him sit on the table. I welcome them.
Okay, so Dr. Mayur Morikar is my brother. We are blood relations, but more importantly, he's one person to whom I refer my cases many a times. So I see him less of a brother and more of a person, and he's more of a person who's an expert in inflammations, and trauma has a lot of inflammation. We control the inflammation. Without that, the results are not going to be great. So.
By the time Saili is loading, I think Dr. Mayur Morkar's role is preventing sympathetic ophthalmia, and if it happens, we can treat. And that's what we are going to convey through the CME. Ready? Yeah, please introduce yourself and start.
Good morning, everyone. I'm Dr. Saili Shirodkar. I'm a phaco-refractive surgeon. To begin with, I'd like to thank Dr. Natarajan sir and my mentor, Dr. Karubi ma'am, for giving me this opportunity. So my topic is going to be a little bit theoretical, so please bear with me before we dive back into the clinical aspect of it. So I'm going to be talking about the classification of ocular trauma and newer terminologies. So devising a classification is important and a challenging art, not just because of the variability in the human anatomy and physiology. It's particularly important to adequately triage and prognosticate your patient. And initially, the classification that we've had for so many years, which is the BETS classification, that is the Birmingham Eye Trauma Terminology, while comprehensive, it still lacks in certain aspects because around 33% of ocular traumas during a recent study were missed in this classification. So we are basically going to talk about newer terminologies and a newer classification for these injuries. So the BETS classification was devised in 1996 to classify mechanical eye injuries, and in this slide is not advanced. So, in 1996, it's already moved on. So BETS basically divides injuries into closed globe injuries and open globe injuries. Closed globe injuries are further divided into contusions and lamellar lacerations, and open globe injuries are divided into ruptures and lacerations. To basically discuss the terminologies that are involved in this, the eye wall is basically the sclera and cornea is what defines the eye wall. Closed globe injuries is when there is when the injury is not full thickness, whereas open globe injury is a full thickness injury. A closed globe injury is further divided into a contusion, which is usually because of a blunt object, and a lamellar laceration, which is a partial thickness injury but due to a sharp object. Open globe injuries include ruptures and lacerations. Ruptures are caused by blunt objects, whereas lacerations are caused by sharp objects. And lacerations are further divided into penetrating injuries, intraocular foreign bodies, and perforating injuries. Penetrating injuries will have just the one entrance wound. An intraocular foreign body will have an entrance wound and the presence of a retained foreign object. And a perforating injury will have two full thickness lacerations with an entrance and an exit injury. So this looks a little complicated, but I'll simplify it in the further slides. So the newer classification, which was proposed in 2009, divides injuries into local injuries, associated injuries, and environmental injuries. Now, local injuries can be mechanical or non-mechanical. Associated injuries will include head injuries, facial injuries, and multiple systemic injuries. And based on environmental injuries, you can classify these into industrial, sports-related, RTAs, assaults, agricultures, and even your routine activities. So basically, a study was conducted in India by Shukla et al., where they retrospectively analyzed 535 cases of ocular injury, and they found that the conventional classification, which was your BETS classification, was only able to classify 364 of them, And a lot of injuries which were classified as destructive injuries were not included in this, and that led to missing about 33% of the cases. So in this newer classification, all cases are divided into local or associated injuries. Local injuries are limited only to your eyeball and your ocular adnexa, whereas associated injuries will have systemic injuries. So they'll have head injuries, facial injuries, or polytrauma. These are further divided into mechanical and non-mechanical. Mechanical are further adnexal and global, whereas non-mechanical include your chemical, thermal, radiation, and electrical injuries. Adnexal injuries, further based on the structure involved, could be orbital, palpebral, lacrimal, or conjunctival. And global could be further structural or pathological. Structural would be limited to your anterior or posterior segment, whereas pathological could be closed globe, open globe, or destructive globe types. So what they found was that the most common closed globe injury was a contusion in 66% of the cases, followed by lamellar laceration in 17% of the cases. And the most common type of open globe injury was a rupture. Phthisis bulbi was the most common destructive globe injury, which was a class of injury which was not included in the older classification, followed by endophthalmitis. Another important thing to be discussed is the ocular trauma score. So this is again essential to prognosticate the patient. So initially the main score is dependent on the initial visual acuity, ranging from no PL to greater than 20/40. And then based on the associated injuries, you subtract from the score to prognosticate the patient. So globe rupture, endophthalmitis, perforating injury, retinal detachment, or the presence of an RAPD will lead to subtraction of a certain set of points and reduce the trauma score. Now, despite the reported benefits of the ocular trauma score, there are certain cases such as in younger children where this cannot adequately classify the patient because it is difficult to assess the presence or the severity of RAPD, and there is always the potential of development of amblyopia. So the predictive accuracy of the ocular trauma score becomes compromised in these cases. So that is why there is the mathematical model called the pediatric ocular trauma score, which is applicable in children less than 6 years. And it takes into account that you cannot merely rely on the visual acuity, because in children you would have the risk of amblyopia. So this calculates the trauma based on 2 times age plus zone, where zone 1 is basically injury limited to the limbus. Zone 2 will include the anterior part of the sclera, and zone 3 is a full thickness injury extending to the posterior part of the sclera. So in children, this is calculated based on 2 times age plus zone and subtraction of associated injuries such as globe rupture or endophthalmitis. So to sum up, classifying ocular injuries is especially important in order to be adequately able to triage your patient. And also the older classification, which is missing a lot of around 33% of your injuries which are destructive globe injuries, needs to be replaced so that we can have a more comprehensive system of classifying these patients. Another important point to remember is that these rules do not necessarily apply in children in whom the risk of amblyopia is always present, so they need to be managed in a different manner. Thank you so much for your kind attention.
Thank you, Dr. Saili. It was very nicely put, and classifications are boring, but they're necessary, right?
Yes.
Yeah, it helps prognosticate.
Yes.
So thank you for a great lecture. And next we have Dr.
So,
Chaya
you
Shinde.
can take the Smith, the next memento. So Dr. Sunil Morekar can give the memento. And in the meantime, you had Dr. Saili, you mentioned Dr. Feram Skoon's name. And he's coming here on March 18th, and we are doing a CME. It's a Tuesday, but we are all going for a tiger safari the week before and coming. So if you see, I'm starting an Ophthalmic Trauma Center in Chembur in his name. So he was arguing, I have done more than him. I said no. But he has done, he is the authority on ophthalmic trauma, and Dr. Robert Redag is also an authority in managing ophthalmic trauma. He also does cornea and cataract. So he does all the repair, and we had, both of us had Dr. Cesare Forlini as our friend, who was a pole-to-pole surgeon. So I think classification is not boring, madam, because we are part of.
Boring, but it's important.
No, no, no. It's
Half
not
of the
boring,
people
I'm
go
saying.
off to sleep.
No, no. I know my staff hate me. My optometrists hate me. I am great because I am the chief of retina center for all Agrawals. We have 215 hospitals. So we made a software. We are capturing daily. Every day there's one trauma patient will be there in one of the hospitals. And Sand Hospital has the maximum. And she's going to talk on firecracker injury. For your information, on behalf of Ophthalmological Society of India, our Kamala Sundaram Foundation is sponsoring the legal fees, and we are filing a PAL against cracker sale in India. So we want a restricted sale. I actually wanted a ban, but people will threaten me, but I don't care, like Sunil. But we are, even Usha Kim said, she made an against this Jallikattu in Tamil Nadu, and the present Chief Minister's brother threatened her. So I think we are not afraid of that, because we are seeing daily cracker injuries and face injuries and eye injuries, losing vision. And he says, if the injury is there and if you don't repair, you will sue. But who is going to sue the cracker? He is not suing the cracker people. You should sue first them. No, he should sue the people who are selling the cracker and who are buying it for birthday, for Christmas. What is the connection with Christmas? Or any festival they are doing, a wedding. I had a patient who had a rocket gone inside the 5-star hotel just before his marriage. He was hospitalized. He could not do a marriage also because he had a CSF leak, and if he would have done eye surgery, he would have died.
Second, because very important part here was, since you're calling this a CPD, the CPD aspect of it is CPD codes for insurance. So unless you have the classification, the CPD is not going to come.
Next we have excellent outside. So next we have Dr. Chaya Shinde, head of the Department of Ophthalmology, and we are working together from the time I came to Bombay in National Society for Prevention of Blindness, and plus she's now one day going to become a dean, and will do more for ophthalmology.
Okay, so good morning. My talk is management of ocular firecracker injuries and prognosis, a case series. It's a small case series. So next. Okay. Firecrackers are used for recreation and celebrations. Like in some countries they celebrate Independence Day. In some countries they celebrate Christmas. Most of the countries they celebrate New Year. And in our country, Diwali is the festival where firecrackers are used maximum. India has got many religions and many cultures are there. So previously, many years back, it was only Diwali. But nowadays we see anything and everything, birthday, wedding, engagement, and politicians, when the elections are there and they win, that time also there are loud firecrackers. So firecrackers, they lead to injuries in the body, they will lead to noise pollution, then they will cause auditory problems, so many, but these are not taken care of. As sir said, there should be some prevention on the use. Because these firecracker injuries can result in permanent vision loss and irreparable ocular damage. So we'll focus on that. We conducted this prospective study to evaluate the management and prognosis of ocular firecracker injuries in a tertiary care center. The purpose of the study is to assess the impact of the firecracker injury and to create awareness among general population. So the prospective single center hospital based case series of 5 patients in last year, and patients who required admission and surgical intervention. Many patients who come, we treat them on OPD, casualty basis or OPD basis, and they didn't require admission. So we recorded all the data in trauma pro forma, which included demographic details, mode of injury, type of injury, and ocular examination findings. Detailed general and ocular checkup was done, including best corrected visual acuity, slit lamp examination, fundus examination, and intraocular pressure. B-scan, ultrasonography, and CT scan or X-ray orbit was done where indicated. Patients who requiring primary laceration repair, it was done immediately. We have emergency OT, and all throughout the day and night we operate. It was followed by secondary surgeries after 4-5 days or a week as the inflammation subsided. For example, where intraocular foreign body was there, retinal detachment. These injuries were classified according to Bett's classification. So our patients, 5 patients were there, they required admissions, all were below 30 years. 4 males were there, 0 to 10 years, 1 male child, and the rest were 20 to 30. So age group is important. Most of them were in the younger age group because they would like to celebrate. They are older people, they will not go near the firecrackers, but young people, they want to celebrate, and 1 female patient. Now in this, patients who can be actively involved, they are only bursting the firecrackers, or bystanders are also there. Like that also we get the injury. So I know a doctor, my doctor friend, and that their son, so it was a new year, and he went to see the firecrackers, and that rocket or something, it went into his eye, and that boy, poor boy, he suffered. So being a bystander also is not good. So in this, scleral lacerations were 3, 1 corneal laceration and 1 was hyphema. Next. First patient, this was a scleral laceration, and CT scan showed intraocular foreign body. Later on, this patient needed Parthena vitrectomy, and intraocular foreign body removal was done in the second treatment. Next. So this patient, he had a lid tear, lid laceration, and you can see lid laceration and scleral laceration with uveal tissue prolapse. Now uveal tissue prolapse, when it is there, there also lies a threat of sympathetic ophthalmia later on. It may be immediately within few days, few weeks, or after years also. And it is here a post-op photo is also there after the suturing. When lid laceration is there, we have to keep in mind that alignment is there. So first suture you have to take at the lid margin. You will see that proper alignment is there, and it is sutured in 3 layers. Second patient, he presented after 48 hours. What happens when the patient is in some other place, it's not near the Sion Hospital, then they take local treatment from local doctors, or on their own they put some ointment, put the chemist, and afterwards when the pain increases, then they will come within 2 days or 3 days also. So this is a similar patient. We repaired, and later on we found out that he developed endophthalmitis. So we managed with vitrectomy. He needed vitrectomy, antibiotics, intravitreal antibiotics, vancomycin, ceftazidime, and also fortified antibiotic drops were given to this patient. This is a patient who developed endophthalmitis. Third patient, he had hyphema and corneal epithelial defect. So this patient needed anterior chamber wash. So we waited for a day, and when we think that the cornea is going to blood stain, then we proceeded with the anterior chamber wash. Now these patients, afterwards we found that there was macular edema also, and we managed with steroids and topical NSAIDs, non-steroidal anti-inflammatories. Fourth patient, he had scleral laceration, epithelial defect is there, limbal ischemia is also there, and in this patient we also find that soot material is there which deposits on the ocular surface. So that we have to remove very carefully. This patient needed phacoemulsification, PCL implantation later on. This patient had a scleral laceration. Now some patients, that scleral laceration, it is underneath the muscle. So we have to disinsert the muscle and then do the suturing. So what is important is, are there protective devices used during firecrackers? So nobody uses protective devices. So ideally, we can start telling them use a face shield. That should be advised. And awareness, more and more awareness programs are needed. It should be done under supervision. Like parents should supervise the children when they are bursting firecrackers. Bucket full of water should be kept nearby. They should not lean on the firecracker. What happens is when dead firecracker, means when they burst it and it does not burst. So the child, he goes near to see what has happened. Is it still live? And then suddenly it bursts. That explosion occurs. So that is bad. Then bottle rocket. What they do is they put the rocket in the bottle, and then the bottle also breaks and it flies very high. So these things, it is not supposed to be put like that. So these things should be told to people, and remember that it causes irreparable ocular damage many times. Even though we repair, surgery is good, but the result, the patient will not get the vision. These are some references, and once again I thank Dr. Natarajan and Dr. Karabi Madam for giving this opportunity.
Yes, Dr. Robert. In the meantime, Dr. Chaya, I can give the mic.
So thank you very much for a very interesting presentation. So we have also a lot of experience in Poland with treating victims of fireworks. First of all, we have a lot of fireworks from China, and there is no safety instruction in Polish language. Only Polish people try to just play with fireworks without any knowledge how to do it. Second thing is we influenced politicians, and now in many areas of Poland fireworks are forbidden. Only maybe New Year celebration, but it should be really official. So the percentage of accidents is lower and lower, but still even last time during New Year celebration I had to operate several children because they are observers nearby. So really awareness should be still built up and stimulated by us ophthalmologists. Thank you very much.
Thank you, Robert. And I think New Year Eve, Germany had a major cracker injury. And I think US also had this year, which is surprising, in spite of its ban. And
I would request Sunil to hand over
Sunil.
the certificate to Chaya. Thank you, Chaya, for the good talk.
Madam, have you published this? We should publish it. So I am collaborating with Dr. Robert because he is up to date in publications with his team. He's got a big team, but still he is a great leader. And I think we have also a lot of things pending. Dr. Smith is sitting next to Dr. Robert. He has got a lot of my surgeries with him. I told him to publish, but he's telling me, you better write. So we are fighting. So I think we want students to collaborate with Dr. Robert's residents so that we can publish together between Mumbai and Lublin.
I would request everyone to stick to their time of 6 minutes, and 2 minutes would be for discussion. So we invite comments during that time or any questions from the audience.
So who's maintaining the timer? Okay, so 6 minutes you will do it for me. So I'll start as an example because and then we want to listen to Dr. Robert Reda with his experience. He's the only one given 20 minutes each talk. So I'm giving this talk of late to many meetings all over the world. So the fine art of science of managing ophthalmic trauma passionately. So surprisingly, I'm doing trauma work for 42 years. That means the time I joined ophthalmology. And also, as a 10-year-old boy, I also put torch for my father to remove corneal foreign bodies, where we lived in the ophthalmic hospital quarters, where people were daily around 20-30 people will have iron particles coming. So the eye is protected, and if you see the evolution in the animals like frog and some animals, the eyes were in the front because they had to see far outside what regarding their enemies, but later it come into the eye with a bony orbit, but still we have the trauma happening. That's why, thanks to Professor Gangadhar Sundar, we changed the term from ocular trauma to ophthalmic trauma, because ocular means only the eyeball, and ophthalmic is the eye and the eyeball and the orbit. So there's some key features. Is the number one ocular emergency, and that's why we are all here. And so here we have a traumatic retinal detachment with explosive hemorrhage, who is a 76-year-old male. So you can see that this patient had he was a 76-year-old male who's actually father of a IS officer, who was the chief, at that time the principal secretary in government of Maharashtra. So you can see, actually I did a first surgery, and then explosive hemorrhage happened on the table. And then 2 weeks later I went in, and there was a heavy oil in the subretinal space. So I complete the basic excision, and then and then you can see the subretinal silicone oil. So it was a heavy oil, so it was sticking on the surface of the choroid. So I'm going into the retinal subretinal space and removing it, and using the retinal brush, and I saw a macular hole, so I decided not to use perfluorocarpet liquid. And generally you should not go through the macular hole, but with a fine tipped soft needle I went in through that, did a endodrainage and PFCL and oil exchange. So this was actually, the surgery has been put wrongly. So this was the first repair done, where I did a tagging the muscle, and I made sure that the intraocular pressure was high always. But in spite of that, I think my mistake was I shouldn't have put a belt buckle, which I like to do all the time, but I think probably during this time there was a hypotony, and because of the hypotony, explosive happened on the table. We don't know. But if you will be shortly seeing, when I was doing the vitrectomy, there was a bullous retinal detachment happening. I thought it was a suprachoroidal infusion, wrongly placed cannula, but the cannula was in place. By the time I realized it was, in spite of all the experience, I've done the maximum vitrectomy surgery for explosive hemorrhage, but still I didn't recognize the explosive was happening. So in spite of it happening, I make sure that I close the eye, I used oil, I used air to stop the bleeding, and then I removed the 240 band, and then because there was no use that time, and then did the second surgery. And you can see this was the 2 weeks later, the eye was like that, and then there was a fundus photograph missing. So patient got about 3/60 vision, but I had recurrent hemorrhage. So this is another eye with, yesterday Dr. Nikhil was telling you should show an eye with the pellet ocular trauma, where this is a forceps designed by Dr. Mahesh Shanmugam, Dr. Manish Bapai from Nasik, and myself, where it's a 4-pronged forceps. We can grasp the 6 minutes over. Okay. So using a separate incision from the 11 to 1 and remove the pellet. So like this, 1011 injuries we were tackled in Kashmir in the 2016 time. So we closed the scleral wound, and then also the conjunctiva, and proceed with the 3-port pars vitrectomy, where all the surgery were done in Kashmir, and I'm glad they had a good Zeiss microscope with a good Alcon vitrectomy system, no financial interest. But you have to do a meticulous surgery. It's a back-breaking surgery. So I recommend all ophthalmic trauma surgeons to have the back strong. That means you should do good exercise. You should have good oxygen for yourself. That means you have to run, you have to walk, whatever. The reason is you need stamina. You can see the external, the exit wound of the pellet, because it is particular. After that, one pellet had gone through into the orbit. You can see it is close to the optic disc. So I do a laser around it as though it is like a coloboma choroid, and then do a fluid air exchange and let the eye fake it, and after that 3 months later we can put a secondary IOL, either a glued IOL or a scleral fixated IOL, or even an iris claw lens posteriorly. But I think since the macula and disc are all right, and if the central cornea is fine, many patients got 6/9. But in our analysis, we had 80% of the patients had only counting finger close to face. And somebody may ask, why are you spending? The New York Times reporter asked me, what is the point in doing surgery from morning to night and the patient is getting counting finger. I told them that if the fellow eye, these people are 15 years to 21 years old, and if the fellow eye had a 6'6", and then at the age of 80 he may have an injury, and that time that fellow eye will work as a stepney. That means it will be a spare eye, he will be able to see his own plate, he can go to the toilet, and that fellow will bless us. And that's why the role of vitreoretinal surgeon is to not only to get the anatomical, but also the 6 minutes over. Okay. So this is the first surgery patient where a macular hole was there. So I did a laser around macular hole and also around the break, and the retina was attached. And this is the one which I want to show you. The patient was referred 20 days later, entire corneal abscess. Fortunately, there was no panophthalmitis. Sunil said, if you have an endophthalmitis going into panophthalmitis, you have to eviscerate. Otherwise, the patient will go in septicemia and can die also. So I think we cannot take it light. That's why we are recommending when an injury happens, please repair the eye immediately. So Aditya Jyot was always open 24/7, and I myself have done my own trauma in the midnight. Thanks to Dr. Kerry when she joined me in '89. We were doing surgeries in night 1 o'clock and 2 o'clock and waiting till 3, 4. So you can see this. I planned for a temporary corrective process, but I could not put. The whole eye was necrotic. There was a plastic exudative material on the iris. You can see the iris is swollen. And so I did a meticulous dissection. My anesthetist was asking, are you doing a micro evisceration? Maybe, because the only other way is to eviscerate the eye, but you don't have a chance. But I did whatever exudative material was seen in open sky. I put a flaring gas ring to prevent expulsive, because in an open sky vitrectomy there is the risk of expulsive hemorrhage happening. If expulsive hemorrhage, it's not the end of the eye, but I think it's not the end of the case also. You can close the eye, and actually they use the thumb to close the eye because there's no, you can't have the time to close the, what do you call the wound that time. So the whole thing will come out if you don't close. And I have seen in '85 when I was assisting Dr. Majid Kulkarni, that when she was doing a parental everything came out. And we didn't know what to do because that time we were not ready to manage the expulsive hemorrhage. Now we know we can manage expulsive hemorrhage. The only thing is to close the wound. You can see a preserved cornea with net, and a corneal surgeon, Dr. Kavita Rao, did that. And that time she told, you are wasting a cornea. I said, no, you are saving an eye. This cornea can become opaque, but we can do if the eye survives, we can do a optical graft later, and the patient can see. This patient probably got close to finger, the pointing finger close to face with a grayish reflex, and I said we can do another surgery to clear the back, but the patient was not ready. So this was the no PL, and from there he got counting finger close to face. So this again, I think this is a phakic eye. So where I am doing a 23 case. So we had all sorts of injuries. So here again I want to show that even in a phakic eye, when the young people don't do a lensectomy because the natural lens is better than the intraocular lens. And I know cataract surgeons like Dr. Robert and Smith are here. They like to do, but I think preserving the natural eye, the natural lens is better, even in a diabetic eye or a trauma eye. You can see the pellet had hit near the center of the eye and fallen down, and you can see the pellet within the vitreous hemorrhage, which I made a special technique where I don't remove the pellet from do the total vitrectomy. I make sure I identify the pellet within the vitreous hemorrhage, grasp it with the forceps and then remove it so that it doesn't roll and fall on the retina. Because if you're going and touching with the forceps on the retina, experienced hand, iatrogenic break will not happen. But why allow anything to touch the retina? So you do the basic excision, clear the eye. So there I did surgery from morning 7 till night 11, and then I had a cervical spondylosis after that, because in spite of all that, because there was no handle, I got a Maharaja chair in my operating room, so we have the shoulder weight on the elbow and the elbow right on the wrist, which I think I should show you tomorrow in my OT. So I call it Maharaja chair. Maharaja means king. So here you see the forceps I'm using, grafting and removing through the 11:1 separate incision. So the idea is not only to remove the foreign body, but you have to make sure do anatomical success, and then hope the vision will improve. So same as close the wound and then do it. So this is how the pellet is removed. So my philosophy is eyes with no perception of light, vision should also undergo primary repair even when the anatomical success is estimated to be less than 1%. And I'm sure a lot of patients we have saved. Many we have saved the eyes, but if you don't remove the eye, I think the psychology of recently it happened in Bombay that there was an eye injured and the surgeon called me and said, "Doctor, you can't do anything, I'm going to remove the eye." So I told the patient, get medical discharge against medical advice. They came and Dr. Smith was there, he went and saw the patient in the hospital. I don't want to name the surgeon and the hospital, but I want to convey that because people are watching all over the world in live YouTube and docplexes, that don't enucleate primary enucleation or evisceration. I think we should repair the eye and then restore the anatomical success first and then hope for the functional success. Thank you.
Thank you, Dr. Natarajan. That was really amalgamation of a lot of gruesome cases treated with a lot of passion and care. But I am so glad that you covered traumatic end of that, because my only grouse about my program was that nobody was speaking on traumatic end of. Okay, I have a question for you. How would you manage a patient who has a shrapnel injury from bomb blast, where shrapnels are found everywhere, on the face, on the orbit, inside, outside the eye, inside the eye? How would you manage such a case?
So usually pellets also had similar thing. Only thing, pellets are made of lead. That the controversy was there that the lead will produce some problem in the lead poisoning in the that's why the Kashmir, some activists were telling, but no point in removing in the skin. So if there is multiple all over the face, it's made of what, iron, sharpness, maybe iron. So the problem will be for siderosis happening all over. So I don't know about the skin part, we have to check with the plastic surgeon. But in the eye, definitely we remove it. And if it is in the orbit, we don't do it. Even if it is iron, we don't do anything in the orbit. I hope you will agree with me as a orbital surgeon. But if it is within the eye or in the even the sclera, we should remove, because we have seen patients with the cirrhosis bulbi happening 11 years later also. And even after 11 years, if the patient has 6/6 vision, and I am reluctant to operate, but I remember operating a patient, but went into multiple problems. And I think because once you do a 11-year-old injury patient, even removing the foreign body is a problem. And by the time you produce retinal tear or retinal detachment, and they are highly prone for PVR. But still we recommend, because one day they may lose the eye, but we have to document it so well so that the patient doesn't sue you. So I think we can combine some questions with Dr. Robert. So I'm happy to, next is Robert, and I want to introduce Dr. Robert Reda. I know him for several years, and I have seen him for the last one and a half decades, and he's excellent from pole-to-pole surgeon from cornea to back of the eye, and he runs an excellent institute. He's not only an ophthalmologist, but he's also an administrator, where he's the rector of the Lublin University, and he's a respected ophthalmologist in the entire Lublin and in Poland, and he works in Warsaw too. And I think he's a great host, and he would love our Indian ophthalmologists to go for his meetings. And thanks to him and the city of Lublin, they gave me a medal for the contribution for teaching Polish ophthalmologists. And one more thing I learned from him, a lot of Indian students are doing their MBBS in Lublin, and once he invited me to meet them, and there is one group of, I think, company or whatever they call, they have every year some, I think about 200, 300 students come, and there are about 1,500 medical students at a time in Poland. To you, Robert.
Dr. Natarajan, please, Chaya will hand you over the certificate and memento. Welcome, Dr. Reda. It would be nice to hear from you.
Professor Robert Reddick, he's an ophthalmologist of great repute. We all know about him, and Dr. Natarajan has already introduced him. What is more important that he's one person who's involved with the ISASO. ISASO is a very comprehensive program for education of the ophthalmologist. And I think people who are here and are listening to it can contact him and try to do their researches.
No. So yesterday, Dr. Robert was impressed with the place. I took her to Sion Medical College, to Dharavi, our foundation clinic, as well as the new center which we are opening in the evening by Mr. Bajaj. And he now promised we will do better than this also in Mumbai. So between Poland, Mumbai and Egypt, we have Dr. Ashraf. So we will do start World Ophthalmology Surgery Center for training. Dr. Robert, all yours.
Okay.
So the world is listening to you, Robert.
Ladies and gentlemen, it's really my great honor.
Microphone.
Yes, but I must wait.
So Dr. Robert has invited me several times to his operation theatre, and he's got a sophisticated operation theatre and does live surgery every year. And I go in January, February when the entire Poland is frozen, and the outside of Poland is, outside of Lublin is sometimes goes to -20.
Yes. So again, I'm really grateful for this kind invitation to Kamala Sundaram Foundation, to Professor Natarajan, and to organizing committee. This is my great honor to be a friend and to collaborate with Professor Natarajan. I think about 15 years already. We met many times, and also I would like to thank very much to Professor Natarajan for teaching us and me personally this philosophy. He presented in his presentation. Don't give up, continue treatment, and also he was the first showing me really severe cases, and that it is possible to help the patient to use several techniques. Also, he was one of the pioneers of mini-invasive techniques in vitrectomy. So we implemented all of these ideas, methods in Lublin many years ago. And you can imagine myself working in Europe in, let's say, steady conditions, quiet conditions, and suddenly a war began. Just my center is 200 kilometers from Ukrainian border, and I realized that now we have to pass an exam, because real life and the dramatic situation came to us, not so far from Poland, and not so far from, I mean, in a neighboring country, not so far from my center. And then together with my colleagues from Ukraine, so these are co-authors of my talk, Dr. Olga Denishuk from Kiev, who is my fellow in ocular trauma surgery, Dr. Marina Gupanova from Kharkiv, and I have privilege and honor to know Dr. Jorg Corona from US, from Dallas, who is organizing charity missions, visiting Kiev and Ukraine and helping people. He's an oculoplastic surgeon. So this talk will be presenting you as like systemic approach to this tragic situation. So with doctors who are working inside, so in Ukraine, and with me helping them from neighboring country. So this is really a dramatic situation and a huge change in organization. You can see a lack of energy, water supply on this map. It has started in 2022. so on 24th of February, and the life condition and also security, everything has changed. So even yesterday morning, I shared with Professor Natarajan video. There was huge attack in Kiev. The metro station was damaged. Also, there was no water supply. So my colleagues sent me this video. So really, this is a tragic situation. So it looks like this when you wake up in the morning. So Professor Natarajan showed me today a wonderful sunset, but my colleagues unfortunately observed such dramatic moments every day, and the attacks are normally during the night or early in the morning. So this is Kiev, and also this is another city, Zaporozhye. In every city of Ukraine you have really such dramatic situation. And what we are doing in Poland, this is my patient from Ukraine, sent by another colleague, Dr. Natalia Price, with camera. They take photographs, sending us results to Lublin, and we consult the patients, we advise what to do. This system is very popular in hand camera you can use for diagnostics. Also, it has it is independent from electricity supply, so they can use it even if there is a blackout. And this is Professor Andrei Zimenkowski from Lviv, who is also working with us. And then, if it is necessary, you can see they send such patients to Lublin. So this is a family, so mother and two twins are blind. Then we have to operate at my department. This is first surgery. I would like, as an example, I would like to show you a case of the mother of these two twin boys and two twin brothers. And this is my surgery I performed immediately sequential bilateral cataract surgery 10 days after bomb explosion. And the lady had post-traumatic cataract on both eyes. So you see, I tried to implant IOL very quickly because I suspected a presence of intraocular foreign body, despite CT scan was negative. And behind the iris I found a piece of glass. Also now IOL protects this the posterior capsule, so I could remove it. And finally I observe the patient already almost 2 years. She has full vision. This is fellow eye of this patient. So the same session, so I continued with the fellow eye, but fortunately here there was no intraocular foreign body. So as Professor Natarajan mentioned, I am both cataract and VR surgeon. In Europe we do quite many combined procedures, and personally I also like very much cataract surgery, so I perform a lot of normally more than, I don't know, but for Polish conditions I perform around 250 cataract surgeries a month. So it's for Poland it's quite a lot. Of course then I perform like 60 vitrectomies a month. And so you see, fellow eye, I could implant IOL. during this procedure as well.
Good afternoon.
And this is the interview about this situation.
Are doing pretty well. Mrs. Olena and her children already have undergone a series of operations. At the moment they are discharged from the hospital and they come to us for a checkup. Mom is feeling very well. She has basically full vision, so she can take care of her children now. She's totally independent. She was operated because of bilateral post-traumatic cataract, but at the moment we are totally happy that the healing process is finished and she has full vision. One of the brothers, Nazar, unfortunately lost his eye during this bomb attack, but with the other eye he can see very well. Second brother has also undergone several surgeries. One eye needs still some treatment. The fellow eye is in a very good condition, so two brothers are playing, running around, they are happy, so we can see also that the help of psychologists also is very important, so now they look very happy, they are happy family. So we are planning still kind of follow-up of the family because they stayed in Lublin, so it will be easy.
It is joyous. It is so joyous to hear that they are doing so well because, like I say, I met them a few weeks ago and they've just been recovering. So it is wonderful to hear that they're already discharged. They were originally...
Of course, this is a long interview, also describing how we act, but I will try to show you other cases. So this is the mom after, like, I don't know, maybe 1 year after surgery, but I even examined her recently, so more than 2 years after surgery, with the two twin brothers. We already published this case, also describing the surgical technique. And this is another patient. So as you can see, quite often we have a TV documenting our results of our surgeries because of this war situation. So it is another stressful situation for doctors because they interview patients, they present all these aspects, but okay, this is the war, and we try also to share experience and recommending what to do, how to act. This is the case. So this is a giant intraocular foreign body with a corneal wound. So during the surgery, what is also the problem? But sometimes these patients come and leave the center, and we don't know what if they will come back. So in this case, I decided to implant IOL. You can see we know that there is a giant metallic foreign body in the eye, but it was hanging like chandelier, stuck in the lens material, and didn't hit macula. So the trick is to avoid falling down such sharp metallic intraocular foreign body on the retina. So a combination of let's say cataract surgery together with anterior vitrectomy. We recommend to use anterior vitrectomy really very early. Don't aspirate vitreous. Just when you have prolapse of vitreous, you should cut immediately vitreous, and at the end we decided to implant IOL to the sulcus with optical capture technique, obtaining quite good result. So the problem was with the cornea, and we work on the system, how to develop a cross-border telemedicine system based on the example of ophthalmological examinations in these conflict conditions in the Ukraine. So we study how to prevent, how to act very quickly. So we analyzed 500 patients. Our Ukrainian colleagues sent us photographs using these portable cameras, and we analyze data, publishing our data. So two papers are submitted, so I am really open for collaboration also in this area. We have quite experienced group. And you can see we also invite our colleagues from Ukraine to Lublin for training. So this is Dr. Olga Denisiuk, also learning vitrectomy, and recently in December a big group of Ukrainian doctors visited me in Lublin, so we organized like surgery and also access to many simulators to give them possibility to learn vitrectomy. And so my colleague Olga sent me some slides showing how they work nowadays. So you can see they have generators, they have special light sources enabling them to operate even when there is no power and electricity supply. They are now really experienced how to do it, how to perform surgery in such conditions, using different also technology, dealing with traumatic cataract and ocular trauma. And I must tell that our colleagues now are really independent, sending rarely patients with big problems, especially corneal problems. So they are presenting techniques. We will come back later to all these subjects today. This is another colleague, Dr. Marina Gupanova from Kharkiv. She's oculoplastic surgeon, really experienced expert, and now dealing with such cases, you know, after really severe ocular, not only ocular trauma, of course, combined nature of damage of the head, face, including the eyes. Also treating soldiers and civilians, civil patients due to different kind of war-related trauma. And finally, I would like to show you also this material. So how Dr. Jorge Corona helps Ukrainian doctors.
Ready for a great first day.
So I know that Dr. Jorge Corona and the team from US is planning next missions. He comes quite often to Ukraine. Now I would like to show you also how they organize these trips, bringing new technology to Ukraine.
As the war in Ukraine stretches on, inside a Kyiv hospital, Dallas-based surgeon Dr. Jorge Corona is operating on a Ukrainian soldier injured by Russian troops. He lost both his eyes in the battle. Dr. Corona used custom-designed 3D printed facial surgical implants created and donated by Dallas-based MedCAD to recreate the soldier's face.
we're giving them back a little bit of their humanity that they have lost.
The medical mission was sponsored by Dallas's Leap Global Missions. Dr. Corona is part of the so-called Dallas Medical Miracle Team. We talked to Dr. Corona, who just got back from Ukraine at MedCAD's printing facility in Plano. CEO and President Nancy Hairston showed him the $1 million 3D printing machines that make the surgeries possible.
And then here is the bed, and the titanium is brushed across, and a laser beam hardens each layer.
While in Kyiv, Corona met a U.S. citizen nicknamed Gandalf, who came to Ukraine to join the army to fight Russian forces. He too was injured on the front lines.
Because you are one of the heroes.
Corona did not operate Gandalf, but followed up with the Ukrainian surgeon who handled the reconstruction of his mandibles using the surgical plan and implant provided by MedCAD. He's doing well. Dr. Corona says doing humanitarian work fills his heart. He considers it a blessing to be trusted by these injured soldiers disfigured after battling to limit Russian incursions.
I find that I am not going to carry weapons. I'm not a soldier, but in my area of expertise as a doctor, I'm able to deliver care to these patients, hope to the country.
So as you can see, such situations like ocular trauma can be really complex. And also what is important and what I learned from Professor Natarajan, really time is really important, timing of the surgery. So refer patients as soon as possible. Also inform patient that he should visit the doctor immediately after ocular trauma. Also telemedicine and the new systems of remote diagnostics are really useful, really crucial nowadays, not only in ocular trauma. I will present you also our experience with diabetic retinopathy, but we have new challenges, but we also have solutions. Thank you very much for your attention.
Thank you, Dr. Edak. That was an excellent presentation, and it was very sort of soul-searching to see all the scenes that you showed us of the war. It really touched us somewhere deep down. Thank you so much for bringing this to us. And I would request Dr. Natarajan to hand over the memento to Dr. Edak.
It's a pleasure.
I would now request Dr. Hitesh Sharma to come on the dais to present his talk on a sinister problem, sympathetic ophthalmia.
Welcome, Purva. I think teachers are here, students are not here. No? So any comment for Dr. Robert's talk by the time he's getting ready, so because there's the YouTube people are watching.
Yeah, that's what I was discussing with Mayur. That it is so difficult to give them vision back, whatever we do as surgeons. So is it worth, the wars are worth, why the wars are there? That was the question in my mind all the time. Why the wars are there? War is there. Who decides the war? Is it necessary to do? Why this catastrophe? It's not in our hands.
It started in Mahabharata, madam.
Mahabharata. But hats off to you, sir. You have seen the surgeries and you are trying wonderful. You are trying your best to give back the vision to these patients. I saw this family, 2 small children and the mother, and all got ocular trauma. One child has lost the vision. It's so sad. But also in such situation, we see the ray of hope that many countries, other countries, they come forward, and the collaboration which you are demonstrating with other countries to help the people who are affected by the war. So there also we have to learn. Keep helping others and keep doing. That's a message.
Yes, that's why we want peace all over, and there is a...
I have a question.
Yes, sir. Yes, doctor.
Dr. Robert, good morning. You have mentioned about the telemedicine in the war between Ukraine and Poland, what you said. So how do you manage the trauma cases remotely through telemedicine?
So first of all, we try to advise what to do, and it has changed. Before, just after when the war began, patients were sent to us. So a lot of patients were sent to us, and we had to tell, okay, this patient we can help, this patient you can do yourself. So first pre-selection. Then, of course, we want to try to find, to build a system of remote, let's say, consulting with patients, as well as I remember one patient from, he was taken to Italy, but in the meantime they sent me results and I told, okay, I can operate on him. So he took another flight from Italy to Poland, and we performed surgery. So it is really now a crucial technique in organization of such, let's say, system and decision making.
How long you are doing this?
So we started diabetic retinopathy before the, so it was maybe 2020, but it speed up, everything speed up during last 2 years.
Yeah, we see a lot of future in teleophthalmology and ocular trauma. So in our country also, many times we lose eyes because they are not properly guided, properly counseled, what I will show in my talk also. So probably teleophthalmology, taking the images from the trauma cases, can be transferred to the base hospital for immediate diagnosis and counseling to the patient and the doctor even. So these are the advantage of teleophthalmology.
I completely agree, yes.
Thank you.
This is the
Thank
future.
you, sir. Thank you. Thank you.
You have to do the collaboration.
Yeah.
TOSI
Yeah. So I am the teleophthalmic secretary of the Teleophthalmic Society of India, and Dr. Natarajan, our president of Teleophthalmic Society of India. We'd like to collaborate with you so that maybe in the future, in coming years, we work together.
With a pleasure.
Thank you. Thank you. Thank you.
Hitesh, all yours. Now what happened? It's working, no?
Slides are not changing.
Oh.
Okay. Yes. Good morning all, and I would like to thank Natarajan sir and Karobi madam for giving me this opportunity after this excellent talk by Professor Robert and his great work in Ukraine. I hope my topic is little interesting. So me and Dr. Mayur Morekar sir, who is my senior and very good friend of mine, we both practice uveitis, ocular inflammation. So what better topic in a trauma CME than of sympathetic ophthalmia? So by definition, sympathetic ophthalmia is a bilateral diffuse granulomatous panuveitis following an accidental or surgical trauma injury to one eye. The traumatized eye is the exciting eye and the non-injured eye is the sympathizing eye. So it is one of the most oldest clinically defined clinical entity. So it has been described by various veterinary surgeons also. So it was William Mackenzie who used the term sympathetic ophthalmia, and Pritchard was the first who practiced excision as a therapeutic measure. Dallin described the nodules in the inner surface of the choroid, and Fuchs established a distinctive clinical entity. And Elsnick was the first to postulate the role of autoimmunity in the pathogenesis. So usually onset, it can happen anytime between 5 days to even as late as 66 years. 80% of the cases occur within less than 3 months and 90% within first year. But the most dangerous time is the 4th to 8th week post-trauma. So it is usually has a bimodal peak, usually in young adults, and 6th decade of life. So usually trauma was the most common precipitating event. Now ocular surgeries, especially VR surgery, is now considered as the major risk factor. So sympathetic ophthalmia can occur after vitrectomy, retinal detachment, repair, various procedures. It can occur even following non-perforating procedures like laser, cryotherapy, cyclotherapy. So various pathogenesis have been described, but the exact etiology is still unknown. So there is a genetic predisposition, HLA is also involved. So genetic predisposition mainly HLA-A11 and HLA-DR4. So major histocompatibility factors are there. So there are susceptible patients who can present with sympathetic ophthalmia post-injury or any surgery. So as we know that our ocular tissues are have a distinctive immune privilege and ACID. So infectious etiology has also been postulated. So Rao et al. Postulated that retinal S antigen was found to be present in rabbits, but no such antigen was detected in patients of sympathetic ophthalmia. View and associates said that RP was played a critical role in the disease mechanism. So immunohistochemistry, there is a predominant lymphocytic response. Histopathology, similar in histological features similar in both the exciting and the sympathizing eye. There is diffuse granulomatous non-necrotizing inflammatory reaction. So choriocapillaries and retina are classically not involved. So Dallin-Fuchs nodules have been described, which are whitish yellowish lesions at the level of the choroid in the mid-periphery or the peripheral fundus. Histopathologically, these lesions are Dallin-Fuchs nodules, which are collection of lymphocytes, histiocytes, and depigmented RP cells. So seen in 1/3 of the patients, but not pathognomic. So coming to clinical features, symptoms, mild visual disturbances, there would be history of any trauma or injury. So most commonly patients would complain of near vision compromise, which is a very common MCQ during our entrance exams. So pain, redness, significant visual loss depending upon the severity of the injury or the inflammation. So clinical features, typically as I said, bilateral or granulomatous inflammation, and there would be retrolental cells, which are the first sign of the inflammation, and severe panuveitis like picture is there. IOP can be variable. So posterior segment, there would be mild to severe vitritis, retinal vasculitis, choroidal lesions, choroiditis, and papillitis, and in late chronic cases there would be a sunset glow-like fundus. So posterior pole and mid equatorial lesions, as we have white choroidal lesions which correspond to the Dallin-Fuchs nodules seen on histopathological examination. So differential diagnosis, all the granulomatous inflammations can be considered. VKH closely mimics sympathetic ophthalmia, and if there is no proper history of injury or there is no proper history of any surgery, sarcoidosis and tuberculosis has to be ruled out. And we do rule out HIV and syphilis in all these cases also. So there is a very overlapping features in sympathetic ophthalmia and VKH. So again, these could be very rare differential diagnosis. Sometimes there can be coexisting CSCR, so we have to rule out that also. So diagnostic workup, definitely we require some tests, mainly imaging. So fundus fluorescent angiography, B scan, OCT. So this is after IVMP. So this is after treatment with IVMP, and that is intravenous methylprednisolone and immunosuppressants. So management, prompt wound closure, enucleation of the injured eye less than 2 weeks is query like preventive. If wound closure is not performed within 2 weeks, enucleation should be considered if the injured eye is blind or painful. So this is a little controversial now. So once you diagnose sympathetic ophthalmia, we usually start with 1 gram per day of intravenous methylprednisolone for 3 days, followed by oral steroids and immunosuppressants. So in refractory cases, we also do use biologics a lot. So complications, there can be glaucoma, cataracts, maculopathy, and various other things. So cataract surgery in sympathetic ophthalmia, my teachers from Shankar Nethralaya have published this very large series of patients in which they have successfully operated cases of sympathetic ophthalmia. So prevention is better than cure, so as we all know. So prognosis, better healthcare facilities, aggressive management. At times it is quite aggressive. We have to keep on monitoring patients and hike up steroids and start immunosuppressants and biologics. And we should always explain the patient well, counsel well, explain the relapsing nature of the disease and also the complications. So take home message, thorough history and clinical examination, high degree of suspicion, early diagnosis and appropriate aggressive treatment, and good counseling and documentation. So I would like to thank my teachers from RIVHU and Shankar Nethralaya. Thank you.
Thank you, Hitesh. Can I request Dr. Chaya Madam to give the memento? In the meantime, I want to say that the primary enucleation evisceration should be avoided, and I recommend every time when you do the wound repair, make sure that none of the UL tissue or the iris tissue is involved in the wound. So I think wound toileting is very important, and I think prevention is important. So I recommend in my practice for the last 20 years, we do a video consent for every trauma patient. And every trauma patient is mentioned about sympathetic ophthalmia, and if it happens, and we also tell them to do, there is a need for evisceration or enucleation, but I think so far I have not done. So I think we have to explain to the patient, because in Australia, again, there was a patient who sued the hospital for not treating the sympathetic ophthalmia. Thanks. You want to say?
Hitesh, I request you to take the memento and certificate from her. I would like to call Dr. Mayur Morekar to the dais.
Mayur will be speaking on a very interesting aspect of counseling, that is doctor-patient family triangle, complex dynamic interactions in sympathetic ophthalmia post-surgery. So his is a continuation of what Hitesh has started off, and he's going to show us some cases and talk about this triangle.
So always have started all my presentations with acknowledgements to the teachers, and yeah, so that's me. I work as an associate professor of ophthalmology at Bombay Hospital Institute of Medical Sciences, Mumbai. And the topic for today is a doctor-patient family triangle and what dynamic interactions can happen in sympathetic ophthalmia, especially when it happens because of iatrogenic trauma, that is post-surgery. These are the points of the presentation, and we start off with a case synopsis. This is just one case that I'll present, and we just go over this case. This is a patient who first presented to us in October 2021, a 51-year-old lady who had a sympathetic ophthalmia post an anti-IOP surgery which was done left eye. She came to us with a best corrected visual acuity of PL and PR accurate in the right eye and an inaccurate PR in the left eye. And this is how the picture looked like. You can see that PI in the right eye. So she was on treatment for glaucoma. The left eye, you can see that cryosurgery had been done. Now, this is the fundus picture of the right eye. You can see that there is a disc edema. There is an inferior bullous retinal detachment. The veins are dilated and tortuous. And this is the patient the same patient 8 months after treatment with azathioprine. We started the patient on intravenous methylprednisolone immediately and put him on to immunomodulation with azathioprine, and this is one point that we would like to make. We all don't use azathioprine so much in the past, but nowadays these drugs are available and they make the prognosis better. In fact, one of the oldest patients of sympathetic ophthalmia is Louis Braille, who at the age of 3, while working at the workshop with his father, had injured the right eye and then ultimately became blind because he developed sympathetic ophthalmia in the left eye. 22 months on azathioprine, and you can see that the B scan on the left is normal. UBM, that was a cataract. We did a cataract surgery and we were able to achieve a vision of 20/200 N6 close to face. This is at the last follow-up of the patient in November 2024. But this brings us to this point of the presentation, that in a patient like that, who are the major human stakeholders? Obviously, the first is the referring ophthalmologist, because this is post-surgery. Stakes are involved there, the patient of course, the current treating ophthalmologist, and the relatives, the sons and the other relatives. I put them in this order because as a second treating ophthalmologist, you will first come in contact with the referring ophthalmologist when he'll pick up the phone and call you. It is only after that you are going to see the patient. This concept of doctor-patient family triangle, I am sure all of us are somewhere deep down aware of it, and the first time we wrote about this was in 2022 in the official magazine of KEM Hospital. And the next few slides are about this triangle. And all doctors should understand that there are subtle dynamics of an inevitable triangular relationship during each encounter with the patient, and to achieve desirable wholes of holistic care, we should be aware of this triangle, and we should make efforts to address issues over there. Originally, the concept of triangulation was described within families, and often this concept is referred to in dysfunctional patterns, that is negative patterns, but the same concept can be very well extrapolated to therapeutic encounters between doctors and patients with their accompanying families. In fact, there is a book published, it's called Family Therapy and Family Medicine, and it points out to the illusion of a dyad in the doctor-patient encounter. The illusion is that we feel we are dealing only with the patient, but in fact we are not dealing with the patient. We are dealing with the relatives as well. And this book refers to the relative as the ghost in the room. In the consulting room, there is a relative who's sitting there who is constantly judging you. And dysfunctional patterns which can be seen are, that's the triangle, the doctor, patient and the family. And perhaps the first dysfunctional pattern that can happen is the permanent perfect parent. The permanent perfect parent pattern is when the doctor takes over the role of being the perfect parent. We may all like to bask in the glory of such a role, but we should understand that the permanent perfect parent doctor is held responsible not only for the success, but also for the failures of all subsequent events that will concern the patient. These are the dyadic enmeshments. We should try to avoid these. You see there are three scenarios over there. The first in which the doctor gets excluded, the second in which the patient himself gets excluded, and the third in which the family gets excluded. If the doctor gets excluded, one example that happens is when after the consultation, the patient and the family get together and they decide that probably the treatment that the doctor has suggested is inappropriate. This often happens to us when we talk of immunosuppression. They feel that he's talking of suppressing the immune system. They get together and they keep away the doctor and the treatment of the doctor. The patient get excluded. I have put this example over here. Many times we are all as ophthalmologists encounter children who are made to incorrectly feel responsible and castigated for their refractive errors. It is when the family, the parents try to coalesce with the doctor and try to put the blame on the child. And family getting excluded, this is the most common scenario. We should not relegate family members to the thankless role of only accompanying the patient to visit the doctors. In fact, that is when they become the ghosts in the room. And the ghosts in the room are the most dangerous because they are going to start talking after the consultation is over, and they are going to then influence the patient against you most of the time when you have not addressed to them. Illicit correlations are taking these dyads ahead to the extreme. And of course, the first one is if the doctor gets excluded, that's a source of potential litigation. If the patient gets excluded, then that's a problem, obviously, because the patient is a stakeholder. And if the family gets excluded, then there will be a repressed hostility towards the doctor. So coming to the conclusion, the ideal therapeutic alliance is a positive triangle in which all members support and guide the others, and in which resources of all members are available to all. Successful relationships are based on trust existing along all sides of the triangle. And the physician and the patient should mobilize family resources. In fact, it's up to the physician to mobilize these resources for the patient. In the case that I had presented, the relative was a lawyer and he was a lawyer in the High Court. So I had to address his issues more than the doctor's issues every time. And ghosts can be good or bad, but because I have mentioned ghosts, it is up to me to invoke the person who takes care of all ghosts. Thank you.
Thank you, Mayur. That was an excellent talk. I would request Preeti to please hand over the memento to Mayur. Any questions for Dr. Mayur?
This ghost concept was really, I liked it. We must remember it. Because many times the surgical decision and even the treatment decision
depends on the ghost.
Depends on the ghost, and the doctor shopping also depends on the ghost.
We now invite Dr. Nageshwar Rao Subudhi to come on the dais, and he's going to present his talk on role of teleophthalmology in ocular trauma. Welcome to Mumbai, Dr. Subudhi.
Good morning, thank you.
Thank you for coming all the way here to be part of our meeting.
Thank you so much. No, but I can take it here.
You can take it here for your reference, for audience you want to.
Oh, you to change it. Oh, I see. Good morning, everybody. As Dr. Karabi said, I came all the way from Bhubaneswar to give this talk on teleophthalmology. Really, I'm so much impressed by Dr. Roberts about his talk on telemedicine, connecting people on one side of the border to the patient's other side of the border. Thank you. So I thank Dr. Natarajan giving the opportunity to talk to me on this favorite topic of teleophthalmology. So these are some of the injuries we come across in our day-to-day practice. but usually they report to us very late. If you go to the epidemiology of ocular trauma, 450 million people experience ocular trauma annually, and 19 million people suffer from blindness in one eye, and 2.3 million people have reduced vision in both eyes. So how teleophthalmology can help in reducing this blindness? That is our aim here. So blindness is a major trauma which affects an individual not only physically but also emotionally. It has become a global problem. And blindness from ocular trauma is 9 per 1 lakh in the developed countries and 75 per 1 lakh in developing countries. And moreover, the most important fact is that 80% of the people in our country, they live in rural areas and hilly areas. So these are you can see the pictures. So they do not get proper treatment, advice of their eyes because of non-available ophthalmologists, also infrastructures in these rural areas. So early detection, timely management and adherence to the treatment are crucial for preventing visual loss in ocular trauma. So when considering the importance of early intervention, these cases contribute significantly to the global burden of blindness. So one example I would like to say that is a case of a 2-year-old child while playing suddenly was injured with a bird pick by the car. And while playing with the hand in a remote village, it is a remote village, and he presented to us after 5 days after the injury. When we saw, the parent thought it is a very trivial injury, but when we saw that it is a lid edema, conjunctival congestion, perforated corneal injury, and there is a vitritis. So we advised a corneal repair, PPB, and intraocular antibiotics under GA. No doubt we started immediate treatment, but in spite of all our best efforts, the child could not get good vision. So timely detection, awareness, and proper counseling probably would have saved the child from having blindness in one eye. So early detection and intervention, early diagnosis and management of eye conditions such as ocular trauma, remote screening, and virtual consultations would save vision in many cases, as Dr. Roberts said already. So they also require regular monitoring per follow-up of these patients. So role of teleophthalmology in ocular trauma is very important nowadays. The use of telecommunication technology to provide eye care services remotely, including the diagnosis and management of ocular conditions in a remote way. So teleophthalmology, the goal of teleophthalmology is to decrease the global burden of vision loss, vision-threatening eye disease, mostly diabetic retinopathy, glaucoma, then refractive errors, even ocular injuries, and they improve the quality of life of patients with eye disease worldwide. So teleophthalmology bridges a gap between the advanced technology and the common man, in particular the rural areas. So these are the conditions where teleophthalmology are useful. I don't want to go into the details of these cases, but we do a lot of teleophthalmology in diabetic retinopathy screening. So integrated teleophthalmology in the management of ocular trauma has shown significant potential in enhancing patient outcomes, especially remote and underserved areas in our country. So what is teleophthalmology? Teleophthalmology is nothing but it involves using digital imaging devices and communication tools to facilitate the remote eye care. So technology used are digital cameras, smartphones, internet connectivity, and specialized software for transmitting and analyzing the eye images in the base hospital. So these are the benefits of teleophthalmology: remote accessibility, early diagnosis and treatment in many eye diseases, including ocular trauma, cost effectiveness, patient need not have to travel long for the eye treatment, and efficiency also. So enhanced accessibility, particularly in the rural areas, the accessibility becomes more. Then early diagnosis treatment. We speak about early diagnosis in many eye diseases like glaucoma, diabetic retinopathy, ocular trauma cases. So teleophthalmology definitely gives us a prompt and effective treatment at early stage, reducing the risk of complications and improving the recovery outcomes. So these are the advantages of remote consultation, image sharing, guidance for the first aid whenever the injury occurs. So immediately if you can guide the patient what to do, what not to do, so at least you can save the eye from extension of the injury. Referral and follow-up and education awareness is very, very important, as in the firecracker engine is told. Awareness is very important and it has to be circulated throughout the country. And definitely it's cost effective also. So use of teleophthalmology reduces the need for travel and in-person visits, so that making eye care more affordable. Efficiency and expertise also. This allows the efficient use of specialists sitting at the base hospitals and controlling the patient in a rural eye hospital or rural vision center, where an optometrist or a ophthalmologist or only medical officer controls the patients or sees the patients. However, there are challenges and limitations, technological barriers, training requirements. You require the proper training of the optometrist or the village health worker to use these technological equipments. Patient acceptance and compliance. Many times the patient refuses to go virtually. They want to see the physically to the doctor. And quality and accuracy diagnosis. Sometimes images are not very good. Sometimes you get wrong images, and wrong images get the wrong diagnosis, sometimes wrong treatment too. And of course, legal and regulatory changes are very important. Medical legal is very important because sometimes we have to give the particular industrial establishment to the compensation. So if not properly treated, properly diagnosed, probably these legal things come into the picture. So we have to take in this. So whatever it is, in spite of all challenges and limitations, the potential benefits of teleophthalmology in improving access to eye care and managing ocular trauma are very, very significant. And continued advancement in technology, there are a lot of improving. We go from 4G to 5G, 5G to 6G. And the Starlink, everything is coming up. So combined the efforts to address these challenges can enhance the effectiveness and acceptance of teleophthalmology. So future of teleophthalmology, as I told you, artificial intelligence, metaverse, 6G, and the Starlink, providing the internet facilities all over the country. So teleophthalmology in the future, the ATM is the one-stop digital touch-point integrated machine designed to diagnose the disease and deliver the primary care, like these kiosks. We can have vision kiosks in rural places, maybe stations, railway station, airports, wherever it is possible, we can install, and the patient gets immediately AI through AI, give the immediate diagnosis of the disease. And also proper guidance, whether it's referable or non-referable. So to conclude, teleophthalmology stands as a transparent approach in managing ocular trauma, bridging gaps in accessibility and expertise, and ultimately contribute to the better patient care, particularly in rural areas. As technology continues to evolve, the potential for teleophthalmology to revolutionize eye care and improve patient outcomes remains vast. So, to conclude, teletrauma care enhances the early detection, facilitates timely intervention, and contributes to better outcomes for the trauma patients in our country. So that's to enhance this. We started this teleophthalmology society last 4 years, having our dynamic Professor Natarajan is the president, and since last 5 years we are doing a lot of work on the diabetic retinopathy and glaucoma detection through teleophthalmology. We can add ocular trauma too. So be a member of teleophthalmology society and enhance our activities in our country and get the benefits of a lot of teleophthalmology startups in the clinics. We are planning also to start a South Asian Teleophthalmology Society, SATOS, integrating all SAARC academic countries. So once again, I thank the organizers giving the opportunity to speak, to stand before you, and popularizing the teleophthalmology in our country. Thank you very much.
Thank you, Dr. Subudhi. That was a very informative lecture. I would request Mayur to please hand over the memento to Dr. Subudhi. And I would request Dr. Preeti Kamdar to come on the dais to speak on her topic of traumatic glaucoma, overt and covert.
So Dr. Preeti is taking a couple of minutes to load the presentation. In the meantime, there will be a couple of questions that we can take here. Anybody in the audience wants to ask any questions? If this,
Nitin, we are happy we have our president of Bombay Ophthalmology Association here, Dr. Nitin Balakrishnan. And oh, Nikhil Nasta has come, I didn't see. So Nikhil, say hello to Robert. If you have any questions, because Robert is willing to cooperate with us. And can somebody give the microphone to him? Samir? Okay. Nitin, you can say some few words by the time she's loading the slide. Nikhil, you also.
We are not taking
Nikhil,
an
I
official,
showed the pellet ocular trauma because you told me yesterday.
Yeah, so essentially we're not taking an official tea break. Whoever wants to have tea can go out, have it and come back.
And also bio break. Nitin, say some words, man. No, you can't delegate this. You are president.
It's a pleasure to be here. It's a fantastic audience and a fantastic faculty. And topics which are not generally discussed in normal conferences. So really a pleasure.
And sir, I want to congratulate you for starting the charitable retina setup which we're inaugurating later today. Only you can think of all these things and make it affordable. So thank you for that.
Thank you. Thank you, Nikhil, for encouraging. So that's what I was telling you yesterday, that I learned the lesson from what happening in Mumbai. So we should make sure that this should be only for the poorest of poor and not for the people who can afford. Absolutely. So I have made a system with the trustees are coming in the evening, because I think Hitesh is close to that place, and also we have our own Agarwals there. So the whole idea is not to compete with our ophthalmology, to help people, particularly patients from Sion Hospital, where I am an emeritus professor, who cannot afford and they cannot do complicated surgery, I want to do. And like Purva sends her tough patients to me, and I use that for live surgery. That patient is doing well. You saw the wondrous photograph, I think. So I did a live surgery for Cairo 3 days back. So we want to make sure first the trauma repair is done well in Mumbai, and we should have the best outcomes. That's what Dr. Sunil is telling, to analyze the even Kashmir work for 10 years. It's 2016. So 2026 will be 10 years from now, and hope no more like that. That's the world's largest pellet ocular trauma report we have published. And that's why the trauma center I'm naming after Ferenc Kuhn, who's a chairman of the International Society of Ocular Trauma, as well as he's the authority, and also Dr. Robert. He's running a Ophthalmic Trauma Institute for he's the head of the Trauma Institute, which is there for 50 years. That means almost, and I think during the Second World War, Poland was the maximum attacked. And now Poland is one helping the Ukraine war. And they said, not the war, Ukraine war victims. It's sad. He showed a beautiful video, but very sad, like a mother and children getting injured. And yesterday, he was very upset because yesterday morning, Russia bombed a dam and cut off electricity in the town. Oh. Sad. You know, Dr. Chaya was very emotional, said, why wars are happening? Unfortunately, it started with Mahabharata. Yes, Preeti. And Preeti is my neighbor.
Yeah, that's true. So, good morning, everyone, and I thank Dr. Natarajan and Dr. Karobi for the opportunity and inviting me here. It's like when the patient first comes and the retinal guys do a great surgery, and then we realize the patient doesn't gain vision because the pressure was ignored. So the incidence of glaucoma is higher in closed globe injuries, because that's when the damage to the trabecular meshwork is higher in closed globe injuries. And it can be as high as 3.4% in non-penetrating injuries. And the topic is covert and overt. Now, the IOP can be acute, and we can divide it roughly into 4 categories, acute and short-lived, acute and unrelenting, but it is overt, in your face. You'll not miss it. And then there are these chronic, the acute might go into chronic, and then you have the late onset. So after me, there's a talk on the acute rise, so I'm not going to talk on that, the overt. I will just talk on the covert. And just one thing, there will be a talk on what are the causes of acute IOP rise, so I'll not go into details into that. But yes, whenever a patient has obvious hyphema, it's you know what you need to do. But even if you don't see blood in the AC, put in a gonioscope. Gonioscope will be able to detect streak hyphema. And sometimes, if the intraocular pressure doesn't come under control, and you might feel that, no, the IOP is out of proportion to what the blood you see in the AC. Even then, go ahead and do an AC wash. And sometimes you will be very pleasantly surprised that just a simple AC wash with minimal blood also could get the intraocular pressure down. So this is just one tip which I wanted to give. The rest of the things of the acute rise of IOP, Sneha is going to talk about, so I'm not going to cover that. So let me go into this one case. Just last month, in December, I had this very young girl with vision of 655 N5, 27-year-old. Intraocular pressure in the right eye was 23. She was referred for further management, and left eye was 32. And there was no history of trauma. And if you see in the right eye, it's a very clear picture, 0.2 cupping with a very healthy neuroretinal rim. And you see the left eye where the pressures have gone to 32. And you will find that, yes, there is a subtle enlargement of the cup disc ratio. There is mild pallor of the cup disc ratio inferiorly. And fields were normal. And this is OCT. The OCT right eye is healthy and left eye shows global thinning. So one would say 27-year-old, no history of trauma, one eye 23, so on the higher side, left eye 32. So maybe it is juvenile open angle glaucoma and presenting more with the left eye, but till the moment you put a gonioscope. And in the gonioscope you see 360 degrees angle recession. And one thing about angle, you have to compare it with the other eye. The other eye showed normal open angles and this shows angle recession. So I went back and I asked that there has to be a history of trauma. And she said that when they were little, the siblings used to really bash each other up. And that could be one reason why there is angle recession. So this is what I mean by covert. It's not in your face. Unless you put a gonioscope, you have to find a reason. Although if I had not done a gonioscopy is mandatory for glaucoma, but just if it was not done, it would have been managed as juvenile open angle glaucoma, when actually it's not, it is angle recession glaucoma. And so the late onset glaucoma, the covert. So one thing I wanted to talk to you about angle recession is that, as I said, they are not on your face. Pay attention to the other eye. There is a school of thought that these patients are anyways prone to open angle glaucoma, and the trauma just expedites the process. And that's why one eye gets glaucoma, but the other eye may develop glaucoma later on in life. And that's one thing which I wanted to tell you about. The second is closure of cyclodialysis cleft. Many times a very small cyclodialysis cleft will actually act as a treatment for the intraocular pressure, and due to whatever reason, sometimes because of cataract surgery, sometimes on its own, the cyclodialysis cleft shuts down. And that's when the intraocular pressure rises tremendously, and you would worry, why is glaucoma occurring after maybe 10 years, 15 years of surgery? So these are two causes of glaucoma where you will really not, and when it closes, you might not find any signs of trauma even when you do a gonioscopy. So a strong suspicion is important, and of course these others are there, lens-induced. Retained intraocular foreign body can also be the covert type of glaucoma, epithelial downgrowths, but you see them. And so one takeaway from this lecture, I want counseling for long-term follow-up. It's counseling because patients grow up, they forget, but they at least once a year, not only for glaucoma but also retinal detachments. You can have late onset retinal detachments after trauma. And so medical management, what do? You can use all the anti-glaucoma AGMs, including prostaglandins. Sometimes the intraocular pressure is so high that you sort of don't go to the step-by-step approach. If you have pressures of 40, 50 with advanced disc damage, use everything. Once you use everything, you realize, is this patient going to respond to medical treatment or not? And then you can take the decision for surgery early. Pilocarpine avoid only in acute cases, and I hardly use pilocarpine. So maybe if you have nothing else left and the patient doesn't want surgery, maybe pilocarpine used. Trabeculectomy in younger patient fails. But in older patients, you can use trabeculectomy even after trauma. Tubes in younger patients, yes, that is my surgery of choice, particularly between the age group of 15 to 30. And trab or tube in pediatric, trabeculectomy has a good role to play. I'm not playing the video because there is no time. Yeah. So the take-home message is lifelong monitoring. In acute cases, as Neha will say, they can progress real fast. So take action fast. AC wash can still save the day. Prostaglandins even in acute phases can be used very safely. In the acute phase, avoid pilocarpine. SLT has very limited role to play. Trabs and tubes, depending upon the age group and the severity of the trauma, you can use it. And so once again, don't ignore the lifelong. One important message is lifelong counseling and a very strong degree of suspicion. So thank you once again for inviting me here, and have a lovely day.
That was a lovely talk, Preeti. Preeti, a small question is that you mentioned about epithelial downgrowth. Do we still go ahead with the barbaric pratha of doing a cryotherapy for these things or a grattage kind of an effect, or we do something else for an epithelial downgrowth?
How the vision is. If the vision is stable, I have had patients with 6/6 vision with a downgrowth.
Mike.
Sorry? Yeah,
Mike.
Sorry. I have had patients even, so depends on what the vision is and how fast it is progressing. If it is progressing, vision is really going down, the patient is one-eyed, then you might do that barbaric procedure. Okay. But otherwise, just observe.
Okay.
Yeah. And if the pressure is going high, sometimes these epithelial downgrowths, they can cover whatever fistula you have covered, you have made with the trabeculectomy. So in that case also, maybe you can just go and remove that part only if the vision is stable.
Okay.
So it depends on the other...
medically only.
Yeah.
Okay, fine. Thank you so much. I would request Sunil to hand over the memento.
One question, I think.
Yes, Purva.
Regarding the AC washing mandate, so when do we take a call that we should wait or wash? Because again, chances of re-bleed formation is there. So
yeah. So one is that if it's a full chamber hyphema, obviously you will do it. Okay. About the AC wash, when you have very little hyphema, just dispersed blood, what is the level of the intraocular pressure? If the intraocular pressure just doesn't come down, and you will say that, okay, now I have to do something about the pressure, that's when you go ahead with the AC wash. And again, the clots, you just try to debulk it, don't try to remove each and every blood clot. Because yes, you can actually reopen those bleeders and they may start bleeding again, and then use tamponade. That's what you do. Thanks.
Thank you, Preeti. Preeti, can you receive your certificate and plaque? I would now call on Sneha Kankriya. Sneha is going to continue from where Preeti left off, and she is going to talk to us about, what's it like? Management of glaucoma in ophthalmic trauma.
Yes. Good afternoon to each one of you present here. I'd really like to thank Professor Natarajan, Sir, Karobi, Ma'am, Dr. Smith for this opportunity. So today I'll be talking about management of glaucoma in ophthalmic trauma. So what exactly it is? It's basically different underlying mechanisms that lead to a common pathway to a raised intraocular pressure and increased risk of optic neuropathy. It's divided into early and late onset. I'll be primarily covering the early onset glaucoma. It's related to both types of trauma, that's open and closed globe injuries. Now, when we come across any patient with a closed globe injury, we look at the 7 rings. We need to look for a pupillary tear, angle recession, iridodialysis, cyclodialysis, a TM tear, a trabecular meshwork break, zonular dehiscence, and retinal dialysis. The etiology is multifactorial. You can see there's some amount of inflammation, TM disruption, alterations in the lens position, hyphema, phacoanaphylaxis, glaucoma due to increased episcleral venous pressure, or glaucoma following chemical injuries where you can have an acute rise in intraocular pressure. The risk factors for glaucoma would be, if there's an increased angle pigmentation on gonioscopy, a higher baseline intraocular pressure, hyphema, angle recession of more than 180 degrees, or a lens injury. Now let's look at the incidence of glaucoma in traumatic uveitis. It's usually about 20%. Initially, in certain cases, you might find that the IOP is low because of initial ciliary body shutdown. The mechanisms would be anterior chamber precipitates, trabeculitis. The treatment is usually, it's a self-limiting disease, topical steroids, plus minus anti-glaucoma medications depending upon the presenting pressure. In the acute phase, you would try and avoid prostaglandins and pilocarpine. If there is prolonged inflammation, we would try to rule out any systemic inflammatory conditions or a retained intraocular foreign body. Now, if you have something like a hyphema, usually the blood clears out. The bleeding is from the small branches of the major arterial circle that goes into the anterior chamber. Rebleeds are common within the first 1 week. It's about 5 to 30%. Gonioscopy to be deferred during this time. The complications of hyphema would be corneal blood staining, a peripheral anterior synechiae, rebleeds. We would restrict the patient's activity, head elevation, topical steroids, cycloplegics, anti-glaucoma medications. 5% of these cases require surgical intervention. Now, how do we proceed with it? The guidelines would be for healthy eyes if the intraocular pressure is more than 50 millimeters of mercury for 3 days, or maybe 35 millimeters of mercury for 7 days. If you have a full chamber hyphema, grade 3 hyphema, the risk for a peripheral anterior synechiae would be higher, or if there's appearance of a corneal blood staining. Already the angle recession glaucoma has been discussed. The incidence of glaucoma would increase depending upon the degree of angle recession. It goes almost up to 25% if you have greater than 240 degrees of angle recession. Now, this is a case I like to discuss where we had a 13-year-old boy. There was trauma with a wooden stick. He presented to us 10 days post-trauma where he was already being treated elsewhere. His vision was 660 parts with 1/3 chamber hyphema, a few blood clots in the fundus. We had a hazy view. His pressures were about 32 millimeters of mercury on maximum medical therapy, along with oral acetazolamide, and he'd already received about 200 ml of mannitol. Gonioscopy was deferred for the moment, so we continued the medications. Oral steroids as well as topical steroids were continued. We closely monitored this child. Up till day 15, his pressures came down to 22 millimeters of mercury on maximum medical therapy. Then we stopped the oral acetazolamide and we just monitored him almost every month. We got down the pressures to almost 10 millimeters of mercury. It's a 1-year follow-up, but right now he's on 2 anti-glaucoma medications. But what we need to look at is on gonioscopy, he's almost got, superiorly he's got angle recession. And he's also got zonular dialysis, so the nasal anterior chamber is shallow. We need to keep a watch on that because for the development of any peripheral anterior synechiae. So this child is under close follow-up. But certain cases like these, we cannot medically manage them because of uncontrolled intraocular pressure if you have any subluxated lens or phacoanaphylaxis. The algorithm for a closed globe injury would be with a raised intraocular pressure. You start the patient on anti-glaucoma medications, steroids along with cycloplegics. If you have uncontrolled IOP and eye femur, you would consider an AC wash. And in spite of that, if your pressures are not under control, you would think of a trabeculectomy with a mitomycin C. Coming to open globe injuries, the initial treatment would be medical. And if the pressures are still under control, is not under control, there's basically, due to multiple surgeries and multiple trauma, you won't have a space for a trabeculectomy. You may have to consider tube shunts or maybe even laser in such cases. So in summary, usually traumatic glaucoma, it does resolve by medical treatment, but when it's associated with retained lens matter, cataract, rebleeds, they may require surgical intervention. We need to keep a watch on steroid responders because most of these are on long-term steroids, and regular follow-up is very, very, very important. Thank you. Thank you. Thanks a lot. Thank you.
Please receive your Dr. Sneha. Request Dr. Mayur to present the Our next speaker is Dr. Sunil Morekar. Dr. Sunil always likes innovations, and now he is going to enlighten us on artificial intelligence in traumatic glaucoma and optic nerve. Dr. Sunil.
Can I start? Yeah. So at the outset, I would like to thank Dr. Natarajan and Dr. Karobi Lahiri, both of whom have been more of my teacher than any other teachers. Is it audible? Yeah. So these are my affiliations. I've been working with CPD. The CPD committee, which is an advancement from CME towards continuing professional development, and this is what the conference is about. And I have to say that initially I worked as an associate professor in the medical college, and then I was working with Dr. Natarajan as professor and head for DNB, and then with Hinduja Hospital. And I preferred going back to the medical college because as an associate professor, I allowed myself to be going back to an AP because there are 4 medical colleges with the MGM group, and that is 100 students each. And each of those students collecting photographs and data, and that is what gives me a real big data. So there are 4 medical colleges of MGM in Maharashtra, 1 in Gurgaon, and 1 more in Nanded. So these institutes, I have access to at least around 8 institutes with so many students sending pictures from there, and that is what allows me to do AI. Financial disclosures, none, because I'm going to be talking about some things here. Before we talk about AI, I would recommend that you do some of these courses. There are these biostatistics and Wolfram language course from University of Cape Town, and there are other courses from MIT which you can do if you want to start doing this AI. And I see a lot of youngsters here. It is possible for all of you all to do the AI. And introducing AI, I mean, what is the purpose? What is AI and what is the purpose? So AI is a branch of computer science in which artificial intelligence systems are man-made, and intelligence denotes thinking such as consciousness. And the major purpose is to simulate human thinking process by learning from existing experiences to solve problems that cannot be solved through traditional computer programming. So all of us think. So we are involved in a cognitive process. I think differently. Dr. Edak thinks differently. Somebody else, Dr. Lahiri thinks differently. And so we all think about how we are thinking, and then we go to metacognition. Then metacognition goes to metacognition errors. So in one group of hospitals, we may have multiple thinking, and there might be errors in that also. So we incorporate all that complex process into a machine learning that makes it easier for you to come to a conclusion
which is not a biased conclusion based only on your cognition. So when we talk about AI, a lot of people think AI is very simple, but machine learning is one part of AI, where AI can be recommender systems, planning, fuzzy logic, knowledge representation, expert systems, multi-agent, and machine learning is further divided into supervised, unsupervised, deep learning, semi-supervised, regression, and ensemble learning. So it is a complex subject, but something that is on the forefront right now, and unless it's like a self-driven car or a car which or robotics or something like that, if you don't enter into it right now, you are going to be disadvantaged in some stage. So machine learning is a subset of AI, and this is saying the same thing again. And among the various machine learning models that have emerged, neural networks that simulate the synaptic structure of the human neurons. So I saw something, I saw an angle recession, I saw an angle recession the second time. The first time I remembered it, and so now I know that this one is an angle recession, and this is what exactly the machine will do. You feed it something, it will recollect it from its data, and then attribute this as, so you will say that this man looks similar. So this is he Tom Cruise? So he will take the picture and put my features and say, no, this looks like Tom Cruise, but it's not Tom Cruise, this is Sunil Morekar. All right, so the machine learning will look at multiple features, neural networks, and then further we go to convolutional neural networks, which have encoding structure similar to that of the visual cortical neurons. Now, in human vision, each neuron corresponds to simulation by specific regions in the visual space. So when I see an angle recession or when I see a glaucomatous patient, something I have remembered about my first patient 25 years ago, something that I remembered about my patient 10 years ago, something that I remember the patient that I've seen yesterday. I have to amalgamate all that. Humanly not possible, because I'm trying to see that over 30 years. Humanly just not possible, especially when you get old. So you have to rely on machines and what you have fed the machine. You have taught that machine. So it's your most reliable student. There are advanced algorithms which you use in AI. There is UNet, which is a convolutional network that was developed for image segmentation. So you make images. So I can make an image. I can say that this patient has got myopia. This patient has got injury. There is a large disc. There is a cupping. This cupping is because of myopia. Now, is this cupping because of myopia becoming cupping because of glaucoma? So I have multiple layers, and that kind of a thing, I can create an image. This is what my daughter does, creates images. I create an image and match that on that. So I create another James Bond 007, 2026, and then, oh, Sunil Morekar looks like that, right? So I can create an image and then match it with that image. ResNet is a residual network in which layers learn residual functions with reference to the input layers. So you make many layers. So whether it is Sean Connery type of James Bond, whether it is Pierce Brosnan, so you make multiple layers and then learn from that. AI in glaucoma, it has been around for quite some time now. So you do the image processing and then call it normal or abnormal. And then you add the multiple layers to it, the intraocular pressure, and then how you see it, and the visual fields, and how would you call this glaucoma, not glaucoma. And then this further can be introduced into traumatic glaucoma. So AI in glaucoma, it can be used for patient education, for data collection, and your papers can come out of it. Your glaucoma screening, whether this is traumatic glaucoma or not, diagnosis, predictive analysis, is this glaucoma going to be progressing very fast? Why is it progressing very fast? So in glaucoma, there is something we call about, I was talking to Dr. Karubi about traumatic reserve loss glaucoma. So if you were to consider glaucoma as if my retinal layer is becoming bald. So I am becoming bald. So as I grow old, my nerves are being lost, my hair is being lost, right? And so if you pull my hair, then some baldness is there right now. So I will become bald faster and earlier, right? So that is what it can. So the available data sets, these are available on internet. So this is a Riga data set. So you can compare your data with that. There is a Messidor data set. So if you need it, I'll give you a demonstration outside. And then there is Pegasus, a cloud-based artificial intelligence web app, which is available on Microsoft. So you can actually download this on your phone and then compare your patients with it. And the evaluation for this was done by the European Optic Disc Assessment Study, which is now collaborating with the Pegasus, with the Orbis and the Visualite. And the ROC curves, I'm not going to discuss more about this, they're much better, and then you realize that the machine does much better than what an individual will ever be able to do, whether it is an ophthalmologist or an optometrist. So then I talked about traumatic reserve loss, so you pulled my hair and you made me partly bald. Alright, so glaucoma after ocular surgery or this thing, you have inflammation further, so you have monocyte infiltrating and response to cytokine inhibitors, and you look at these data and you figure out whether this patient is going to go into glaucoma further or not based on inflammatory disorders. And you look at retinal nerve fiber layer thickness damage based on the severity. So how much of my hair have I lost? That is what you look at through AI, and then you figure out how fast this patient is going to progress. So there are times when you say it's refractive glaucoma, the IOP is low, but the glaucoma is still progressing very fast because you pulled my hair and made me almost bald. I have left with one hair. Alright, so even if it is no pressure, I'm going to lose that hair. Right? So then there are traumatic angle abnormalities. So you can use the data sets, pictorial data sets, the gonioscopy data sets, they are there in the internet. You can use that and compare that and come to a diagnosis which anybody can come. The ophthalmologist or this thing, they can then refer the patient to you saying that this is definitely a glaucoma as diagnosed by AI. So then there is something which is called as traumatic pigment dispersion without angle recession. So you might have just one quadrant angle recession, but there's a lot of pigment dispersion which is causing blockage of the trabecular meshwork, and that is something that can be picked up by AI, telling you that though this is not a huge angle recession, no, not a very deep angle recession, yet there is so much of pigment dispersion, so this is going to go to glaucoma. And then you have automated anterior pigmented analysis using 360 degrees gonioscopy. And then you can also look at automated gonioscopy for angle recession. So I will run through that. And then you have rapid diagnosis for ocular trauma through USG. Standardization of the images of the optic nerve. You look at the blood supply of the optic nerve. Because of the injury, there has been a blood supply loss or there is a nerve loss, and that is going to go into glaucoma. So you want to know whether this is a patient with glaucoma who suffered a trauma, or this patient is non-glaucomatous who suffered a glaucoma, or this is a traumatic reserve loss, or this is an angle recession high pressure glaucoma, which is going to come later. So there are multiple things which you can look at through the ocular blood flow, and that can be analyzed with automated this thing. And then finally, I'm going to run through that. You can revolutionize the clinical understanding and the diagnosis of optic neuropathy. You can use the detection of photographs to deep learning for optic nerve injuries. So you have traumatic optic neuropathies, direct and indirect. And then you can use the color vision, and the color vision can be done with this insight abnormalities. And then you can do the artificial intelligence for acquired color vision deficiency because of trauma. And you can, that's this thing, and then you see how it gets corrected. So I'm talking about subtle cases which can get corrected. The prognostic imaging of VEP, you can use artificial intelligence through VEP, artificial intelligence through visual fields. There's a lot of things, and then you have the generalized discriminant analysis. So I'm giving a lot of words here. I want the youngsters here to go back home and look up Google and look at what is possible. And then the optic nerve sheath analysis. Now, what we have done is what we have applied the Wolfram language in our case, traumatic optic neuropathy, and figured out what patients are going to do better and what patients are not going to do better. And some of these cases, so these are complex injuries where the traumatic brain injury, Dr. Usha Johri is here. She's going to talk about traumatic brain injury and how that traumatic brain injury can cause retrograde loss of nerve fibers, which will give rise to a appearance of a optic neuropathy, all right, where the injury is in the brain. And sometimes you can do 3D reconstructions and do an artificial intelligence for the 3D. And when there are multiple layers involved, multiple polytrauma, where there is nose involved, there is maxillary involved, you'll have to apply various AI algorithms. So that's the academic disclosure. If anybody is interested in AI, I just gave you an overview here. There are 45 ways in which ocular trauma can be put to the test of AI. If any one of you is interested, you just have to contact me. My numbers are there. My email address is there. You can come to me. I can show you how to do AI for ocular trauma. Thank you.
Thank you, Sunil. That was a very, very, very informative talk. With something which went a little above the head also. I request you to call for Dr. Nishikant.
Yeah, next speaker is Dr. Nishikant. He's a senior vitreoretinal surgeon in Mumbai, and he's going to talk on choroidal rupture. Meanwhile, we'll give the plaque to Dr. Sunil Morekar. Dr. Preeti, please. Cholesterol plaque? No, that is better avoided. We don't want an embolus in the optic nerve.
So good morning. Thank Dr. Natarajan and of course Dr. Karobi for arranging such a wonderful meeting. I'll be talking about choroidal ruptures that we come across very commonly in our particular town or our country because basically we have a lot of choroidal ruptures that we see, and mainly that is because of the cricket ball injury that we get, and that is I think one of the highest incidents or the reasons that we get. Followed by motor vehicle accidents and physical assaults. So it was first described by von Graffe, and it was also called as sclopetaria. And the choroidal rupture can actually have a big impact on the visual this prognosis of the patient. Now, what's the pathophysiology as to why a choroidal rupture is so devastating? So when there is an impact, there is a sudden compression, and then there is a reflex concentric outward force that happens once the eyeball recovers. Now the sclera is very tensile, it can withstand it, and the retina is also elastic, so it can even withstand it. But the RPE and the choroid are not so elastic, and therefore there's where the rupture occurs. Now even the tensile strength of the sclera is there to resist it, but if you actually see that the outer retinal cells are not so elastic. So most of the times, the brunt of the trauma goes not only to the choroid, the RPE, and even the outer retinal cells. And once there is an injury out there, the photoreceptors which are not suspended on the outer side with the Mueller cells are much more vulnerable to damage, and that's why you will have so much of neurosensory loss when you get a choroidal rupture. Now, most of the times, whenever there is a choroidal rupture, you will see it involving inferior or inferotemporally, and that is basically because of the Bell's phenomena. So when an object comes very close to the eye because of the Bell's phenomena, you tend to adduct the eye and also look upwards. And because of that, the direct impact is not really speaking head-on with the optic nerve being just behind that or the macula just being behind that. And therefore, many a times you will see that the choroidal rupture is inferior to the disc or temporal to the disc. And the reason for that is basically nothing but the Bell's phenomena that comes in just before the impact. Now, what are the causes of visual impairment? Like I said before, first of all, it can be a direct trauma to the photoreceptors. There can be subretinal hemorrhages, and we know that hemorrhage is always traumatic to the retina. We can have pre-retinal hemorrhages, which can also cause visual loss. Of course, the recovery is much better. But more than that, there are long-term sequelae of the trauma itself, which can be like you get a traumatic angle recession glaucoma. You can get a choroidal neovascular membrane, which is so common after a choroidal rupture, which can lead to a visual loss over a period of time. And of course, there are other comorbidities like a retinal detachment or a traumatic macular hole, or even an optic nerve avulsion that comes in along with the trauma, which can contribute to the visual loss. Now, diagnostically, traditionally we always followed the fluoresceint angiogram, because the fluoresceint angiogram actually showed a choroidal rupture much more than what you would have seen just with a normal examination. For example, if you look at the picture on the left, you will not make out the choroidal rupture which is just next to the optic disc. We can very clearly see the choroidal rupture which is just in the macular area. But when you do an FFA, you can actually make out that there are two choroidal ruptures which are concentric, one just after the nasal to the macula, and one which is just involving the macula. So FA traditionally always highlighted the choroidal rupture. But now we have multimodal imaging, and with the multimodal imaging you can actually delineate the choroidal rupture much early, even if the hemorrhage is blocking it. For example, if you look at the fundus autofluorescence, it will definitely show you the choroidal rupture, because that's where the RPE has sort of moved inside with a choroidal rupture, and there is a crowding of the RPE cells. And because of the crowding of the RPE cells, there is a hyperfluorescence there, and therefore with the fluorescence, fundus autofluorescence, you can actually highlight the choroidal rupture much easily. Also, when you go to the OCT, you can also find out where actually is the choroidal rupture and where is the shrem which is caused due to the inflammation followed by the choroidal rupture. So the multimodal imaging has made it much easier for us to visualize and also to diagnose the extent of the choroidal rupture and how much it has affected the retina, how much is the hemorrhage, and what is the subretinal hemorrhage. Everything can be easily seen. OCTA is just sort of emerging into choroidal rupture, not really of great value as of today, but I am sure over a period of time we'll learn much more about OCTA in choroidal rupture. Now, more important thing is we need to have a serial follow-up and we need to have a serial imaging. Now, if you look at the earlier picture, this and this is of the same patient. But now you can see the visual, the choroidal rupture visible in a much different way. As it is healed, there is fibrosis, there is proliferation of the fibrous tissue, the way it has involved the fovea, how the ISOS junction is involved, and now at the OCTA, you can even see the scleral vessels that have come in. So you need to have a serial photography to know how the choroidal rupture is progressing. Now, when you come to management, what I'm going to do about CR itself is nothing much, but we have to really keep on monitoring the patient, like I said before, because we know that there will be complications that are visual threatening that can come out due to the trauma and due to the choroidal rupture. And the most important thing that can come due to the choroidal rupture is the subretinal hemorrhage. Just a minute. Now, if you have a subretinal hemorrhage, then displacing it by using a C3F8 gas and with or without TPA is important. This is one such patient of mine. Came in with subretinal hemorrhage. You can see the hemorrhage just subfoveal, finger counting 2 meters was the vision. And after giving TPA, you can see the macular blood has cleared off. The vision has recovered after 1 month to 624, and after 6 weeks, he has come back to 612, and you can see most of the hemorrhage is gone. And now you can see that the choroidal rupture is not really involving the fovea, it's a bit next to the disc, and another rupture here and another rupture there. Of course, long-term follow-up is very important because you know that the scarring and hyperplasia can go on over a period of time, and then it can start migrating towards the fovea, so you have to be very careful. Like in this case, you can see initially it was here, and as the fovea emerges, you have to be careful because it's just next to the fovea. You never know when this is going to migrate inside. The prognostic factor, just a curvilinear shape of the ruptures that were inferior and temporal to the disc have generally a good visual prognosis if it is just not involved directly the fovea. But if you have multiple extensive ones which are just to the optic disc, then it has got a bad visual prognosis. The other, of course, are involvement of the optic nerve itself, a macular hole, and other things that can traumatize the retinal photoreceptors and the optic nerve that can lead to a worst visual prognosis. So in conclusion, choroidal rupture can be threatening. We have to have a careful observation for knowing the potential complications that are coming in, like a secondary CNVM. If a secondary CNVM comes in, it responds extremely well to anti-VEGFs, and if there is a submacular hemorrhage, you really need to take action fast for a faster visual rehabilitation. Thank you. Thank you very much.
We end this session now, and I would like to invite the conveners of the next session. Dr. Robert, I'd request you to come to the stage. Dr. Lahane is not here. Nikhil, you can come in place of Dr. Lahane. Dr. Subudhi, Dr. Balkrishnan, and Dr. Nishikant Borse, don't please go down. Yeah. And I would request Dr. Ashish to hand over the memento to Nishikant.
I know. How are you? Beautiful.
Same participant.
It looks like you borrowed a dress.
I did. I was going to say that. I said too bad.
How are you?
I'm good.
I'll sub you.
Just call them back and
the participants of the first session, if you all can come up, we'd just like to take a group photo.
The first session that includes all of us.
Group photo. Come.
if you're not in it, you'll not
Yes,
be in the next
yes.
one. If you're not here, you'll not be in the next
Usha. So this is the first and second session together.
Joseph will not like it.
Yeah.
Thank you.
Okay, so in view that we are running late, I think we have skipped the coffee break, and whoever wants to have tea and coffee can just go and have it. And we will start off with this session with Dr. Sharang, who will be speaking on closed globe injury, the fury of an injury. Is your talk ready, Sharang?
Yeah.
Wonderful.
So at the outset, I'd like to thank Karubi ma'am and Natarajan sir for giving me this opportunity. And my talk is a little bit of overlap with what Dr. Saili spoke and what Borse sir spoke just now. So it's a bit of a revision for some of you. So I'll be focusing on the posterior segment effects of a globe closed injury, right? Now, a classification, as Dr. Saili already mentioned, I'll just go briefly in it. Like, you have either an open globe or a closed globe injury. In a closed globe, if the impact is blunt, then it causes what is known as a contusion. But if it is a sharp object, then it is a lamellar laceration. Lamellar because it's not a full thickness. Right? And if it's an open globe but with a blunt object, then it will lead to a rupture. If it is a sharp object, then it will lead to a full thickness laceration. Now in the laceration, if it's only entry wound is there, then it's called penetrating. If there's an entry and exit, then it becomes a perforating injury. And if there is a retained intraocular fallen body, it's classified separately. You can also classify it based on the amount, the location and the visual acuity at presentation. So you have this A, B, C, D, E classification, and then you have different grades as far as the visual acuity is concerned. Plus you have the location, 3 zones you can classify it, and presence of RAPD or absence of it. So in my talk, I'll be focusing on the contusion part of it. It's a closed globe injury and posterior segment effects. So mechanism, you have these coup and contre coup mechanisms. Coup is wherever is the impact at that location when there's an injury, that's called an coup type of injury. And the other is because of the shock waves that are sent after the injury that causes on the other side, that is known as the contre coup injury. The other type of injury is when there is an antero-posterior compression and that causes an equatorial expansion, then that also can lead to multiple effects. And now I'm going to talk about the retinal injuries, the hemorrhages, the choroidal injuries, and the optic nerve injuries, right? Now in retinal injuries, you have different types of problems that you can see. One is, of course, the commotio retinae, which is a very common finding which is seen. and it is a contricu type of injury. If it is involving the macula, then it is known as the Berlin's edema. There is basically a grey-white opacification at the level of deep sensory retina. And you have to understand it's not actually a true edema when we say of a Berlin's edema. It is a fragmentation of the PR photoreceptor outer segments, right? And the treatment is just observation. You don't have to do much. That just 4-5 days later, that the commercial retinae will disappear, and it has an excellent prognosis. Retinal tears nearly always occur at the time of injury. And based on the mechanism, they could be of different types. One is the necrotic tears, which are because when an object strikes posterior to the ora, it can cause a coup at the site of injury itself that can lead to necrosis and form a full thickness tear. Stretch tears are because of the rapid horizontal expansion that I spoke about. These are usually curvilinear and concentric to the optic nerve head, and they may self-heal as well. And then, of course, the common ones are the traction tears, where again you could have what is known as vitreous base avulsion, which is just like a ribbon floating in the vitreous cavity, and you don't have to do much for it. Retinal tears can also occur because of secondary to the PVD that occurs post-trauma. And the treatment, of course, for such lesions would be either doing a laser therapy or cryotherapy if there's vitreous hemorrhage and media not permitting. Retinal dialysis nearly always occurs traumatically, with inferotemporal quadrant being the most common, and in 10% it can be bilateral as was. Treatment could be laser cryo, or if there is some fluid which is already developing, going into detachment, then buccal could be also an option. Macular holes are caused by tangential traction, or they could be caused with a anterior-posterior traction because of PVD, or sometimes chronic CME can be there for so long and cause a macular hole or necrosis as well. Right? Based on the appearance of the traumatic macular hole, they have been classified into 5 types. And management initially is observation only, because traumatic macular holes are known to close spontaneously as well. 40% of the cases will close after 2 months, and around 60 to 70% after 4 to 6 months. Right? So vitrectomy is indicated if after 3 to 6 months there is no closure seen, but the visual, although the surgical results are great, the visual improvement is generally poor in such cases. Traumatic RDs are seen, especially it's the leading cause in children, traumatic RD, and they usually progress slowly, they are unnoticed, and that is why they will show the signs of chronic retinal detachment, like you can have demarcation lines, you can have subretinal precipitates, you can have bands, or there could be cysts, and extensive tobacco dust formation would also be there. Causative tear is nearly always somewhere close to the base. Based on the location of the break and the type of break, you could do a pneumoretinopexy, you could do a scleral buckling, or you may require a vitrectomy. Coming to retinal hemorrhages, you could have a subretinal hemorrhage, right? And this is usually secondary to choroidal rupture. Borses already showed a lot of images of that. If the heme is not involving the fovea or the macula, then you could just observe it. There's nothing much to be done. But subfoveal hemorrhage ideally needs to be displaced. And based on, there are multiple options available, surgical as well. And if the patient is young, usually will not have any ocular comorbidity, then pneumatic displacement could be tried, where we just inject a gas bubble in the eye and ask the person to keep a prone position, maybe slight rotation of the head to push the hemorrhage away. In an elderly patient with no ocular comorbidities, you could consider a vitrectomy with subretinal TPA along with gas, or you may just try an intravitreal TPA followed by gas. And if there are accompanying comorbidities, then you could add an anti-VEGF as well. Subhyaloid hemorrhage, you have to look for retinal tear or subclinical RD, and it could be just observation if the size is small, or you could do a YAG hyaloidotomy or a vitrectomy. Vitreous hemorrhage, you need to observe, give a propped up position, and the hemorrhage will most likely reduce. You have to keep observing to look for breaks if you find any, and ultrasonography may be required to rule out RD, and vitrectomy if no resolution after 1 to 3 months. Coming to choroidal injuries, I think this has been extensively covered by Sir. Just the mechanism that he spoke about, equatorial expansion, and generally subfoveal will have poor prognosis. And you could also have a late onset choroidal neovascular membrane. Scopate area was typically described for high velocity missiles passing through the orbit, and that causes the shock waves leading to rupture of choroid and retina. And they could have multiple things like this claw-like break in the Brooks membrane and fibrous tissue proliferation, optic nerve damage. Finally, coming to optic nerve injuries, you could have optic neuropathy. Mechanisms are different, either because of an intra-sheath hemorrhage or direct shock wave to the nerve fibers. And they have been treated with IV steroids, surgical decompression, stem cell transplant, all these things have been tried. No specific pros and cons for this. Finally, you could have an optic nerve avulsion where there is extreme displacement of extreme rotation of the globe, causing severe damage to other tissues also. So you need to have a good detailed evaluation. Look for RAPD, that's very important. Visual acuity as presentation will decide the prognosis. If there is an hyphema, do a gentle examination. Scleral depression may be initially avoided, and don't forget to do an ultrasonography. Prevention, like most things in life, is very important, and workplace injuries are very common, and you need to use all kinds of protective equipment that is available at your disposal. Even for sports and leisure activities, you need to be careful. Pediatric trauma is a big thing, so always children have to be kept under supervision, right? And public health education and eye care programs are also important. Please remember the lifetime prevalence of ocular trauma is higher than that of glaucoma, ARMD or diabetic retinopathy. Finally, I'll end my talk with this image. You know, this cricket box abdominal guard was started used in 1874, while the helmets were used in 1974. People took 100 years to realize that their head is also important. Stay safe, everyone. Thank you.
Wonderful talk, Sharang, and very well enumerated. Sharang, just one thing you touched upon the last part about the protective gears for the eye. So, can you throw some more light? Because I tell you one very interesting session we had at ASRS. So there was one first presentation was about an eye injury that happened because the guy was not wearing a protective one. And the next presentation was by Manish Nagpal, which showed a penetration of the eye that happened because of the breakage of the protective glasses. So, you know, there has to be some standardization because people just wear anything that comes to their mind. So I think.
Yeah, absolutely. So, I mean, you can't just use what we give like post-op goggles. You can't wear that for sports or anything. So there is a gradation of how these, like in a car, the glass is a special type of glass which will not shatter immediately and will not penetrate in your eyes. So there are glasses also which you can make in similar fashion, like the ones which are, like suppose you are doing a cycling, right? People don't even wear helmets here while cycling, but helmets at least some people do. Nobody wears protection for the eyes. So I think that is something which is important because these small things are more likely to cause damage initially rather than something more severe.
Thank you.
Thank you.
Nikhil, can you please come over for your next talk of domestic violence and eye trauma?
We need to connect this.
Yeah. Sorry, Sharon, can you please come up and Dr. Robert, can you please present the memento to Dr. Sharang Verti? Yeah. Thank you, Doctor.
कैनवा से ब्रेक
कैसे करेंगे
कुछ भी कनेक्ट करना पड़ेगा
डिस्प्ले के लिए सर ये पॉइंट कुछ है आपके पास कन्वर्टर
I think Preeti has oh sorry, here it is.
We have a MacBook.
Yeah, he's got it.
क्या करेंगे
Next is you.
Wait.
Okay, so while he loads it, I would like to thank Dr. Karobi ma'am for always including me in her programs. Thank you to Dr. Natarajan sir, Subudhi sir, Smith, and Dr. Vishal. All of you all spoke about trauma. How many of us have had accidents in real life? Not so many, na? 1 or 2. But, okay. How many of us have actually seen or been a victim of domestic violence? Quite a few. We don't want to see show of hands, but in your minds you know it, right?
All the guys here.
All the guys here. Okay. So
in COVID, that was the maximum eye injuries in the world. You know that?
yes, that is my slide also. Yes. क्या करना है? So there are so many movies made on domestic violence. Can you name a couple of them? So many of them. So many Hollywood and Thappad and just now Do Patti. So this is a topic which is, see, the difference between a trauma and a domestic violence is that there's no escaping domestic violence. You need guts to get out of it, and it's going to be day in, day out. Right? So it's a recurrent thing which doesn't get the kind of attention that it deserves, which is why I've chosen this topic.
He was a male patient. He was a diploma holder,
Huh.
and the wife was an interior decorator or whatever company. So in the COVID time, that guy was sitting in the bed and asking for and then she got angry. In between, I think he
screen change करने का
you're not even a degree holder.
extended
Doing with the broomstick. She turned the broomstick and hit him. And then it went and eye gone.
So she was interior decorator, na? Decorated his face also.
डुप्लीकेट कैसे होता है डुप्लीकेट
मेरे को नहीं आता है.
आपका स्क्रीन आ रहा है you will duplicate this screen duplicate
How do we screen mirror this?
duplicate in
Why is it happening? पहले तो किया ना, इन लोग ने MacBook से किया ना.
उनको आता था
उनको आता था.
duplicate this screen
I want to present in Canva.
duplicate this screen duplicate this screen display no it's not coming where is the internet for this no internet the screen is presented there
Domestic violence we see mostly in rural areas. Dr. Natarajan?
I think here
I'm here.
Happening.
Domestic violence most commonly seen in rural areas because the people they drink
All child with after accident with part of inhaler during a kind of domestic violence incident. So my talk will also present one case like this.
ठीक है.
Dr. Kerubi? No, Dean sir has come. It's 12:20 and we have 4 more talks, no? So what shall we do? We can do that. Anyway, Nikhil, you finish your talk. So maybe we'll have we'll have a Dr. The sir is here. Already he has arrived. He is sitting there. What I'm saying, sir, we're just adjusting the program. But anyway, it's all online. What I'm suggesting is after Nikhil, we'll have Dr. Robert Reda's talk, which is scheduled. And the rest of the talks we'll do after inauguration.
2 talks after Nikhil.
2 more only. Who's that?
Only Dr. Balkrishna and
Okay. You don't mind, sir? 2 more talks only. Okay. Oh, sure. And I would like to welcome Dr. Mohan Joshi, and I think he's one of the best deans I've come across in Mumbai. Please, sir, take your seat. The reason is, really, because he knows I was frustrated because I want to go and teach, and the municipal commissioner at that time was my friend. He wrote that Dr. Natarajan wants to teach, and he wrote to all the 4 medical colleges. The 3 rejected me. Only Dr. Mohan Joshi accepted, and he renewed later. And now also, yesterday I went to the department. Dr. Chaya's secretary asked me, "You have not signed the attendance." So now I asked, when is my expiry? So he said, April. Sir, I need a approval before you go. Okay. So anyhow, so the best part is, I didn't know, later I came to know Dr. Mohan Joshi's daughter is a vitreoretinal surgeon in Shankar Nethralaya, Dr. Aditi.
Jackie, don't go so fast. It's not your expiry as yet.
No, the order. No, they have written already 98% of Dr. Natarajan.
Welcome, Dr. Mohan Joshi, sir. So, sorry about this delay over here. It's an honor to present to this esteemed group of ophthalmologists on a topic that, while sensitive, is very crucial in our field, the impact of domestic violence on eye trauma. Domestic violence affects millions all over the world, and as eye care professionals, my slides are not playing.
Yes.
Okay. There are videos, but they're not playing. Okay. We are in a unique position to recognize and address ocular manifestations of this very pervasive issue. If you look at the numbers, 30% of people have experienced domestic violence in their lifetime. It's not called domestic violence anymore. It's called intimate partner violence. Everything in the world is changing and getting very complicated. This violence is not just husband to wife or wife to husband. It can also be children to elder parents. It can be very powerful parents to their children, and children to young parents also. It's a very gray zone. It's very common, and it happens across generations, across countries, across all race, religion, status. It really doesn't matter at all. Estimates suggest that 20 to 30% of these victims of violence experience eye trauma, ranging from injuries which are minor to severe vision-threatening conditions. Yeah, I'm still moving. So my presentation is from a review of literature by Grace Baldwin and John Miller, which is saying that, like I said, mid-face injuries are the most common. And these injuries which impact the eye and ocular region, they are very important to identify because they lead to a lot of psychological and even life-threatening conditions at many times. The law has also changed. The IPC is now BNS, and under section 498A of the IPC, they deal with criminal offense of cruelty against a married woman by the husband or the relatives, like dowry cases. In our internship, in our residency, we've seen so many of these happening. Right? Section 84 of the BNS 2023 deals with this same provision, and it was passed on 7th October 2024. There are various types of eye trauma. 45% of these domestic violence cases come with some form of eye trauma. That's close to 50%. Okay? So as ophthalmologists, we need to identify. The patient may come with, I fell down the stairs or I slipped, but you need to read the body language, the signals, and offer some support. If they are repeatedly coming to you with same kind of injuries, then it's a red flag for you. Now, injury could be caused by a blunt object like a fist or a punch, a sharp object which could be just flung at them, or even a chemical trauma. Anything that's liquid in their hand, could be a bottle of alcohol, could be a bottle of spirit, or anything that it may be. I saw some smoking in the audience. Okay, now the thing to note about this is, if you look at this video, suppose I were to hit someone, okay? I'm not a lefty, most people are righty, so we're going to hit like that. When we hit like that with the right hand, these people are going to be injured on the left half of the face. So a repeated left-sided trauma, subconjunctival hemorrhage, or a repeated injury here, that is an indication of some form of domestic violence. Also, if I were to punch someone, I would hit them bang in the middle. So it's going to cause a nasal fracture, all the zygomaxillo, all of this. And these are hard bones. The nasal one will to crack, but if there's a crack of this bone, means it's a repeated thrashing or a repeated trauma. It's very tough to crack that, but it does happen. So we need to be very, very particular about what are we seeing and is it correlating, and we need to raise our alarm. Various IPV-related eye injuries are reported involving nearly each and every anatomical part of the eye, right from the front, that's the cornea, all the way back to the optic nerve. There were detailed descriptions of these in the previous lectures, so I'm not going to go in much detail of that. The vision-threatening injuries here are traumatic cataract, retinal detachment, intraocular hemorrhage, orbital or zygomatico-maxillary complex fractures, the ZMC ones that I spoke about, and open globe injuries. In this study, one case reported optic nerve avulsion related to IPV, and another one described dislocated lens also. Overall, the commonest, which were the minor ones, were periorbital contusions and corneal abrasions. So this is a classical domestic violence where they come with this kind of a contusion, and this is a black eye, what we usually call, right? This is a case of orbital fracture. So because of repeated punching, this person has got an enophthalmos, they would have diplopia, there's a subconch hemorrhage, and this will need a proper surgery. This is also very common where there's sphincter tears, there's a traumatic mydriasis, there's a hyphema. We can't see the D-shaped pupil here. This is choroidal ruptures, retinal detachments, and injuries around the optic nerve as well. This is a globe rupture, so imagine that someone is repeatedly hitting and they've actually smashed something on the person's face. So the injury is so bad that there's a contour coupe injury, there's a horizontal and vertical displacement, everything is shaken up like a mixer getting turned on. And the smashing effect caused the globe to rupture, everything is popping out. So this has to be handled very sensitively also, because this one will lose vision. Suturing can be done, whatever you may do, but it's not a very good prognosis. This is a series of chemical injuries because of something flung at them. We don't need to go in details, we've done that before. Just showing you the various aspects of what can happen. Now there was another study where they reported one very severe case. What happened here was they successfully salvaged a case of cataract and RD by domestic violence. A 33-year-old female had presented with impaired vision both eyes. She was a victim of domestic violence by her dad and her mother-in-law for 10 years, and she was PL with hand movements. There was cataract surgery done, implantation of IOL, vitrectomy and silicone tamponade, but when the oil was removed, there was a redetachment. Ultimately, there were multiple surgeries, and there had to be a lot of support also. Like Natarajan sir was mentioning earlier, in the COVID pandemic, frustration levels were at an all-time high. People were just getting into each other's faces, and that's when the incidence and the prevalence of these injuries went very high. Okay, people were binge watching also on all these Netflix series, reading depressing news and all thrillers, and they were getting into the zone of thrashing and beating. They were alcoholic, they were depressed, they were frustrated. We saw a lot of injuries at that period. Now disturbingly, ZMC fractures also occur twice as frequently in IPV related assault compared to non-IPV related violence, the thrashing and hammering that I was talking about. Now what are the challenges we face with domestic violence? Annually, about 1.6 million people lose their vision due to these intimate partner violence injuries. And I'm sure there are many more because it's a taboo, so there's a lot of underreporting in this. Right from conjunctival tears to corneal abrasions and tears to sclera like you were describing earlier, anterior chamber like a long-standing glaucomas, traumatic glaucomas, iris where the iris is entirely knocked off, there's a dialysis, pupillary sphincter tears, ciliary body ruptures, the lens getting dislocated, lodged into the vitreous, optic nerve avulsions, vitreous hemorrhages, choroidal tears, and even retinal detachments. The whole spectrum is covered with trauma. There are long-term consequences like traumatic glaucoma, optic neuropathy like they threw light upon before. Now general guidelines when you see a patient with this kind of a trauma: avoid unnecessary manipulation to the globe, avoid tonometry because you don't know if the eye is totally punctured. Get appropriate and adequate imaging done because you don't know what's happening at the back. It may look very minor, but there may be an intraocular foreign body, or there may be something at the back which you may be missing. Give them analgesics and antiemetics. You don't want them going in for a retching or a Valsalva's maneuver. That's going to make things worse. Cover them adequately with prophylactic antibiotics because we don't want endophthalmitis. We will always try to salvage the eye. And do an emergency lateral canthotomy if you're thinking it's a retrobulbar hematoma. Release the pressure there. Besides your ophthalmic care, they also need a lot of social support. So it's nice to build a support system. Towards this, I have an initiative which is with the Unite community. This was covered extensively in all the publications last month, where I support this campaign called No is No. So it's a campaign for domestic violence, and we run this. So we all should be aware of this, and yeah, that's all. Thank you.
Dr. Subudhi, can you please present a memento to Dr. Nikhil? And I invite Dr. Nitin Balkrishnan, the president of BOA, to deliver his talk.
ये निकाल दो.
So, Dr. Balkrishnan is going to talk about traumatic subluxated cataract.
Mirror display. Display. Mirror display.
किधर है? This one?
I think
Screen mirror.
Waiting for you to come, Dr. Robert. Dr. Robert, you were telling something about the domestic violence in your country. Do you get something domestic violence?
So we, of course, as everywhere, we have law in Poland. If I suspect or if there is evidence about domestic violence, as a doctor, I should inform police about it. I don't know if it is the same.
We do it here also. We do it here.
And of course, sometimes it is not easy to recognize because, for example, small child and the parents does not tell the truth about it. And I will present one case during my talk about it. So I remember one situation when the small girl was injured with like a wire by the sister, and the whole family totally tried to hidden this evidence. So there was also then a rupture of optic nerve avulsion, so really severe consequences.
Thank you.
Right. Thank you.
So Dr. Nitin Balakrishnan is a marathon runner and one of the best ophthalmologists of Mumbai, and he is the president of Bombay Ophthalmologists Association.
Good morning. I would like to thank Dr. Natarajan, Dr. Karobi, and the organizing committee for having me here. So this is a case which I would like to present of a 22-year-old boy who had an injury to the eye with a squash ball while learning to play squash. So he came to us with iridodialysis, a white fibrotic cataract. We started off with iris hooks to keep the iris away, and the cataract was stained with vision blue. Now, as you can see here, being a fibrotic cataract, it's very difficult to get an entry into the anterior capsule. So we've been trying, and in these cases, the patient also had a loss of about 120 degrees of the zonules. So a little bit of posterior pressure, and we made a small entry into the anterior capsule in an area which was not fibrotic, and then using a micro scissor and a micro forceps from MST, no financial interest. We made a small nick, and then in order to get a good counter pressure, because the zonules were weak on the opposite side, so in order to get a good counter pressure, the iris hooks were shifted to the opening in the anterior capsule. And now we go in with a micro utrata forceps. And as you can see, we are going in, but again, we feel that there is a need for more counter pressure. So we switched hands. We used
a two-handed technique where Utrata was used to give a counter pressure on the other side. It's very important in these cases while doing the rexes to see that you're going in the right direction, because it's very possible while pulling upon a fibrotic band to cause an extension into the periphery. So as you can see, we're going around, and towards the end of the rexes we realize again that we are in the fibrotic area. Now here you can see the pull on the capsule. We're trying to do the little maneuver to try and complete the rexes, but since it's not possible, finally I decided to go ahead and with a micro scissor and amputate that end. Just amputate that end of the anterior capsule to get a continuous round rexus. It may not be a perfect circle, but it at least salvaged the zonules. The cataract in this case was pretty soft, but there's always a fear that the posterior capsule also could be open. Unfortunately for us, that was not the case. And being a soft cataract, only an aspiration without any phaco energy was sufficient to get the cataractous material out. Staining these cases with trypan blue is a little dicey, because very often you have the vision, the trypan blue going into the posterior chamber and staining the vitreous. This gets absorbed within the next few days, but then surgery after this becomes very difficult because the red glow cannot be appreciated. So having done a good cortical cleanup, we realized that the zonular loss was about 120 degrees, so a CTR was sufficient. We didn't feel the need for implanting a sutured CTS. So this was a preloaded CTR. And having done this, a 3-piece acrylic IOL was implanted into the bag. We can see I could see the inferior haptic below the area in the iris opening. Now I decided to turn the microscope by 90 degrees and come to the head end of the patient in order to address the iridodialysis. So we start off by taking 3 mattress sutures to suture the iris to the sclera. Here it's very important to know that when you are holding this iris, the iris could be very often atrophic because of lack of blood supply over a prolonged period of time, because this injury was almost about 6 months old. So we are taking the mattress sutures. Again, the plane of the scleral suturing is very important. If you go too anterior, you will damage the trabecular meshwork, and Preeti will curse me for that. And if you go too posterior, you will cause a hemorrhage, and further surgery becomes difficult. So the knots are tied. Again, we are doing the second suturing again here. I try to hold the iris as far in the periphery as possible. And then the third mattress suture was taken to anchor the iridodialysis area to the sclera. Having done this, all the knots were tied and buried. So this was done by a railroading technique. And now we use the microforceps to try and tug upon the pupil, because this was a young patient. We didn't want traumatic mydriasis to be present. So we're trying to tug the iris, and we saw a V-shaped area over there. So we decided to close the pupillary opening with 2 mattress sutures. This was done by a slip knot. And having done this, we are again tugging upon the iris to try and get a circular pupil, which we thought we had achieved quite well on the table. So this was a case where post-operative, I'll show you the pre-operative and the post-operative pictures. So this was the pre-operative and the 1 week post-op, with the patient achieved a 6/12 vision unaided. Thank you. So the basic points which I would like to make here is,
remember that these fibrotic capsules there is a high risk of them running away to the periphery. You will further damage the zonules. One needs to assess the amount of zonular loss. If it is anything more than 120 degrees and you feel that the bag is not going to be stable, it's important to put in a sutured CTS segment in these cases also. And also remember that there could be a posterior capsular opening. So after having achieved a perfect rhexis, we normally are in a hurry, especially with a soft cataract, just to suck it out. But remember that there could be a posterior capsular opening, and that could be a catastrophe if you continue. Thank you.
Thank you, Nitin. And Nitin has created a group of ophthalmologists in the family. Yes, sir.
Yeah, I have a small question. The suture material which you use, is it absorbable one?
No, it was a 90 proline. It is not absorbable, but it is biodegradable. So over a period of time, it can get biodegraded, but the iris is sutured to the sclera. And because of the fibrosis which occurs over there.
Will the pupillary reflex differ in the operated eye and the left eye?
Yes, definitely.
Will differ.
Yeah, the patient usually has a sort of a not semi-dilated but a mid-dilated, sluggishly reacting or non-reacting pupil.
Thank you, Dr. Balkrishnan. May I request Nikhil? Nikhil, can you please present a memento to sir, please?
Yes. Robert, you want to comment on the surgery? Dr. Nitin is a great cataract surgeon. About his cataract, traumatic cataract.
It's a wonderful surgery.
So should I announce next speaker or?
She can next. You can invite the next.
So now we would like to invite Dr. Smith Bavaria with the presentation Glut IOL in a Traumatic Cataract.
Thank you, Dr. Albert. First of all, thank you, my guru, Dr. Natarajan sir and Karobi madam for the opportunity today. When you are working in Aditya Jyot, you don't have to only raise the standards in retina. We have to be raising the standard in anterior segments every day because we get a lot of complex cases every day in and out. Today, I'll just show a short video of a traumatic cataract, how to manage with the glued IOL. Nitin sir has already raised the bar, so it's difficult to match that bar. So this is the case, 72-year-old female, history of blunt trauma, 1 year back. And I'll just start the video. So I always want that, a lot of residents, also doctors are there, young doctors are also here. So, we always fantasizing for the phaco surgery. We want to learn the phaco surgery faster and faster. But the SICS is also actually very important because when you see certain complex cases, this is the savior. Sometimes you want to do lot of cases. We see lot of videos in the conference, YouTube's, everywhere. But this is what I always feel that the SICS is the savior in certain cases. So I made a good 6 mm, 7 mm tunnel. I created the flaps 180 degree apart. I will try my best to do whether the phaco is possible or not, but I was sure that looking at the dialysis of the zonules, it won't be possible. So now I'm creating a flap similar as a trabecular flap by 2 by 2 millimeter. I create 2 side ports to make sure that my handshakes when I'm doing the glued IOL is easier. After creating the flaps, I tried to do rhexis. I wanted to give a try whether I can do a phaco or not with possible CTS segments and everything. But looking at the zonules, it was like impossible to create a rhexis. I tried to do all my possible ways. I also used the MST scissors also. But then I realized it's not going to help. So finally I just thought of opening the wound and go back to the basic, back to the residency where we used to do the Vectis assisted cataract extraction.
Yeah, this is just the same posterior trocar I am using as an anterior trocar, just to maintain the fluid level, because when I am planning a gluteal surgery is always based on the fluids, not the viscoelastics. This is the basic of removing the cataract from the eye. I did the vitrectomy after that in an anterior chamber. Now I am using the fluid inside the eye, because if I use the fluid before, it can affect the let's say the anterior vitreous phase more while doing the vectis removal. So I went behind, did the vitrectomy, remaining the lens matter and the capsular part also I removed. Make sure that the whole anterior vitrectomy is done completely well. We have to make sure there is no strands hanging in the anterior chamber before planning to put the lens inside the eye. After doing the thorough vitrectomy, I use my MST forceps. This is very simple when we are doing the SICS assisted glute IOL, so that we have a big enough wound, and just the tip of the haptic we have to catch. Because the fluid is on, you will have a lot of difficulty. The lens will pluck out many times. Then you can use your other hand to just pull it inside, push it inside. Do not remove the first haptic until and unless the optic is completely inside the eye. This is the one basic thing we have to remember while we do the glute IOL. After the optic is inside, I pull out my first haptic outside the flap. At the same time, my assistant will help me to hold that haptic, and I will use the handshake technique again to put the another haptic inside the eye, and the lens will be externalized both sides. So this is the simplest way to do the glute IOL. We can do it with the phaco incision as well, but as I was doing SICS, it became easier for me. We create a Gabot-Steritz tunnel and then put the haptic inside, and then you can see we did the same entire surgery without taking a single suture. So this is what I always do when I have this kind of traumatic cataract. Okay. The key home message is, I always tell that SICS is very important tool when we are doing anterior segment surgeries. Second thing is, glute IOL is a simple method. As an anterior segment, we have to learn at least one technique which can save us, and we can make sure that the patient doesn't have to go through a complete vitrectomy. Either way of doing iris claw or suture fixation IOL, either Yamane or glute IOL. So my experience with the glute IOL is very long. I mean, it goes long back, since like 10 years I am doing with, Amar sir taught me himself, so I'm very confident in glute IOL, so I just keep doing the glute IOL day and out at Aditya Jyot. Thank you.
So,
thank you, Smith.
Robert, you want to comment on this glute IOL? Yesterday you were saying.
So congratulations, a really interesting case, and up to now this is still the technique we should introduce in Lublin. So we use as a standard Yamane technique and also Carlevale lens. Carlevale lens is quite popular. It comes from Italy, so in Europe. But yes, very, very nice approach. Congratulations.
Yeah. Only difference between the over a period of 10-15 years, that only the tilt is very less when we have a 100% 180 degree externalization of the haptic. So the tilt will be very minimal with the glute IOL. That's the only advantage. Then every surgeon to surgeon it gets preferred.
Yes. Smith, what's your view about using an posterior iris claw in these cases, or you'd prefer?
To be very honest, I have not tried, because this is the training I got. So what you learn during your residency and the immediate post-residency, you keep following that for a period of time.
For lesser mortals like us, I think the posterior iris claw works much faster and better, because...
Yes. Yeah. If in a good hand, it is very smooth surgery as well.
Thank you, Dr. Smith.
What type of glue you are using?
It's a fibrin glue, human fibrin glue.
Fibrin glue?
Yes.
But what advantage do you find over versus not suturing and leaving it like that? Because ordinarily people used to leave scleral wounds open for a while.
As such, it doesn't need suturing. Because haptic we are putting inside the tunnel, creating inside the...
Yes, correct.
So, haptic will be stable without any support. The flaps what we have created, it can be easily opposed with the, with the glue. So there is no need for suture. If there is a thickness or any other issue in that creating the flap, then we might need a suture. There is no harm in taking suture, but like we create SICS tunnels every day and out, and we don't take sutures every time. So flaps can be opposed with the glue itself.
Thank you. Can I ask Dr. Subudhi to present the memento to
So there are a
Dr.
lot of
Smith?
postgraduates here, no? Purva, where is Purva? Where are the JJ students? Any questions from JJ students?
In the meantime, I invite Dr. Robert to give his keynote address on the management of severe ocular trauma in the hands of a vitreoretinal surgeon.
Can you?
Can you connect my laptop? So, again, I would like to thank Professor Natarajan for inviting me here. He asked me to summarize our experience in treating severe ocular trauma cases. Together with Professor Cesare Forlini, who unfortunately passed away, and some group of experts, we tried to introduce new methods into our everyday routine, and I will try to present you today what we have done since last decade, also how to prevent severe and chronic complications after ocular trauma. So this is my hospital. This is one of the biggest eye hospital in Poland, consisting with 3 buildings. This palace is under renovation, will be soon, probably in April, will be ready, open and back to function. And managing ocular trauma, we should of course focus on primary surgery, but our goal should be to prevent endophthalmitis, because of course this is the main risk, especially penetrating ocular trauma, all wounds or presence of intraocular body. So it's really the big threat of endophthalmitis, which is a devastating pathology. Also, as we have heard today, glaucoma is a big issue, very important pathology to be treated and to be avoided as well. So there is always specific spectrum of damage. We should examine carefully the eye globe, checking what kind of trauma it is. We already have heard about classification. So blunt trauma normally causes, may cause many consequences. So cataract, post-traumatic cataract, oral tears, or retinal detachment. And so sometimes we should really work on strategy, specific strategy, how to treat the patient. On the left side, we can see subluxated cataract and vitreous hemorrhage. So my colleague, Dr. Hash, decided to perform first cataract surgery because we couldn't see any retinal break, any retinal detachment.
So we can see cataract surgery with reconstruction of the pupil. And on the right side, we can see a combined phaco-vitrectomy because of retinal detachment. So the first surgery was quite complicated, as you can see. Iris hooks are used to stabilize the capsule, to finish the phacoemulsification. Also, CTR was used, and the case is finished with implantation of 3-piece IOL. Then there is a reconstruction of the pupil. On the right side, it's a standard phaco-vitrectomy with gas tamponade. Then we have heard today about strategy about lens subluxation and luxation. I would like to present standard technique at our department, Yamane, IOL fixation after a blunt trauma. We start from vitrectomy because of dropped nucleus. So normally I am using handshake technique by manual surgery to remove lens material. Of course, if it is stone hard, I elevate the nucleus to the anterior chamber using Decalin bubble and perform phacoemulsification in the anterior chamber. It is much faster than endophacophragmatome, but it depends on the experience of the surgeon. Then we perform Yamane technique. As I mentioned, we have in Lublin also Carlevale, and also iris claw. Artisan IOLs are really popular, especially if we combine the case with, for example, silicone oil tamponade. But depending on the conditions, on the decision of the surgeon. Also, Canabrava technique is becoming more and more popular in Poland. Of course, how to prevent endophthalmitis and to plan your surgery, especially if you have a wound, corneal wound. So optimal wound surgery is really necessary. Normally we use Rosey-Hayes technique to close corneal wound. Also to have really the best possible visibility if we have to continue with vitrectomy. So also to, let's say, reduce the post-operative astigmatism. Especially in cases when we plan vitrectomy, this is really very useful technique. So stitches are shorter to the center, and we of course hide the knots intracorneally to reduce edema and to speed up healing of the wound. And in such cases, we may continue even with vitrectomy next day. But the most important is to rule out presence of intraocular foreign body, and the best technique is CT scan. Is the best method we've got with less than 1.5 millimeters. And we normally, as an addition, always use ultrasound. Be gentle, especially if there is a wound in the sclera or cornea. Don't press the eye globe. And of course, it is a tricky wood, vegetable matter, only intermediately reflective, or you cannot find them. Also, blood can resemble vitritis, or so normally we always, as a standard, send the patient to radiology department for CT scan. And UBM might be helpful, especially in detecting small intraocular foreign bodies, especially nearby the sclera. We can find if they are inside the eye or outside. And of course, endophthalmitis has its own dynamics. We know, we all know symptoms, but anyhow, it is an emergency, normally caused by gram-positive bacteria. Gram-negative are much more virulent, and still 1/3 of results are culture negative, but PCR is really the crucial method. This is the technique. Normally we admit the patient, and if there is a early stage, we may consider vitreous tap and intravitreal antibiotics. We take specimen for bacteriological examination, but if there is a progression, we start vitrectomy. Also, as we assess patient and we see red reflex, and let's say it's a good visual acuity, first we perform vitreous tap and intravitreal antibiotics, and we observe the patient every hour in upright position. In case of progression, we indicate vitrectomy, but in general, in our hands, so our rule is early and complete vitrectomy as a primary line of endophthalmitis therapy. So early means 6 hours, and I also try to induce PVD. Despite retina is necrotic, so I try to avoid necrotic areas. We participate in many studies. We published so far some reports about it. I would like to show you some cases. So, this is a very special case of young man. He was sent from another hospital to us because our colleagues couldn't remove metallic foreign body, and probably they even pushed it into the angle. So then I performed cataract surgery because of early stages of siderosis, and then I could, using this gonio lens, I could find in the angle there is metallic foreign body. So also cataract surgery helped me to make it to widen the angle and to make it without any hemorrhage. This is another case, a young patient with intraocular foreign body, but the wound is in the cornea, in the lens. So I decided to perform cataract surgery. In such cases, I start immediately from using vitreous cutter, not faculty, not to aspirate vitreous. So in this case, I could even implant IOL into capsular bag. And then I continued the surgery with 25 gauge system, and you see metallic intraocular foreign body on the macula. In this case, I create additional sclerotomy to use bigger forceps, so enough to remove foreign body. Because I avoid to remove trocar, because of course we will continue vitrectomy later on. Chandelier light, and so sclerotomy, 20 gauge forceps by manual technique. I always use Decaline to protect macula. against iatrogenic damage, and using by manual technique we can remove so gently without problems this metallic foreign body. After removing foreign body, we put stitches on the sclerotomy, we close the wound, and we continue vitrectomy, inducing PVD. In young patients, sometimes it is difficult, so I'm using peak. I make peak from needle, 25 gauge needle, to start PVD in high magnification, and then we continue complete vitrectomy. So you see here we can start gently PVD, and then we continue, we remove vitreous, incarcerated vitreous from the wound, and then use laser, and this was gas tamponade. The result was full vision after this surgery. And now I would like to show you this special case of 6-year-old girl. She was, and it was really mysterious, let's say, conditions why she was injured. So it was probably like domestic violence. And you see here, this is the surgery. My colleagues referred this patient from another hospital because they decided to enucleate the eye. This is the plastic band, and behind the iris is a metallic buckle, blocking totally, like with harpooning effect. I couldn't remove this giant intraocular foreign body. So I decided, checking the position, because I had a second part of this plastic band with buckle, so I could imagine how it might be positioned behind the iris, and I decided to use a so-called T-shaped sclerotomy to remove this giant foreign body. So exactly where the metallic intraocular foreign body should be, we created, so in pars plana, sclerotomy, and because the big size of this object, we create T-shape incision, and you see we could easily remove this foreign body. So this is 6-year-old child, yes. Then we closed, thank you very much, we closed sclerotomy, and of course removing vitreous, being really careful. I performed like anterior vitrectomy, removing all lens material, and I decided then, of course, closing corneal wound to stop. And it was really good decision, and fortunately for the patient, afterwards there was no retinal detachment, so vitreous hemorrhage resolved. So then next steps were we implanted IOL, and we still have this corneal scar. But the girl, first of all, we saved the eye globe. She could continue education, so also, of course, There was no problem with development of the face. So it was filmed. We performed multi-center study on this technique on 30 patients. Publishing this paper, and now continuing on other cases. I would like to show you also this case with a giant metallic foreign body. So it really works. It can help you to remove giant foreign body with sharp edges. So not only saving the eye globe, but also function. This is another patient and a short fragment of the surgery. Of course, depending on the case, you can use many approaches. Also, quite often I use corneal incision to remove the foreign body through corneal tunnel, just depending on its shape. So like here, it's really huge. But I can tell that the school comes from Mumbai and Professor Natarajan, because of his visits and discussions, we develop all of these techniques together, like here. So this is crucial moment, again, to remove, but not to induce damage, additional damage. And sometimes you may also, you see how big it was and sharp. Yes, so this is the patient, happy patient under follow-up. And finally, I would like to show you my first experience with Siluma, a digital microscope of Bausch & Lomb. I am advisor of Bausch & Lomb. Even in 2 weeks I go to Munich, because now Siluma has intraoperative OCT, and I will test on a wet lab how it works. And here is again a trauma patient. So I would like to refer to a very interesting lecture about protective glasses. So again, yes, it should be really controlled what glasses you use, because not every glasses are proper. And in this case, there is a huge, again, giant intraocular foreign body, but like a part of the metallic wire. So fortunately for the patient, after cataract surgery and vitreous prolapse, as you can see, I opened infusion, and this wire was hanging in the vitreous. So I decided to, because first it was not easy to remove, but then I found the way, just the paracentesis of cataract, and I could just find how to remove it through paracentesis. So no additional damage to the eye globe, like this. Quite tricky. And then we, of course, continued vitrectomy, complete vitrectomy. So this is, yes, the moment that surgeons, the moment can be emotional, but after a while you remove and you continue vitrectomy. So this orange, so I have no commercial interest, but this is a new vitreous dye, so instead of triamcinolone. You can use of Bausch & Lomb, and we continue vitrectomy. For young doctors, for trainees, I would like to stress how important it is to clean all vitreous from anterior chamber staining, then you go to the posterior segment, corvitrectomy, and also quite tricky in ocular trauma patients is PVD, like here, because it's very elastic with young patients. So you should really be careful to make it properly. So in this case, I could just aspirate vitreous along borders of optic disc, and then we continue with vitrectomy to the periphery. And in this case, so this is TV, and 6 months after surgery, visual acuity 0.7. I will only show the patient because quite new was this digital microscope, so TV showed. We were first in the world using it after Munich and Paris was Lublin. This is the patient, happy patient. So don't wait, refer the patient and treat the patient immediately to avoid really severe cases of endophthalmitis. We also use Landers Folks keratoprosthesis, but of course if it would be early enough it wouldn't be necessary. Sometimes obtaining quite good results. So primary line of treatment for the vast majority of eyes with endophthalmitis should be complete and early vitrectomy. Normally we use vancomycin in infusion fluid, low concentration, and ceftazidime, and if appropriate voriconazole if we have fungal infection. Thank you very much for your attention.
So thank you, Robert, for coming and sharing your experience. And I thought I've done the maximum number of traumas in the world, but I learned something new yesterday. You showed me this video, a T-shaped incision, because I always make a long circumferential incision and you end up in retinal dialysis, even though you do a basic. It's a wonderful technique, and there are a lot of residents have come here and watching in the YouTube. So I think we should ask for volunteer residents to join us online to publish, because I have some 1,000 videos or more than that not written up. My colleagues are not having time. So maybe the Polish residents can come here and write it for me. I hope the Sion Medical College and JJ can take it up, because there are a lot of videos to be taught to the world. Even in Kashmir, we have got 1,000 patients video. So I have 1 TB of video which I myself don't have time to see it again. But I think we have to see those and improve the technology. So that's the old building which he has, which is the Trauma Institute for last 50 years. So it's a beautiful city, and I love to go in -20 there for a few hours.
So I am impressed what I have seen in Mumbai, what Professor Natarajan presented me, university department, also concept
he's the dean.
So congratulations, congratulations. Concept of creating training center for young surgeons, and also speed up publishing. So we are very open, so we collaborate since 15 years already, and I would be happy to strengthen collaboration.
So you and Prof. Evanman and me, we did one full journal on Journal of Ophthalmology.
Yes.
So I think we keep doing that.
Exactly.
So I think already we are a little delayed. We'll start the inauguration. So Joseph, can you put the chair straight? Jyoti, you can start. Mayur? Yeah.
Excellent lecture, sir. We really learned something. Beautiful. All the videos are so excellent.
Yes, sir.
Yes, yes. You have to just show that.
Yes, yes.
Sam. Sam.
Yes, please.
इसलिए कल बोला था आपने नहीं जलाए
Hello everybody. Before we start the inauguration, there is a small task which I'd like to do. This is Dr. T.P. Lane, whom you'll all know very well. And as you know, he's standing for the Vice President's post for the All India. A sincere request to all present over here to please vote for him in huge numbers and motivate your friends also to do the same. Thank you so much. He was supposed to be here in person, but he's got held up because of something. So I'm making the personal vote appeal for him on his behalf. Thank you.
Hello. इनॉग्रेशन स्लाइड CME का डाल देना. Good afternoon, everyone. Good afternoon, everyone. It is my honor to welcome you all to this momentous occasion as we gather for the 98th birth anniversary celebration of Professor Dr. N.S. Sundaram and the CME on ophthalmic trauma and polytrauma. I am Jyoti Gupta, your host for today's event. On behalf of the organizers, I extend a warm welcome to all our esteemed guests, dignitaries, and participants. Let us begin this program with a moment of peace and positivity. I request Samir sir to play Saraswati Vandana. Ladies and gentlemen, please rise for the prayer.
इधर साइड
करा या श्वेत पद्मासना या ब्रह्माच्युत शंकर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा.
I may like to invite our guests and dignitaries on the stage, please. You can take your seats, everyone. Thank you. Thank you so much.
I would like to invite Dr. Mohan Joshi sir on the stage, Dr. Nitin Balakrishnan sir on the stage, Professor Dr. S. Natarajan, Dr. Robert Resdak, and Dr. Karobi Larry ma'am. Thank you for the serene beginning. Thank you for the serene beginning. Lighting the lamp symbolizes the dispelling of darkness and the spreading of knowledge. I now invite all the dignitaries on the stage for the ceremonial lighting of lamp. May I request everyone to kindly join in applause as they proceed? Thank you, dignitaries. Moving forward, I invite Padma Shri Professor Dr. S. Natarajan to introduce our esteemed guest of honor. The stage is yours, sir.
So it's a great pleasure to have Dr. Mohan Joshi with us. He's a well-known gastroenterologist with a laparoscopic surgeon, and I was happy that he's taking keen interest in generally medical education and in particular now ophthalmology, because I think because of his daughter who's a vitreoretinal surgeon from Shankar Nethralaya. And I'm happy he is always inquisitive, he asks questions, which is what we need, and he's a great teacher. And I think, as I told when he entered, that one of the best deans I have met, because I'm working with the Bombay Municipal Corporation for several years. I have a lot of arguments with them because the executive health officer has their own plan and idea, and I have some plan for making Mumbai blind free. We are working with them in the screening of diabetic retinopathy with the F, G and M ward. That's what we have signed an MOU, but I want to do for all the 199 Apla Davakana. So I am working with Ratan Tata Foundation to get 199 cameras for BMC. So I hope we'll succeed. Dr. Robert Redak's post-lunch talk is on teleophthalmology for diabetic retinopathy. So thank you, sir, for being here. We welcome you to today. You are our chief guest, and we have Dr. Robert Redak, who's the main speaker of the whole program. I know, even though the audience is less, but people are watching world over, and it will be there in the net forever. And we are on 2 platforms, the YouTube as well as the Doc Plexus, which is open for 200,000 medical professionals in India and world over. And thank you, Robert. And Robert is an excellent vitreoretinal surgeon and a cataract surgeon. He, my friend Dr. late Cesare Forlini, and the other guy, Dr. Thanasis Nikolakopoulos from Greece, and also Professor Arne Vicentes, who is the president of International Society of Ocular Trauma. Fortunately, Dr. Arne Vicentes visited us as a resident for our conference in 2007 in Mumbai that time. And Dr. Ferenc Kuhn has come in to 1997 when Dr. Shanta Motwani was the head of the Department of Sion Medical College. We did a major conference of 4th International Society of Ocular Trauma in Nehru Center, and now this time we are doing as a CME in nehrusciencecenter. So thank you, Robert, for all your support. So it's even though I love to go and teach there, but I learn whenever I go to Lublin, and they don't speak English, the staff, the nurses, the secretary, but they are so wonderful to assist me whenever I go, and thanks for all your hospitality. It is only a little we are doing for you, but I'm happy Dr. Mohan Joshi will, during his talk, he will say something about our collaboration. And I'm happy we have the president of Bombay Ophthalmological Association, the dynamic Nitin Balakrishnan. He's a marathon runner. Plus, I think he's a wonderful human being. And I thanked him because I didn't even call him once, and he's here. Thank you very much, Nitin, for having. And finally, the entire backbone of the scientific program, thanks to Dr. Kerobi Lady. So I balance her in dance, and she balances me in the scientific committee. Thank you, Kerobi.
Thank you, Dr. Natarajan, sir. Now, I request Dr. Karobi ma'am, the driving force behind this initiative, to share insights about the trauma CME.
Thank you, Jyoti. At the outset, let me welcome all you people over here, the speakers, the faculty, the delegates, and the invitees who have been invited to hear these talks. In fact, the thing is that I just came to know from Sunil Morekar that what we term as a CME, we have called this a CME, but this is not a CME, this is what is called as a CPD, which was news to me. What is a CPD? It is continuing professional development, and it focuses on risk management, health and health economics, managerial education, which includes counseling and medico-legal issues, and media communication. And all of these are what is present in our today's CME. So this is a CPD, which is one level higher than a CME. So welcome to it. Now, we all know that trauma is a burning topic where the thing is that where an eye is concerned, it is a vital sense, so it causes a loss of quality of life if anything happens to it. And if this is coupled with polytrauma, it adds another dimension because the risks and whatever you have to do for it much extends whatever you might have to do for an eye singly. Today we are here to sort of focus on certain critical areas, that is the immediate and the long-term management of ocular injuries, the implications of polytrauma on systemic recovery, the intersection of innovation and clinical practice in trauma care. With advancements in diagnostics, surgical techniques, and rehabilitation strategies, this CPD provides an excellent platform to gain insights and improve patient outcomes. The sessions are going to be enriching, as you have already seen from the past two sessions, and we have some of the finest minds and leaders in trauma care who will share their knowledge and experience, which also you have experienced till now with the current topics which were discussed. From discussions of managing traumatic globe injuries and orbital fractures to addressing systemic challenges in polytrauma cases, we aim to cover a broad spectrum of topics that are critical to managing modern trauma management. I express my gratitude and thanks to Dr. Natarajan and his supporting team for bearing with me when I was strict with them and also helping me craft this program out. And I hope this will, for all the participants, it will prioritize continued education, collaboration, and skill enhancement. Your commitment to learning is truly commendable, and I thank you all for it, because without you, this wouldn't have been a success. Thank you so much.
Thank you, Dr. Karobi ma'am, for that inspiring introduction. We now proceed to the official inauguration of the CME. As a token of our respect and gratitude, we will now honor our guest of honor. I invite Professor Dr. S. Natarajan and Dr. Karobi Lahiri ma'am to do the honors. Next story. नहीं ऐसे देखिए
We'll stay at least. Yes, sir. The light is the will can be. Yes, sir. So yes. Is it? This is viewer. So you represent everything. I hope you'll plan it. Sure. Don't give to girlfriend. Sir, you won't give yellow to girlfriend.
Moving forward, it's time to hear from our distinguished speakers. May I first invite Dr. Mohan Joshi sir to share his insights. Sir, please.
Professor Natarajan, who's actually the third generation ophthalmic surgeon and ophthalmologist in his family. Dr. Balkrishnan, who's the president of Bombay Ophthalmic Society. Professor Robert, who's coming all the way from Poland. Dr. Chaya Shinde, our professor and head department of ophthalmology. Dr. Johari, who used to come and organize programs in Sion in the past from Bombay Ophthalmic Society. Dr. Karobi Lahiri, and our own student, past student, and our colleague, Dr. Vaidya. It gives me immense pleasure to be here. I am a surgeon. I don't know why Professor Natarajan called me. I am not an ophthalmologist, but I know a little bit about ophthalmology because during my studentship, I was a Rotary student. Rotary scholar. I used to get some regular scholarships from Rotary Club. And one of the project which Rotary Kalyan Club used to arrange was to have multiple ophthalmic camps. And I used to go there during those times in 1982, 1984, 83. And I used to take the BP. I used to help the project, taking BP, giving antihypertensives, correcting urine and checking for diabetes. And I have at least witnessed more than 500 to 750 surgeries at various places which I used to curiously observe. But that time it was a very simple way of doing cataract. They never used to use microscope. And if the vision came, then it was God's grace. Next week, third week, we would give spectacles. There was no question of intraocular lens. There was no question of suturing the cornea. Sometimes even, they used to leave it corneoscleral junction open. So that was the state of affairs. And if you don't get vision, you don't have to blame the ophthalmologist. Your padda is bad, means retina is bad. Retina is detached, retina is atrophic, retina has got retinopathy. So nobody bothered. If you get vision, it was a good thing. As a general surgeon, so maybe I know a little bit about ophthalmology. As a general surgeon, my professor used to say that doing cataract, because cataracts used to be done by general surgeons then, and he used to say that doing cataract is easy because result need not be guaranteed. But the things are now changing. Things are now changing. Ophthalmic trauma is truly a neglected subject in the country as well as all over the world. We would see, even in 1986, we would see a dilated pupil, somewhere fractures of the orbit, needing optic nerve decompression. Sometimes somebody used to do it, ENT surgeons, they would do transethmoidal, etc. And if ophthalmic trauma is there, you just put in a torch again and see if there is a vision, it's okay, God's grace. If there is no vision, it is unlikely that anybody would aggressively do something, examine the eye under slit lamp or do something, plan something in emergency. It was ophthalmic trauma, it was ignored in the past, and it is probably ignored because the trauma is something which is an emergency. You need to attend it immediately, and everybody is ordinarily reluctant because to go at middle of the night and see an eye injury is not really appreciated by many people. So therefore they would not take ophthalmologic trauma as their first choice. But now the interventions, the investigations, the more preciseness of deciding the injury and treating the injury has increased significantly, and this is probably a most appropriate topic which Professor Natarajan has chosen, and he has invited somebody who is a global leader in ophthalmic trauma, and having a special hospital for ophthalmic trauma is something which is great. So this will help in regaining vision of the Indian citizens where probably trauma is extremely common. That trauma may be because of accidents, that trauma may be because of household violence, that trauma may be because of chemical things. The unsafety belt, is very high. In this country, the trauma patients of ophthalmology are going to be very high in this country, and therefore regaining vision is very important by appropriate intervention. And today's deliberations will take the residents to a new height of what is called as ophthalmic trauma. And this is a very focused symposium, and I appreciate the efforts of Professor Natarajan in selecting the topics, calling the specialized people who are doing this, how a traumatic cataract can be different, etc. It's very interesting to learn, and now the vitreous interventions have also increased. If you develop a vitreous hemorrhage, there was no way once upon a time, there was no way that you could treat and get the vision back if it happens. So I wish all the best for this symposium or whatever you call it as, CME or CPD, whatever you call it as, which is focused at ophthalmic trauma. I have been to Madras for some reason, and we have an annual oration in LTMM Medical College, which goes by the name of S.R. Thalwalkar, which started in 1986. And I have invited for the first time an ophthalmic surgeon who will talk, Professor Pramod Bhende, who will talk in our hospital on past, present and future of retinal surgery. He is a specialist, vitreoretinal specialist, and he deals with retinopathy, and he has taken a common topic which will be interesting to all ophthalmologists as well as to all the resident doctors. He is a professor in Sankar Netralaya. So Dr. Chaya and myself, we have invited him for the oration. The oration will be on 14 February at 11 o'clock in Physiology Lecture Hall. I would request all the members, if you could put a message in the Bombay Ophthalmology group. I would request all the members who are on the dais and off the dais and resident doctors to attend Pramod Bhende's oration on past, present and future of retina. Thank you so much. Thank you so much. I declare the CME open.
Thank you, Dr. Mohan Joshi, sir. May I now invite Dr. Nitin Balakrishnan, sir, to address the gathering. Yeah.
Good afternoon, everyone. Today's gathering underscores the importance of collaboration and knowledge sharing in tackling one of the most critical challenges in ophthalmology. Ocular trauma, as we know, is a leading cause of visual impairment and blindness worldwide. It affects individuals across all age groups and walks of life, often leaving lasting physical and emotional impacts. Addressing these injuries requires not only advanced surgical skills, but a multidisciplinary approach. Let us remember that behind every case of ocular trauma, like we discussed in the morning, lies a story, a life that can be transformed by our expertise and dedication. And together, we have the power to create a future where fewer people endure the pain of vision loss due to trauma, and where those affected find hope and healing in our care. Thank you for your commitment, for having come and spent your Sunday morning and the remaining part of your Sunday to make this event a milestone one. Thank you.
Thank you, Dr. Nitin, sir. Finally, we have Dr. Robert Resdak, sir, to share his perspective. Sir, the stage is yours.
Respected Dean, respected ladies and gentlemen, it's my great honor and pleasure to participate in this ceremony. I'm very happy that we can share experience in a really such crucial aspect like of ocular surgery and ocular trauma. So this is really affecting young people, very active, so working, living with, so supporting families. And in one moment, ocular trauma may cause a tragedy, not only for one person, but also for the whole family. So that is why we should create the system how to act really quickly, really fast in such urgent situation. I have an honor to collaborate with Professor Natarajan over 15 years, and I would like to present you my center in Lublin, also in context of our collaboration. So this is my team in front of the building, which is under renovation now, but it will be ultra new building and eye hospital, serving also for ocular trauma patients. We collaborate with many organizations and institutions in Lublin. We created ESASO Lublin campus. ESASO is a European School for Advanced Studies in Ophthalmology, and since more than a decade in Lugano, I was a teacher, also Professor Natarajan visited our courses as a teacher in surgical retina. This is my team. So around altogether 36, 40 doctors, because additionally we have residents are working at my department. And this is my hospital, eye hospital consisting of 3 buildings. One of the biggest eye hospitals, so these buildings are only ophthalmology. The biggest in Poland. And this is my group of co-workers, collaborators in Poland and in the world. So we hope that together with Professor Natarajan we will also create new possibilities for young doctors in publishing, in getting training. So this is ESASO center, ESASO from Lugano, created medical at the Medical University of Lublin, ESASO campus. These are buildings of my campus in Lublin. So it's a university also with the biggest English division. More than 1,500 students are in Poland studying in English. In Lublin, in English. And this is a simulation center, virtual hospital devoted only for training, also in ophthalmology. Normally we organize wet labs, dry labs. It looks like this. Now I would like to show you again how my campus looks like. And also the second part of this video will be showing wet lab and dry lab, both in Lublin and in Lugano. So we have an organized system how to deliver training to young ophthalmologists. You see many machines, many microscopes, whole program, theoretical, practical program. In Lublin also we can provide live surgery sessions showing in practice how to perform surgeries, also in complicated cases. This is Lublin. This is my training center.
And this is example how we perform, how we organize training. Professor Natarajan was here, as you can see, during live surgery ESASO Retina Day. We had some moments of decorations. Department of Ophthalmology, Medical University of Lublin. We are honored and happy to collaborate with ESASO since many years. More than a decade, we have strong collaboration with Professor Guarnacha and his team here. ESASO campus is located at the simulation center of our medical university. It is a really modern building, and since some years we already organized here many courses, very attractive for ophthalmologists both from Poland but also from this part of Europe. We also start now clinical trials together with ESASO, so we are very grateful for this valuable collaboration.
I am Giuseppe Guarnacha. I am a medical doctor and the CEO and Chief Executive Office ESASO in Lugano. Today have a great meeting for live surgery and good and important professor Hansen Yuneman, Natarajan, Marek Renskas. Professor Leidak is a very strong director. I think Lublin will be success not only in Poland but in Europe and in the world.
So, as you can see, we are very active. We have a lot of activities, courses, congresses. Also, we collaborate across Europe. We are the only center in Poland as a member of European Reference Network for Rare Ophthalmic Diseases. And also, again, coming back, we created, I think 15 years ago already, a National Ocular Trauma Center at the Medical University of Lublin with great support of Professor Natarajan. And again, I would like to thank you, Professor Natarajan, for your great support, for supporting us.
Thank you, Robert, for collaboration and friendship, and I'm happy, and I think I visit maybe 20 times to Europe every year, yes. And Frankfurt is my favorite place, but I love Lublin. I was just telling, we enjoy the snow in Lublin, and I can't eat their food, so I go to a Chinese every day. So secretly I finish Chinese and then go for the palace dinner. But thank you very much, and we are very happy to have you. And I'm happy Dr. Mohan Joshi has told me that we'll make paperwork to have I know you are a part of us, but we'll have official paperwork happening, and you'll be a visiting professor in the Lokamanithan Medical College. And I also would like to make some best resident from here can come to, I'll find a sponsor to come to Lublin, but I want them to publish, otherwise I'm not going to recommend them. So we have
special programs to support students from Polish government, Ministry of Health, so we can apply for,
sure.
So it is possible.
Very good. So I'm trying to contact the Polish consul tomorrow. The previous consul was my friend. So I used to go for the consultant parties, but I'm not able to locate. I lost his number, but I'm going to call him tomorrow to the Sion Medical College. So we'll have a lot of, and I don't know whether you know, sir, the Maharashtra hosted the 5,000 Polish Jews when they were chased away in the 1945 after the World War in Russia. They went to several countries, finally landed up in Kolhapur. And there's a tower, not a tower, something like a obelisk, there's a memory created. And somebody was telling me yesterday that, pardon? Where? No, Gujarat also. But in Kolhapur, there is a place near, I forgot the name, there are Polish married Maharashtrians, and every year, last year the Polish external minister came. He went directly to, not to Mumbai also, he went directly to Kolhapur. I forgot the name of the town. It's near Kolhapur. And there is out of 5,000, they married few Maharashtrians, and there's a Polish-Maharashtra connection. Thank you very much.
If I may continue my presentation, because just to show the deed, what we are doing. Just a few slides.
Sure.
So we also, as I presented in the morning, help Ukrainian doctors and patients to get proper treatment. This is from my department. We treat such patients after severe ocular injuries, also using telemedicine, both to consult these patients, also to for follow-up. And another project is telemedicine in a pediatric ophthalmology. We use a special system to screen for refractive errors in school children. And finally, we use also telemedicine for early detection of diabetic retinopathy and diabetic macular edema. So this is our mobile system. We call it iBus. The mobile system, the van this is the van. Equipped with cameras, the van is going to small villages, screening diabetic patients. So I will speak later. We have also big project funded by Polish government. This is around 6 million euro only for digitalization and telemedicine. So thank you very much for your attention.
So we have a Secretary of Ophthalmic Society, Dr. Subudhi, and we will have a collaboration with our national society as well as Mumbai. Robert? We'll have a collaboration for. Yes. You have a lot of homework now.
Of course, we discussed already.
I said you have a lot of homework, no sleep.
Yes, exactly.
Thank you, Dr. Resdak sir, for your valuable words. As we conclude this enlightening session, I invite Dr. Smith Bavaria sir to express gratitude on behalf of all of us.
I know the lunch time is due, so I won't take much time. Thank you, first of all, Dr. Mohan Joshi sir, for gracing the occasion and your time. Thank you, Dr. Robert, for giving us so many different perspective of trauma management all the way from Poland. And we look forward for the more collaboration and associations with the medical colleges there and colleges here. I also thank Dr. Nitin sir for sparing his time for the occasion. The backbone behind the whole program today, Dr. Karobi Lahiri madam, thank you for all your efforts and time to create such kind of scientific fest. And at the last, the child behind the whole program, Dr. Natarajan, is my guru, my mentor, and I can certainly say that he lives his life day and night just to think how to treat patients, how to treat trauma. Whenever he is around, he talks about only how to manage the trauma, how to do better surgery. So one can say he has dedicated his life throughout just to give better eye care, and it's something that we all look up to. Thank you, sir, for such an inspiration to all of us. And also I would like to thank Mr. Joseph and his team for such a nice work behind this whole program. I also like to thank audiovisual team and all the support staff, the volunteers who have come across for this help, for the conduction of the program. And we'll see you again after the lunch. Thank you again.
Anyhow, so thank you, Jyoti. Jyoti is doing her clinical research, and we have a clinical research team sitting here. We have a 1.5 crore grant from Government of India, along with the 6 other institutes, about 10 crore. We hope to get some grants like that for Sion Hospital, and also with Poland. So right now it's 2:05. We request you to come back at 2:30. So the 2:40. Okay. So because it's a lot of people will be watching, so we'll have a break in the YouTube and Docplexes. Samir, you can let them know. So 2:40 we will assemble, and the program hope to finish by 4:40. So thank everybody, and I request all of you to come here for a group photo. Few can come on the stage, whoever can climb, young people, and one group can stand here. We can have a group photograph. Come. Come. Sir can come here, no? Need not climb. Sir can come here. Preeti, sir can come here. No, here. No need to climb, no? Sir, you can stay here. Joseph, you stay here. Rest of all of you come here. Please come. We'll have a quick group photograph. Jyoti, assemble everybody here. Some people can come on the stage. Few can come here. Few can come. So 2 rows we'll finish. All the volunteers also, please come. Correct, Valvadi. So the volunteers can probably sit down. The NSS volunteers from SIS and where else have come? SIS? And? SNDT University. Thanks for coming. So the volunteers can probably not kneel down, sit down. And some more can come behind now. Our social workers. So there are all social workers working in slums of Dharavi, sir. So we are creating a community of ophthalmology. And Sachin, join us here. Just now Dr. Robert spoke about C. Luma. Please come. So they are from Boston Lamy. He is the national head, come from Delhi. So he has given me a quotation for 5 crore. So I am getting a donor to buy that. And okay, we'll move forward. Yeah, come. Yeah, you can come here, Robert. Little. So, no, all of you come, no? And mobile में भी लेने का. इसका नाम क्या है भूल गया. Joseph, what is his name? हाँ? Not Rohit यार. Steven, एक मोबाइल में भी निकालने का. हाँ. क्या? Come forward. And don't leave it here. Come forward. So all can be in one line. No, all can be in one line. Robert, you come forward. Yeah, you can step. No, you can step. Yes. No. You can step forward. Come step. Okay, ready? Everybody smile, including the photographer. Photographer, थोड़ा लाभ होता है. Wait one more. Make 2 more. So all thumbs up, please. taught me this love. No. Some countries they
Yeah?
Yeah, they do this. No, it's bad or what? No, love. No. Symbol of love. No, this is symbol of love.
Okay.
चेक कर ले
एक मिनट हाँ
So you have connected after this
थोड़ा सा ना दिस इज थोड़ा सा लोगों को क्या है उसकी पुराने ज़माने के लोग हैं तो हमको ये सब में थोड़ा आदत होने में टाइम लगता है सुनो ना ये माउस हाँ आई एम साइनिंग इन माउस क्यों नहीं चल रहा
ऑन
क्यों नहीं चल रहा
विद
नहीं माउस नहीं चल रहा
So me you connected that point with this here
Yeah, of course it's all connected. अभी सुबह चेक करके आई हूँ मैं. It's all fine. अभी क्यों नहीं चल रहा? बैटरी वीक है क्या?
नहीं सही है
तो फिर
first you on turn on Bluetooth is what give me that Bluetooth is connected now okay can I connect to this
अब एक बार प्रेजेंटेशन चेक
wait me check
उधर वो स्लॉट है कि नीचे का है
check
पेनड्राइव किसका है?
pointer change
नहीं I don't want it because I'll change it myself with the mouse.
Okay connect हुआ ठीक है
सर शट इट डाउन
फर्स्ट सेशन आपका
इसके बाद में मैडम का है उसके बाद में मेरा डॉक्टर करोबी का है उसके बाद में मेरा
अच्छा ठीक है
तो अभी मैं बंद करूँ
हाँ बंद कर सकते हो रन कर सकते हो आप
तो कोई डिफिकल्टी नहीं आएगी ना
कोई डिफिकल्टी नहीं
ये माउस का मेरे को डर लग रहा है
माउस को टेंशन नहीं है चल जाएगा
निकाल दो
हाँ ठीक है
ऑलराइट बंद नहीं हुआ क्या
हाँ बंद हुआ
थैंक यू
Yeah, coming at this load my test. Okay.
Come here, man. फोकस करना समीर इसको चश्मा नहीं डाला दिखता नहीं है अरे फोकस किया
नहीं सर
Okay. She, the girl is laughing behind you. Joseph, you to her, na? अरे देना इसको फोन. She is laughing from behind because you can't see. I called her from the photo.
Polytrauma.
You are always flashy, sir. Thank you. Not for me, you. No? Yes. किसका फोन है? Yeah. Just check whether it's not from there. Joseph, you have done better. How have you come for lunch here? Finished here? नहीं, 20 मिनट तो आवाज़ आने का. I signed the next. सारा उर्मणी न रोज. And presentation you are already with them. Sumit, बात कर रहा है. Robert, yes sir, thank you. Joseph, yes sir.
How are you? I'm sorry, I said yes. Yeah, I'd like to.
I went to India because sir was always having patient from 84. Sir is having patients to be from 84. You know number
muscles, so when a baby is shaken, the delicate brain moves back and forth inside the skull.
Can you take Robert's back? Yeah. Robert, he is a senior most eye surgeon now. He is only 85 years. That's yes, sir. So he is the one who encouraged me from 1984. I was the youngest pediatric surgeon at the age of 27. And now I am 25. No, really, he encouraged me. Everybody was worried about Bombay, but he encouraged me. He was in the medical college. He was asking in Chembur. You have something dark.
नेक्स्ट में प्ले हो रहा है हाँ ये हो रहा है
सनी आप लोग खाना खाओ ना
ये भी हो रहा है
आप भी खाना खाने का ना ओके कर दोगे ना
काम में
करोगे
यार
टेबल में रखिएगा बेटर लगेगा
नहीं हो गया
सभी थोड़ा इधर रखे टेबल में रखिएगा बेटर लगेगा
So how are you? Yeah. Good. Your tensions are eased?
Not yet.
So I also realized, apart from all the financial implications, right now
the first speaker?
No sir, I'm just co-chair.
He's co-chair. He told me that I've got too many things on my mind. वो bottle दे देना. Excuse me.
Sir, one.
Sir, wait. वो bottle दे देना. अच्छा. नहीं, circle ही चाहिए था.
Bunch is like this.
Yes.
Yeah. And one was free outside. So go lunch for you. Actually, the things are just going quickly. So what will you do? You're going to sit here or you're going to come? I'll go and finish it here and come back because I'm the second. Are you okay? I'm good. Bye, sir. I'll see you later on the notes. What do you want to do?
इतना लागल ना दे अरे
पीडीएफ में कनेक्ट करें ना मैं दिखाता हूँ पहले जो चेंज करते हैं कुछ एडिट करना है इसमें क्योंकि ये ओपन होने के लिए गूगल साइड में ओपन हो रहा है बनना है डायरेक्ट सपोर्ट गूगल सेव पीडीएफ का ऑप्शन अप्लाई करेंगे राइट ट्रांसपेरेंट नॉर्मल तो पैसा आ रहा है चेक करता है
तो समीर तो छोटे ऐसा वाला पतला ले
कुछ दिखाने
काम हो जाएगा
क्या ठीक है आपने किसका बनाया ये जो टेप आप उसको लगा के सुनो हाँ इधर ये टेप लगाने के लिए टेप कहाँ रखा है उनके पास कैमरा
हेलो चेक
हाँ यहाँ पे उधर प्लान में अपना संभालना क्या कन्वर्ट होगा थोड़ा कन्वर्ट होगा आया डिस्प्ले आ रहा है और काम करो हाँ ये पैटर्न नहीं है बहुत ज़्यादा आ गई है कुछ कंटेंट रहता है अंदर जाता है थोड़ा आगे इधर सकते इधर आ सकता है देखो तो वॉच हाँ आई टी डॉट आ जाएगा आई टी आ जाएगा आई टी डॉट नहीं आई टी डॉट
हो गया
ये पैटर्न
अंदर ढकला
पैटर्न क्या हाँ
पैटर्न तो नहीं जाएगा लास्ट
जाएगा पैटर्न नहीं जा रहा है इसमें इसको ये इसको पीडीएफ फुल इसमें हो जाएगा स्लाइड हो जाएगा मैं बताता हूँ पीडीएफ में टर्म पीडीएफ ये ओपन हो जाएगा पीडीएफ फुल स्क्रीन आया ठीक है पीडीएफ फुल स्क्रीन आने के आफ्टर यहाँ एक व्यू रहता है व्यू ऑप्शन इसमें डिस्प्ले फुल ऑप्शन फुल कंट्रोल है ओके कंट्रोल है ये फुल स्क्रीन हो गया प्रेजेंटर भी हो गया इसमें प्रेजेंटर कहाँ पे है मैं चेक करता ओपन हो जाएगा बस इसमें कंटेंट एडिट नहीं होगा पीडीएफ में आप चेक कर लो कंटेंट हाँ हाँ ये रहा पॉइंटर, ठीक है काम कर रहा है। ओके
मुझे इधर स्क्रीन में दिखेगा।
हाँ स्क्रीन इधर से स्पीक कर सकते हैं, फिर लैपटॉप चाहिए आपको लैपटॉप दे सकता हूँ,
लैपटॉप दे दीजिए
चलेगा।
मेरा लैपटॉप थोड़ी देर के बाद
ठीक है।
थोड़ा उठाए ना बहुत अच्छा है। उसको पहले ठीक है ना, उसको कोई बहुत भारी है वो कांच की खराब नहीं होनी चाहिए। पीछे नहीं है हल्का से ऊपर उठाए तो बहुत अच्छा है। नहीं आपका वीडियो प्ले हो रहा था ना, इसमें नहीं होता आपके इसमें हो रहा प्ले। हाँ पक्का देखो,
लेकिन वो पाथ देना पड़ता है, एम्बेडेड वाला नहीं होता है।
आप में होता ना,
मेरा भी नहीं चल रहा था।
अच्छा कौन सा है वो देखो, जो सबका फास्ट है वो देखो।
नहीं दूसरा किसी का प्रेजेंटेशन में वीडियो था क्या, तो अभी जिसका रिसेंटली हुआ स्मिथ का तो अपन ने डाल दिया, इसके लिए चल रहा था। तो पहले किसी ने प्ले किया क्या सारी
कैसे जाएंगे,
खाना नहीं खाया,
जाएंगे कैसे काम
तो इधर ला सकते, इधर ला सकते क्या बोलते लेकिन सर शाम को ये लगेगा अपने को वीडियो प्ले करने में नहीं, वो मेरे साथ वीडियो दिया
ये रहेगा,
कैसे प्ले होगा
ये रहेगा। कोई इसके पास लैपटॉप नहीं लाया, उसको स्क्रीन देखना, उसके लिए मैं बोल रहा हूँ।
तो लेकिन इससे कनेक्टेड नहीं रहेगा ना, प्ले कर देगा
वायरलेस नहीं पाँच और चाहिए नहीं चाहिए। हाँ जिसने नहीं लाया उनको स्क्रीन देखना है, वो मैडम बोल रही है।
लेकिन वो
अभी सर ये लो प्लीज अभी रखे अभी हाँ इधर आप लोग उस टाइम मैं फंस जाएंगे। और ये भी कॉपी कर, ये भी अंदर कॉपी कर।
What are your children doing? What are your children doing? Digro degree શું કરે છે? બેસો ને નહીં સર તમે બેસો પ્લીઝ।
मुझे सिर्फ ये चेक करना है कि लैपटॉप से आपका लैपटॉप सपोर्ट करता है कि वो हो गया, हाँ हो गया, बाकी और कुछ नहीं करना है कि नहीं। वो अगर हो गया तो हो गया, उसका काम खत्म हो गया टीवी का। और ये काम खत्म करते हम लोग, बहुत ज़्यादा ही कॉम्प्लिकेटेड प्रोग्राम है, इसमें इतना कम मतलब बोले।
ये इसमें वीडियो डाला है देखो पॉलीट्रोमा में ना, तो ये प्ले करूँ क्या ऑनलाइन?
ऑनलाइन बहुत देर किसी में लैग करता है, इतना बिग साइज का
50 को
नहीं आएगा, सर्वर से हमें बहुत आने नेटवर्क से तो प्ले कर रहे हो ना।
तो पहला वाला मिक्सर का
मुझे इसको रिस्टार्ट भी करना है, रिस्टार्ट
करने के बाद ऑडियो चेक करना पड़ेगा। अपना खाने के तो इसे
खाना नहीं खा सकते।
आपके उस दिन तीन चार दिन थे मेरे सैटरडे,
वर्किंग डे में रहते हैं
नहीं सैटरडे था। लेकिन सर उधर भी नेटवर्क से ही चलेगा ना?
नहीं प्ले करेगा ऑफलाइन, नेटवर्क हम यूज़ नहीं करेंगे, ऑफलाइन करना है। आप में देना जो आप में देना, सिर्फ उनको जस्ट बोलने के लिए, ये नहीं दोगे तो भी चलेगा। ये अपना आप काम करो, एडिटिंग के लिए ये दे दो उनको,
ये तो वही चल रहा है।
चाहिए तो ये दे दो।
ये किसके लिए? नहीं उसका कॉपी पेस्ट किधर करेंगे? इधर करेंगे फिर उधर प्ले करेगा वो?
इधर कॉपी पेस्ट कर दूंगा, ये स्क्रीन कनेक्ट कर दूंगा बस।
लेकिन हर टाइम उधर पेस्ट करेंगे?
नहीं, जो बोलेंगे उनके लिए, सबके लिए नहीं करना।
अच्छा,
सबके लिए नहीं करना। जो नहीं लाया लैपटॉप ना उसको ऐसा करना है उनको, बताएंगे नहीं सब ऐसा हो रहा है, सब यही बोलेंगे, परेशान हो जाएंगे हम लोग।
ये पूर्वा दाते का ना? उसको लैपटॉप चाहिए क्या?
ये नहीं बोले सर, ये
पॉलीट्रामा वाली ना? उसको दे दीजिए।
नीचे पीडीएफ फॉर्म
ये इसमें वीडियो कैसे चलेगा?
वीडियो नहीं यूज़ करना,
नहीं है ना?
उसको बस चेक करना आपका लैपटॉप जो प्ले करेंगे हम उसको पहले से कॉपी कर देंगे।
तो ये लैपटॉप
आपका कोई भी एक ठीक है, काम कर रहा था तो सही है। ओके, अभी आप ये काम करो, सबसे पहले नहीं आप इस लैपटॉप में ये कंट्रोल मत करो, ऑलवेज कर दो, ऑलवेज करके बैठो। इसमें एक नाटक है, इसमें नाटक है, इसमें चार्जर लगा तो कंट्रोल करो, कंट्रोल करो। ये नहीं इनका नहीं,
नहीं इसका पॉलीट्रामा का हो गया उसका हो गया।
ये नीचे
ऊपर वाला ना
वो भी हो गया।
ये पूर्वा
नहीं पीडीएफ किसी और का है ना बोलो।
नहीं वीडियो किसमें पूर्वा रहते हैं?
ये सब इसका ट्रेनिंग कर नहीं नेटवर्क में आपके पीसी में कॉपी कीजिए
सेशन 3 ना
सेशन 3 कॉपी करो, बहुत बिग साइज है, एक मैंने फोटो दिया, बहुत बिग साइज है।
हाँ ये वो
बहुत बिग साइज है,
ये वाले ज़्यादा है,
बहुत बिग साइज है। हाँ इसलिए बोलने का मतलब फिर ये पीडीएफ कॉपी करो, इनको दे देना,
ये कंप्यूटर से आ जाएगा।
हाँ आ जाएगा, आपका पोर्ट दिखा देगा, पोर्ट चेक करना इसमें आ जाएगा। सी सब इसने तो एच दिया है, बट यहाँ पे केबल जा रहा है यहाँ, केबल जा रहा है।
अच्छा दोनों एक साइड
सब
पीडीएफ तो हो रहा है
वीडियो
अभी ना यहाँ छोड़ दो, कोई दिक्कत नहीं, एक ही कॉपी किया आपने, ठीक है। अपडेट को ऑफ कर दो, इंस्टा में अपडेट हो जाएगा, अपडेट को पॉज कर दो, यहाँ से क्लिक कर दो, अपडेट से जाओ, पॉज ऑप्शन पॉज अपना ऑडियो कैंसिल कर दो, नहीं हुआ पॉज, बहुत पॉजिटिव। हाँ चार्जिंग होगी, उसकी चार्जिंग नाम एडिट कर लिया आपने, दूसरा फॉलो कर लिया।
उसी का है ना
हाँ एक हाँ ठीक है ठीक है ओके हाँ वीडियो आपके अंदर
यहीं से मैं प्ले
ठीक है कोई दिक्कत नहीं ठीक है मैं ये आपको बाद में दे दूँगा
डायरेक्ट कनेक्ट नहीं कर सकते एक बार लैपटॉप में प्ले करके देखो नहीं आई वांट टू सी द वीडियोस आर प्लेइंग
हाँ ये आपका
अच्छा लास्ट टाइम में तो
पीसी तो ये है ना वो जैसे स्क्रीन होगा पीसी ये है
वही यार बट स्टिल वर्किंग
तो आपका है किस लेवल में मार्क
प्रेजेंटर
and we lost the laptop.
लास्ट रिजॉर्ट है
most importantly, okay, but for you to solve wow, so percentage can but no, yes, even yesterday in the morning so really that's yes. So depending who is the sound part is not possible. But but now man must stay in the I don't think we should wait for So will you please come to yes, of course. That's my name. Yeah, he's still there.
डायरेक्ट भी नहीं होगा ना
How are you, with the earbuds, managing yourself? I think it's a fantastic. So 2 in 1.
दे सकता हूँ मुझे मैं तो वही रहेगा वीडियो भी कॉपी कर लूँगा वीडियो भी कॉपी सबसे बेस्ट वही रहेगा इसमें आपका वो जो है थोड़ा सा डिस्कनेक्ट करें अब बैठ जाओ
वो 4 डालोगे ये 5 आएगा
अगर आपको वहाँ लैपटॉप से तो आप अपना लैपटॉप मतलब स्क्रीन देखना है या भी वहाँ से एक्सप्लेन कर सकते हैं।
अच्छा ऐसा है क्या?
हाँ
तो यहाँ से चेंज करेंगे आप? हम
आपको पॉइंटर दूंगा ना, आप चेंज कर सकते हैं। आपके हाथ में कंट्रोल करेंगे।
नहीं
पॉइंटर है वो आपका ये स्क्रीन चलेगा। मेरे यहाँ का स्क्रीन चल रहा है, ये स्क्रीन चल रही है, आपके लैपटॉप पर चल रही है। आपको दोनों ही
आपको ये करने के लिए
पॉइंटर होगा, ये स्क्रीन चेंज होगा, ये सारे स्क्रीन चेंज होंगे। हाँ ठीक है।
मुझे बेसिकली उधर देख के पेमेंट करना पड़ेगा। कोई बात नहीं, आप वहीं से भेज दीजिए।
मैं चेंज कर रहा हूँ क्या नाम लिया
Huh? Even that side is steep here.
Excuse me, sir. My option is the first one. This one. Yes. So we can. No? No, because I go just. I can leave it here. Yeah. Let's put up the chairs on the side.
स्क्रीन नहीं इंटरव्यू नहीं करेगा આપણે બે ત્યાં બેસી જઈએ અને
यहाँ दो और चेयर लगेगा ऊपर
अगर प्रेजेंटेशन बात करें
दो और चेयर लगेगा
फर्स्ट इज कवर सेकंड इज वीक देख लेना बात प्रोग्राम से
डॉक्टर जो
नहीं भाई सेकंड
चलेगा
के बाद में मेरा प्रेजेंटेशन
चलेगा डू वी हैव अ माइक यस स्टेज के ऊपर हाउ मच माइक है प्रोग्राम आ गया कुर्सी
Thank you. Also, no? And also, yes. Pointer.
Good afternoon, friends. After a sumptuous lunch, let's get on with the next session of trauma. It's on.
Hello. And this one.
Yes, sir.
So just to shake us out of our slumber, instead of a trauma talk, we are going to have an interesting talk on telemedicine in the early detection of DME in the Lublin region by Dr. Robert. Good afternoon, Dr. Robert.
Good afternoon.
And welcome.
Thank you. I'm presenting the system. It is currently used for telemedicine in diabetic macular edema, but it might be also modified and to detect different problems. But again, can you show me my?
Yes.
Okay.
Please turn off the top lights.
Yes, maybe.
So we all know that diabetic retinopathy is a growing problem, and that it is really epidemic. In Poland, for example, we have 3 million diabetic patients, and 1/3 is not aware of this problem, and approximately 1/3 of patients with diabetic retinopathy have vision-threatening retinopathy, especially diabetic macular edema, non-proliferative diabetic retinopathy, and also proliferative diabetic retinopathy. Main risk factors are blood glucose level and hypertension, and of course we nowadays know that we can use non-mediatic fundus camera to detect diabetic retinopathy, also non-mediatic optical coherence tomography A and B scans. And using these tools, we can make first diagnosis and also
recommend the patient. For example, here we can see first signs of diabetic retinopathy, and we can perform follow-up every 6 months. Here we can see already indications for anti-VEGF injections. On this photo we can see already neovascularization, so laser photocoagulation, or in severe stages vitrectomy. If you compare histology with fluorescein angiography, you can detect foveal avascular zone, and in fluorescent angiography, of course, peripheral vascular non-perfusion areas. And of course, having non-invasive imaging and face images, you can see and compare these results with fluorescein angiography, so you can see microaneurysms, also non-perfusion areas, and pathological enlargement of foveal avascular zones, as well as OCTB. You can see in the transverse sections symptoms of DME. So telemedicine can be used to image and analyze fundus photographs rapidly. Of course, you can use iNook or other, let's say, commercially available AI algorithms and programs, but we in Poland, we now work on our own Polish applications and algorithms. So this is a model we somehow copied from US, from Professor Marco Zarbin, who is coming to Lublin very often. Even in 2 weeks he will be again in Lublin. So he presented us many years ago his system from New Jersey. But we modified this system. So he's now introducing many new approaches using OCT, B scan, A scan. You can see diabetic retinopathy, but also you can measure corneal thickness, anterior chamber angle, and so enlarge this approach for glaucoma or even cataract. And of course, this is the system from New Jersey. You can see technician taking fundus photograph in standing position. If there is any problem, and iNook shows this problem, then he just step back, the patient, and they perform angio-OCT. And even they can contact retina specialist using special robot, speaking with every language you can imagine. So this is a system in New Jersey under supervision of Professor Marco Zarbin, my friend and my mentor. And this is a calculation. They can examine many patients a day, like around 50 subjects. So in some places even 120 subjects. So we copied this program and this project, and because in Poland we have 38 million people, then 3 million are diabetic patients, and of course we have lack of ophthalmologists. So we now plan to enlarge this system. We have support of Fulbright Foundation and also Polish government. I am a principal investigator, and now we have this iBus. So technician and the nurse are going to the villages
they have a Topcon Maestro 2 camera, excuse me. So they make fundus photographs and OCT with the same equipment. But what is important in Poland, we have really well developed, I think, even the best in Europe, e-health system. So everything is electronic. We have electronic system, connection with family doctors, hospitals, and family doctor is in the center. So family doctors invites diabetic patients, like 50 a day. Then iBus is coming. The team takes fundus photography, OCT, angio OCT, and all results are sent to my department. And the ophthalmologist is selecting so to say, early stages of diabetic retinopathy, and in the same time, Institute of Communication takes care about this, so sending photos, but also the team is working on artificial intelligence. And up to now, we tested 6,200 patients. We visited over 100 family doctors' practices, and 1,885 patients were referred in depth tests, and also over 400 patients was diagnosed, so diabetic retinopathy was diagnosed. And so this is a pilot study, but we convinced Polish government to continue. It was done in Lublin region, but now it will be like 3 other regions around Lublin. And we are planning now to examine like 20,000 patients with this system, which is really working very fast, accurately, and giving possibility to so to say, benefit is to really detect early diabetic macular edema, but also in our system, if diabetes mellitus type 2 is diagnosed, it means the patient should go to the ophthalmologist and to, let's say, wait on the waiting list, to enlarge waiting time for other people, other patients. So this system can, so to say, examine very fast diabetic patients, and they don't need to go to ophthalmologists. Thank you very much for your attention.
Thank you, Dr. Robert, for a wonderful overview of your system. How do you create awareness amongst the diabetologists, amongst the family doctors, and amongst the patients that this is absolutely necessary?
Really, thank you very much for this question. It's a very important question. And so we really created a system between family doctor and ophthalmologist. We also do a lot of media announcements, discussions, how important is early diagnostics. So that is why it must go in parallel. Also, Ministry of Health is contacting doctors. Yes, awareness is really important, crucial in this situation.
And do they take only central photos for telemedicine, or they take?
Technician and nurse take only central photo. And they, but and all photos are sent to ophthalmologists. So ophthalmologist can. Second thing is that then the patient is really in contacts and in the system. So whatever happens, he is aware that it is due to diabetic retinopathy, might be, or also family doctor is inviting these patients quite often. So they are, so to say, in the circle of interest, but they take central photos.
Like our country, do you also have very remote regions where maybe there may not even be a family doctor available, but there might be diabetics lurking over there?
So my region is remote, so to say, but for Polish conditions. We have family doctors there, but they have difficulty getting to ophthalmologists. So at least family doctors are there. I cannot compare with India, big population, a huge country. So we, I think, have like 100 kilometers to ophthalmologists sometimes,
nice.
Which is still something, you know.
Yes. Excellent.
Sir, I was wondering, these photographs, are all of them evaluated by ophthalmologists?
Yes.
Or is there an AI system? Because there are certain models where the primary images are assessed by AI.
Sure, sure.
And the AI actually decides whether the images should further be sent to an ophthalmologist for evaluation, or the patient is called back again for repeat image after a couple of months.
Yes, of course, we know. So we discussed with Professor Zarbin, but the aim is also to build our own algorithms, AI algorithms. So that is why we started from collecting data and creating this new AI algorithm.
Dr. Robert, in our country, we're a little bit different what you said, because we got a lot of paramedics, optometrists, then ophthalmic assistants, and health workers. So what do? We send a mobile van, no doubt, but we have in this mobile van, we got mobile cameras, or portable cameras, fundus cameras, very small, but we have shown one of the cameras in your lecture also. So those cameras, they go and in that, now it has come the AI incorporated fundus cameras. So they select the photographs. Then and there they tell that this photograph, whether it has diabetic retinopathy or no diabetic retinopathy. So if there's no diabetic retinopathy, we ask them, counsel the patient to come back again after 5 months or 6 months like that. But if any case is detected the diabetic retinopathy, there's referable cases, we send the patients to the nearby base hospital for further evaluation, because as you said, we have to dilate the pupil and see the periphery part of the fundus. Many times we miss, for central fundus you may not get all the signs of diabetic retinopathy. So you have to dilate the pupil and check periphery whether any retinopathy is there or not. Then you counsel the patient. If at all any treatment is required, either medical treatment or surgical treatment, we treat those patients. This is our method of teleophthalmology in our country.
Yes, I know there are many approaches. So this system is going to be sponsored by the government. So it's relatively expensive, you know, van and Topcon Maestro 2, the newest model. And the team is a technician and a nurse going. And all photographs are sent to the hospital. And so ophthalmologists are not in this small villages, but just checking only results. And I agree that perfect system would be to check periphery, but this is press screening. So these people have again will be checked because the IBUS is coming back even several times a year. So in any case of any problem, they will be invited again.
Thank you. Thank you.
So, Dr. Robert, what Dr. Subudhi was also suggesting, since you are now, in heading the organization which is in direct touch with the government, so if you add an optometrist, since you are short of ophthalmologists, add an optometrist to your team of the technician and the nurse, and a slit lamp, okay, and an applanation tonometer.
Yes, in ideal world, it can do. You can do it. You know,
yes, so that way you'll be able to pick up not only
problem
diabetic
is that,
retinopathy.
Optometrist needs much more money. You know, so it is not so easy.
But for the cost of paying an optometrist and a slit lamp and applanation, you'll also pick up more of diabetic retinopathy, preventable blindness, plus you'll also pick up glaucoma, which incidence is also more amongst diabetics. So think about it, and I'm sure the government will get convinced.
We will work on it.
Yeah.
Okay.
Thank you very much for a wonderful presentation. Our next presenter is none other than Dr. Usha Johri. She'll talk to us about birth trauma with resultant neuro defects. Dr. Johri has been a past president of the Bombay Ophthalmologists Association, and she does a lot of work with children with neurological defects.
Yeah. Yes, yes. Okay. A very good afternoon to all of you. And thank you, Dr. Natarajan and Dr. Karobi, for having me here. And I'm going little bit away from ophthalmology. Of course, the end point is ophthalmology only. So the talk that has been given to me is the birth trauma with resultant neuro defects. So we all know that there's so much of force and the mechanical tremendous pressure which falls upon the uterus of the mother during the labor. So the uterus and the child, the newborn baby, both of them are, literally fighting with each other. And it's a very difficult process when the child passes through the birth canal. So it's not only mechanical, but at the same time it could be hypoxic and ischemic. And this is how, the signs that we normally see when a newborn child is born is either the size of the forehead is too large and the birth canal is too small, or the child will have a black or blue discoloration around the eyes, bruises, bumps and cuts on the head. So the commonest problem is the physical and head injury and the bleeding of the brain. Now the institutional births are definitely very high, but you'll agree with me that in a country like India, we do have home deliveries. Okay, home deliveries, which are very, very dangerous, done by an, local, okay. And of course, sometimes, even the gynecologist have to use a vacuum during delivery, the forceps during the delivery, which could be a trained, delivery or a forced delivery. So what happens when these happens, is there's a damage to the brain cell. And we all know that the brain cells do not regenerate or repair themselves. However, is it possible for us to intervene early so that we can prevent further damage? Yes, the brain damage cannot be reversed, which we have been taught in first MBBS or second MBBS. And asphyxia, which is the commonest problem, is a very short window to treat these children. Okay, now 2 out of every 1,000 childbirth with premature infants have a very high risk, and 3 out of 1,000 babies who are born full term suffer from some degree of brain damage. Of course, the degree may be very mild, but the brain damage is there. So the mild brain damage definitely recovers fully, but what happens to a severe form of brain damage? It may be lifelong, and the child has to visit multidisciplinary specialists all their life. So in a nutshell, cerebral palsy has no cure. Now, Bell's palsy, we all know how it happens. There's a direct injury by the forceps blades, and there is a hemorrhage around the nerve, the facial nerve during normal delivery. And there is a pressure on the ramus of the mandible of a child, or on the promontory sacrum and the ischemia during the descent. And this pressure is on the mother's bone, the sacrum, and the ischemia. And of course, the child gets a facial palsy. But in such a situation, the prognosis is good, and I'm not exaggerating, 10 per 1,000 live births have facial palsy. Now the types of hemorrhages, I'm not going into the depth of it, They have just showed you the diagram of what are the types of hemorrhages, the subgaleal hemorrhage, the caput succedaneum, and then the subgaleal hemorrhage, I have just showed you a diagram where there's a loose connective tissue, and of course, as the terminology says, it's between the periosteum and the galeal space, and this gives rise to hypovolemia. And caput succedaneum is because of the pressure of the girdle of contact between the cervix, bony pelvis and the vulval ring, and this could extend to the midline across the suture line. Now, intracranial injury, there could be linear fractures when the child is born. The commonest is the parietal bones due to the compression of the forceps or the skull pushing against the maternal symphysis or the ischial spines. The child can have a depressed skull fracture, which I have shown here. Now, the neonatal birth injuries are classified into 3. The fetal presentations, where there could be, an abnormal presentation like the transverse presentation or the breech presentation. The child may have a precipitous delivery, and delivery mechanisms, of course, which are under our control, like using the instruments technique like forceps, vacuums, etc., or sometimes both. Maternal factors, of course, a diabetic mother will definitely have a very high risk compared to a non-diabetic person. The elderly primary gravida, number of pregnancies, the first primary gravida definitely will have a tough pregnancy compared to multigravida, and of course the pelvic anatomy of the mother. These are our disabled children, and these are all having extremity problems. The limbs and the limbs involved, monoplegia, diplegia, hemiplegia and quadriplegia. So what is our role here? I've been seeing these children, and ophthalmic peculiarity in cerebral palsy is not a new entity. It's known over a century. But why did we not detect it? And why did we ignore it? Because all the parents, the relatives always felt that let us look into the extremities first, then we will look into the eye, because eye is such a small part, without realizing that 60% of the brain is involved with the eye. So we landed up with the children having visual disability, maybe an ignorance from our side, overlook, and also a social stigma and lack of education in our country, and of course the economical support. So what is cerebral palsy? It's caused by the perinatal damage to the brain immediately after, during or after birth. There is a disorder in the movement, posture, resulting in permanent, non-progressive defect or the lesions of the immature brain. So the incidence of this is definitely increasing, thanks to our neonatologists who are taking very good care of these children, keeping them in an ICU, and since they are taking a better care, the incidence of cerebral palsy is also increasing. So I would, in a nutshell, tell that we are not the only people looking after these children with cerebral palsy. We have multidisciplinary specialists like the orthopedic surgeons, the pediatricians, neonatologists, psychiatrists. They play such an important role in counseling the mothers, OTPT therapist, ENT surgeon, speech therapist, and etc., etc. The most important, in my opinion, for these children is the mother, who is the first teacher for the child. Now, let's say that we alone cannot do anything, because it's a multidisciplinary specialty. We have started the Global Vision Brain Alliance, where we try to train OT, PT, special educators, parents program, sometimes even the children's program if they're capable of coming. So this creates an awareness, and since these children spend more time with the physiotherapist and the occupational therapist, I feel that the basic training for these people is more important than, because these children rarely come to the ophthalmologist. So prevent or detect early intrauterine fetal asphyxia, avoid premature delivery, avoid traumatic vaginal delivery. Cesarean section, which was considered to be once upon a time as a fashion, even now it's considered as a fashion, but it is really, it has to be used liberally when it is required. And I would conclude saying that just because this child cannot see doesn't mean I don't have anything to say. So thank you very much for your attention. And the damage to the visual brain can result in impaired visual function, including peripheral, perceptual, and cognitive dysfunction. So we detect ocular anomaly, record the visual capacity, treat visual problems which are neglected, overcome visual handicap in time, facilitate overall rehabilitation and importance. So let's not ignore this. Thank you very much for your attention.
Thank you, madam, for such an exhaustive talk. We could see the passion in your voice for having a prevention as the most important thing. Yes. Madam, for prevention, what is being done? Okay, we are doing a lot so how are you creating awareness so that we can prevent the problem?
So wherever I get a chance, I'm trying to, push in myself, whether it's a gynecologist meeting or the occupational therapist conference or the physiotherapist conference. And of course, we have formed a parents group where we have almost 800 to 1,000 children in that group. So we keep on conducting CMEs, sometimes hybrid, sometimes physical CMEs. So I think that's important because it's a multidisciplinary specialty. And we have a very wide platform. And unfortunately, I'm really sorry to say that we as ophthalmologists, including me, we were not very much interested on this topic. But since I've been seeing these children for the last, I think, 10 to 12 years, I feel that we should, spread our, awareness wherever we get a chance. There are even many parents, educated parents, very, double graduate mothers who have sacrificed their life for these children, and they're greatly interested. And I feel the parents are the best people because they're interested and in their own child, and they always come forward, to hear what we are saying. And we arrange, the CMEs where I invite all the multidisciplinary specialists. I don't invite ophthalmologists. All the multidisciplinary specialists are there. We have a case presentation, and then each one tells what is to be done to the child so that we are all on the same page.
Thank you very much, madam.
Now, I had a statement, a small tip over here.
Yeah, please.
That was a wonderful talk, Usha, and very informative. See, the thing is that these children are very close to my heart because I've been dealing with them for the last 33 years. And all I can say is that as ophthalmologists, we have a great onus of treating these people. At least even the basic refraction which you do for these children plays a mighty role in allowing the child to progress on a normalcy path. Because when you rehabilitate the eyes, means we are talking at our level, we are doing a refraction, give a proper refractive error to the child, it helps not only their visibility, it also aids their proprioception, their balances, their behavioral tendencies, their ability to talk. Sometimes we've seen children who start talking after they are given a pair of glasses. So it is, in a CP child, it is a 15% disability, but that 15% is what adds the whole quality of life to a patient. And the quality of life improves, they start improving with their physiotherapy because it's a cog in a wheel which was missing. You put the cog back and you see the things circling. It doesn't move as fast as a normal child, but it moves. Certainly, it moves towards the betterment. It needs positivity. Parents are happy, the child is also, and when you see the child next time, you see a much better child than what you started with. So, I wanted her to say this first because this is a birth trauma, this has occurred. But I am now going to talk to you about something which is a normal child going bad. Give her the plaque.
I would request Paritosh sir to give her the memento.
And one more interesting thing that I noticed was this children with cerebral palsy have multiple eye problems. Okay, and we have classified into reversible, partially reversible, and irreversible. And simple problems like refractive error, amblyopia, squints, this could be corrected by us, but we won't have it.
Thank you, madam.
We have had a sumptuous lunch and many of us are sleeping. So, madam has come to shake us up.
Yeah, this will certainly shake you up when you see the one of the animation videos. So, my talk today is on shaken baby syndrome. Now, what is shaken baby syndrome? It was earlier caused as a whiplash infant syndrome. And what is a shaken baby syndrome? This is not a battered baby syndrome. It's a crying child who the parent or the caregiver in a fit of anger shakes the child. And because the brain is delicate, the dural veins rupture, and these ruptures called micro hemorrhages on the disc, which coalesce and they form bigger hemorrhages. These percolate down into the eye, and that's how you get the causation of a subhyaloid heme. So this is something which is there in a normal child. A normal child getting worse is because of shaking. And these are cases which you have to pick up. It will not come with that history because very rarely the caregiver or parent tells you that I have shaken the child, except a few. So now what happens is that there is a neuraxis damage, there's apnea, hypoxia, a whole resultant areas and it leads into axonal injury, and thus a normal, healthy, happy child becomes comatose without any movements and a moribund child. So this is a very serious thing which happens. Now, how do you recognize this? It's an abnormal child who becomes comatose suddenly. There is no obvious signs of external trauma. Presence of subdural hematoma, retinal hemorrhages, or cerebral edemas, these are characteristic triad which is present, and this is caused by intentional shaking. So now, what is the trigger for the shaken baby? It's just crying, crying, crying. A baby keeps crying, and the parent, if because of stress, frustration, or if there is a lack of parenting skills, or there is a lack of support, sometimes in a fit of anger does it. But also sometimes the caregiver is important, because if it is somebody who is not related to the child, will do it more than the mother or father of a child. Now, what are the 5 S's to comfort a child? Swaddling, side stomach position, shushing, swing, sucking. And you give good music, give a proper feed, change the diaper, put some nice music, songs. And if you have the tendency to be angry with the kid, keep the child down in his pram and go out and take a walk. Because don't ever give in to that thing of shaking the child. Burp, diaper, clothes change, these are other things which you can sort of cater to. The common presenting symptoms are that a child starts looking moribund like this. There is no expression. He's got a stoic gaze. Extreme irritability may be there. He may not feed well. He might vomit. There is lethargy. The head may be turned to one side. He may not be able to lift his head or turn around. Pinpointed, dilated, unequal sized pupils, unresponsive to light, and sometimes there is blood pooling in the eyes or spongy edema of the forehead. So if you see these things, suspect a shaken baby. So, and in the eye, in the anterior segment, we get ecchymosis, subconjunctival hemorrhages, hyphema, and petechial hemorrhages. Posterior segment, you get large hemorrhages like this, you get subhyaloid hemorrhages, and you can get petechial hemorrhages all spread out throughout the posterior fundus. The other changes which can occur is a retinal detachment, choroidal detachment, and sometimes a retinoschisis. So these are my collection over the past 30 years, which is 10 patients that we have found, of which 6 have survived and 4 have copted. They have not survived. And this is what happens is that they range from total recovery to severe disability to death. So it is 1/3, 1/3, 1/3. It's people die like that. 1/3 dies, 1/3 goes away with a lot of disabilities. What's happened? Okay. And this is like, and they have many a times major neurological impairments, learning disabilities, seizure disorders, speech disabilities, hydrocephalus, and cerebral palsies. I'll just run over, these are the diagnostic tests which you normally do. We had 10 patients, they had hemorrhages, subhyaloid, these are the number of cases which had this following things. And in these patients, 2 eyes needed surgery because they had vitreous hemorrhage and 1 had a hemorrhagic RD. The long-acting gas was put in 2 patients who had subhyaloid. Glasses were given to 5 patients and 3 patients died, sorry, not 4. And the neurodevelopmental problems were in total 6 patients, where there was cerebral palsy, autism, attention deficit disorder, attention deficit hyperactivity disorder, and there was 1 dyslexic patient also. So what do? We need a multidisciplinary approach where, it's a coordination between health, child, police, social services, justice, and educational professionals. And in the eye, or for the child, you read all types of specialities which go into the recovery of this child. Now, long-term consequences could be physical disabilities, vision, hearing impairment, speech difficulties, cerebral palsy, seizures, physiological, it could be behavioral disorders, and cognitive impairments like learning disabilities, and as I said, some children die at the end of it. Now, I just want to focus a little on the rehabilitation. This is one of the children, just play it from there, which is a child who had SBF. She was normal earlier, and this is how she became. She came to us when she was at this age. We had given her glasses at that point of time. She was showing a little bit of improvements, and
Yes.
And later, as she grew older, she was much better. And she was able to ambulate also. These were some of the things that she was subjected to. This is another child who was a CP. And again, rehabilitative measures were given to him. He's doing well now. And these were the visual rehabilitation and the physiotherapy, which was given in the form of neurodevelopmental therapy and the sensory integration therapies. This is another child who was autistic. Before the glasses, you see her. And see her after the glasses. She has very pinpointed things. She's able to grasp things. And this girl is 12 years old. So there are legal issues which have to be tackled because they look for not only the 3 symptoms, but the clinical history is also important. That is the reason why document with care. If there is a child where there is no obvious reason why this thing has occurred, please make it your business to see and see other signs, symptoms, and take a very careful history and document it. And so, when you can't soothe a baby, take a break, but never shake a baby. Better that the baby cries than the baby dies. And the dictum is never, 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 never shake your baby. Thank you so much for your kind attention.
I'm shaken up.
I think I've shaken up everybody.
I will request Usha ma'am to give the memento to ma'am. In the meantime, I invite Dr. Vidyashankar sir for his talk.
Thank you, dear. Thank you.
Karobi, do you need to report to the police once you see such a thing?
We reported to the authorities because generally mine is all hospital-based practice. So you report it to the authorities. It is for the authorities to take the thing. But sadly, I have seen that they kind of hush up these issues. There was one child who was the child of an ambassador in care of a there was a nanny who was appointed, and I think the nanny must have done something because a normal healthy child became comatose, was admitted to the hospital. We counseled them, we told them that this could be the problem, and then we told them that this has to be reported because you have to take some action against this, but nothing happens. In our country, I'm sorry to say, but nothing happens. These people go scot-free. Thank you, sir.
Dr. Johri madam, one more point for education, for prevention. So actually, like cerebral palsy, even this, you need to counsel the parents when the lady is pregnant already or young couples before they become pregnant.
Madam was so much charge left to her that she would have gone and whacked some of them who had shaken the babies who have come to her. Yeah. Thank you so much, Trauma Society, Dr. Natarajan sir, Dr. Karobi, and everyone for inviting me for this talk. Basically, we are going to be talking about traumatic lacrimal drainage apparatus and the management of the same thing. It is medial canthal injury. Medial canthal injury does not always require. Okay. Yeah, that's okay. It's mainly called as the medial canthal trauma. That's naso-orbital ethmoidal injury. This basically consists of both the bony attachments, the medial canthal trauma, the medial canthal ligament trauma, the Horner's muscle, and also to some extent the crura. So when you have the anatomical structures, they are basically the bones, the fat, the arteries, the lacrimal system, and the canthal attachments. All of this are bound to be dissociated. When you have fractures, it could be type 1, 2, or 3. Type 1 where only the canthal insertions are out. Type 2 where a little bit of the fracture is also there of the bone but it is not detached. And type 3 where some of the bone has also come off. Signs of injury are traumatic telecanthus, diplopia, retrobulbar hemorrhage, epiphora, and stuffiness. Patients could come as bad as this. It could be multiple lacerations, multiple trauma on the face, wherein you have to have imaging system nowadays to safeguard yourself as to save and also to have a basic plan of what you are going to be doing. Surgical management includes the compressed NOE complexes, traumatic telecanthus, medial orbital fracture, lacrimal fossa if it's going to be disrupted, and in cases of retrobulbar hemorrhages and things like that, in which case you require an immediate. If you have an eye like this where you suspect retrobulbar hemorrhage, you have to go in immediately. Otherwise you can wait up to 48 hours. You have to basically re-establish the intercanthal distance, that is by internal fixation. You may require to add in a plate, a screw, and things like that as well. Surgical approaches could be from the incision site. This is basically giving you a video of the same. Here you have the problem over there. And here are the two ends of the tarsal plate or the medial canthal ligament or the crura. We need to fix that back. If this has not got detached from the bone, then it is okay. But if it is detached from the bone, then you need to, what is basically being done here is the medial, from the tarsus, before you go on to the tarsus, which is over here, I have taken part of the periorbita. We have to be extremely careful over there because the lamina papyracea is there and we need to basically try and avoid going through it. Otherwise we would end up causing more damage than what repair that we have done. So going through the periorbita there, here and there, that's the periorbita, the upper and the lower tarsal ends, we are basically trying to connect back the medial canthal anatomy. That will be followed by the various soft tissue injuries repair that we may encounter over there. Before that particular trying that, we have basically tried and put in this. This was basically done in a multi-specialty hospital where the mini monoca was not available. So the IV cannula has been put in. At the end of surgery, you may have a defect over here. If there is a defect, then we may require a lid sharing procedure. This is a very simpler of the procedures wherein there is only a canalicular tear without involving the crura, without involving the bone. So we dilate it, we probe it, we find, it's gone from there. It's playing here, okay. Let me go a little back. we probe it and put in the mini Monaca stent. So this is to go in through here. There is the other end over there. So we are basically trying to railroad it through the punctum, and finally there is a flange over there. That flange has to be fitted into the punctum. If that is not done, then the whole thing will start coming off, and that will trigger a lot of irritant response on the patient's cornea. And I try and fix it with a proline suture over there so that it does not get extruded. Whereas these are the medial and lateral canthal avulsions pre and post. Sometimes this canthal displacement may not be only horizontal. There may be a vertical one as seen over here. This is not only gone horizontally displaced but also vertically. So this is the proline suture which goes through the periorbita and things like that. This is just a repetition of what we have already shown in the form of the video. So in traumatic telecanthus, this is displaced off. This may be not only displaced this way, this might even go a little down, in which case a YV-plasty or things like that in order to replace the medial canthal tendon to its original position. Here you not only see it displaced horizontally, there is a vertical shift also. In vertical shifts, we generally use a Z-plasty because it will take care of 3 dimensions. Here you are seeing that the eyebrow is in a much higher position. We have to get it down, and that is done along with, initially I had done it along with a plastic surgeon, but nowadays we do, since we are used to the brow lifts and things like that, and a little more anatomy on the face, we are able to treat it a little better. So all this takes a long learning curve, but yes, if we are able to address our basic problems and trying to put them into position like a jigsaw puzzle, then we are able to deliver what we are. Always promise less and deliver more. That is our dictum as oculoplasty surgeons. Thank you.
Thank you for a wonderful presentation, Dr. Vidya Shankar. I think those videos were really nice and self-explanatory. In the presence of a lot of edema that you see in the tissue around, sometimes you're not able to get the anatomy right. What would you do? How long would you wait? Would you wait a little bit for it to settle down, or tissue becomes, it's quite fragile, friable, cutting through? What would you do?
We request Dr. Kirit Modi sir to present the memento and certificate to Dr. Vidya Shankar.
Got your question. Basically, you wanted to know how much time you can give for the edema to settle down. Give it around, you can start with your systemic steroids, wait for around 48 hours. But if you, at any point of time, think that you are seeing an RAPD and things like that, where there is a compromise of the nerve, then probably we may have to intervene much earlier.
Our next speaker is Dr. Purva Valvekar Date. She is the head of vitreoretinal surgery department at the Grand Medical College and Sir JJ Group of Hospitals. And she was in fact the first Dr. Zivonovich Fellow from Aditya Jyot Eye Hospital. She'll speak to us about pole-to-pole surgery.
Thank you, sir. I thank Karubi Madam and Natarajan sir for giving me the opportunity. I have no financial disclosures. Ocular trauma is a major cause of visual morbidity and unilateral blindness. Pole-to-pole trauma involves anterior as well as posterior segment of the eye. The concept of pole-to-pole trauma was introduced by Dr. Cesare Forlini, my mentor, Dr. Robert, who was here with us, and Dr. Natarajan. Coming to our first case, he was a 37-year-old male who had an ocular trauma with a stone. It resulted into traumatic cataract, iridodialysis, which was extending from 12 o'clock to 5 o'clock. In the B scan, we can see the VH. We posted the patient for pars plana vitrectomy, lensectomy, iridodialysis repair with sewing machine technique and CMT flex under local anesthesia. 3 and 9 o'clock position were marked. Decrease the volume. A curvilinear partial thickness scleral groove was made. Pars plana lensectomy with vitrectomy was done. A sewing machine apparatus was made with a 26 gauge needle and 90 polypropylene. Light off. Off. A first bite was taken from the peripheral iris and the apparatus, a thread was taken out. Similarly, 3 bites were taken. The loops were cut and alternatively they were tied together. CMT flex IOL was implanted. The T junction was externalized with the help of Nishi and Pranav forceps. The post-operatively, we could give a kind of a pupil, central pupil, and its vision improved to 6/12 after 1 month. Coming to the second case, he was a 43-year-old male who sustained a blunt trauma with a ball 6 months ago. It resulted in a traumatic cataract, an inferior large pupillary defect, and posterior synechia. In the posterior segment, he had a vitreous hemorrhage. The patient was posted for cataract aspiration, pars plana vitrectomy, pupilloplasty, and CMT flex. 3 and 9 o'clock position were marked. A partial thickness scleral grooves were made. Basic vitrectomy to clear the VH and base shaving was done. Suspicious area were treated with the endo laser. CMT flex IOL was implanted. For the single pass 4-throw pupilloplasty, a 90 polypropylene was used. The inferior margin of a defective iris was taken into the section. The loop was made and a 4-throw pupilloplasty was done. As there was an inferior iris tissue defect, we did not do the second suture. Post-operatively, patient was having 660 on day 1 and it improved to 618. Coming to the third case, a 46-year-old male who had trauma with the stone. There was a history of corneoscleral tear repair was done. The tear was extending from 6 o'clock to 10 o'clock. It had a uveal tissue as well as lens prolapse was there, so it was removed. So it resulted into the anterior segment aniridia, aphakia, and there was a dense VH and total RD in the posterior segment. The patient was posted for membrane dissection, vitrectomy, endo laser, and silicone oil implantation with silicone oil retention sutures. A standard 3-port pars plana vitrectomy was done to clear the dense vitreous hemorrhage. After clearing the vitreous, we could see there was a PVR changes. So arcade to arcade ILM peeling was done. Later on, silicone oil retention sutures were planned. 90 polypropylene with a straight needle was taken. A partial thickness scleral groove was made. Conventionally, we take the other suture at 3 and 9 o'clock position to make a hashtag. But here, as the 3 and 9, there was already corneal scleral suture was there. So we did 11 o'clock and 5 o'clock position. Nasal SRFD was done. Endolaser was applied and fluid air exchange was done. Oil was implanted. This is the post-op picture. In the day 1, he had a 0.5 meter of vision. Coming to the discussion, a surgeon must be trained with the global approach. A surgery by single surgeon is always economic and efficient, and link with the eye bank should be done to have complete pole-to-pole injury management. So trauma is a potentially preventable cause of blindness. Strategies for prevention of ocular trauma should be done, and close follow-up for other eye who can become a sympathetic eye should be managed. Use of eye protection is critical to prevent the ocular injuries in the field of work. Thank you.
Thank you for a wonderful presentation. For some of our junior colleagues who are present in the audience, a lot of these, you have stab wounds, you have bullhorn injuries, you have bullet wounds, where you have very deep scleral ruptures. So it's very important to close. The primary closure is extremely important at the first sitting. And then there's a question about whether you want to intervene with the vitrectomy immediately or a little later. So what is your choice?
Sir, given a chance, we should do it in the first go. But if the eye is inflamed, very much edematous, then we can wait. A primary surgery, observe the patient, and then we can plan our surgery better. And we can, in a second sitting, we can do a complete job with lensectomy, vitrectomy, secondary, that all depends upon the second sitting.
Yeah, so unless there's an IOFB or an obvious infection, it's always better to take it up at the second go, because then you have a chance to give steroids, systemic steroids and topical to the patient so that you control the inflammation and everything. And it's always nice also to have temporary surgical keratoprosthesis, and as Dr. Purva mentioned, to have a good contact with the eye bank and have a cornea standby. So I've had instances where sometimes a good clear cornea is not available when one has to use a keratoprosthesis, etc. So I've transplanted not a very good quality cornea at that stage, and then we go ahead, let the eye quieten down, and then transplant a optical graft later on. So pole-to-pole surgery is something very, very exciting and very intricate, but it's almost like a marriage with the patient of sorts. The patient is going to see you almost lifelong, the life of the patient, your own life, and the life of the eye.
Purva, consider a situation where you have to change the cornea and you don't have a graft. Okay, and there is a posterior segment problem, either hemorrhage or end off. Maybe the cornea is shed off because of this. What will you do? Will you leave the keratoprosthesis in till you get another one?
We can leave, ma'am.
That's what, because I think that's the only thing that you can do.
We can leave till the time.
Yeah. So tell them that, wear it for some time and then we change it later.
Yes.
Excuse me.
Yes.
Are these cases dealt by only anterior surgeon and posterior surgeon combination, or only posterior surgeon?
These all are my cases, sir.
Yeah, I think in the days of subspecialties, this is a wonderful example that we should all become ophthalmic surgeons, not subspecialty surgeons.
Thank you.
Wonderful presentation, wonderful case. I will request Dr. Usha Jory to Madam present the memento. Is Dr. Bhageshri Meshram here to talk about scleral tears? Yeah. So she is going to talk to us about how she does repair of scleral tears. pole-to-pole surgery was pioneered by Dr. Zivonovich and Dr. Forlini and Dr. Natarajan, and I also. We are all students of Dr. Zivonovich. So we used to have a very nice corneal specialist coming in to do just the corneal part after the keratoprosthesis and the vitrectomy element was done. And then at the end she would come just to replace the cornea. So it was very nice. Long surgeries, but extremely gratifying because these were all mostly given up eyes. So please go ahead.
So good afternoon all. I come from Shantilal Sangvi Eye Hospital. I work there as a retina consultant. So thank you so much Dr. Lahiri for giving me a chance to present in front of this wonderful audience. So let's understand scleral tear. It can be a direct with a direct trauma where the scleral tear is at the site of the impact, while diffuse when there is an indirect trauma. So by considering hydraulic law principles, there will be acute rise in the intraocular pressure which will cause a giveaway at the most weakest area of the sclera. So when do you suspect the scleral tear? A direct scleral tear, you will be able to pick up on the direct examination. But the signs of the rupture which are occult are the ocular hypotony, then diffuse subconjunctival hemorrhage, irregular scleral contour, hyphema, abnormally shallow anterior chamber, presence of a RAPD or a vitreous hemorrhage. So let me show you this case of an 8-year-old male who was brought by parents just by a redness in the nasal quadrant, but on exploration under GA we found there was a small scleral tear which you can see which is being repaired, and it was by an accidental fall of a small Taj Mahal miniature which child was trying to remove from a cupboard, which he did not report. So the site of a scleral tear will be direct. When you see direct, the scleral tear is an extension of the corneolimbal wound, or indirect is the rupture where it happens is the area of the most scleral weakness. So in this photograph that you can see, it's a pseudophakic patient where the intraocular lens has migrated into the subconjunctival space by the trauma because the scleral SICS wound has given away. And this patient presented to us with only a hyphema and a subconjunctival hemorrhage with loss of vision. But in phakic eyes, it is an insertion of extraocular muscles. If the eye has staphyloma, it is usually the tear adjacent to the staphyloma. So the only definitive way to find out whether there is a scleral rupture is to do a careful control global exploration. So goals of our scleral tear repair should be a primary aim to form an anatomical integrity so that there is no wound leakage and there is no endophthalmitis. And secondary aim will be to achieve a possible visual functional outcome. And why? Because we want to avoid a retinal incarceration, formation of scar tissue and a fibrovascular proliferation, which ultimately can result in recurrent hemorrhages and retinal detachment. So if the scleral tear presents to you, please avoid using ointments, pupillary dilatation, any contact procedure, and apply eye shield rather than applying an eye patch. Give an injection, tetanus toxoid, antibiotic coverage, and more importantly, the radiological investigation you might like to do is a CT scan to rule out an intraocular foreign body rather than just directly going away with the B scan in an open globe injury. So document the case very well because you have to cover the medico-legal aspect, traumatic experience for the family, for the patient itself. So not to be very pessimistic like the photos that I have illustrated with the retinal incarceration with a large intraocular foreign body that you can see here. Sometimes they do gain meaningful vision. So the steps of the wound exploration will be the first will be the choice of anesthesia. If you do not know the extent of the scleral wound, better to go with a general anesthesia. So the first step will be your conjunctival peritomy. Start at the point which is away from the suspected wound so that you do not cause undue traction and open the wound further with a vitreous leak. And it helps you to understand where is the scleral extent. Then after a 360-degree peritomy, when the wound extends posteriorly, you need to now explore the wound more posteriorly. So the space between the two recti is the best space to open your Stevens sternotomy scissor, go along the globe and open it. Do not close it, otherwise you might cut it. And everything has to be done under visualization for you not to enter into the vitreous space. and be always aware of a vortex vein which you might hurt while dissecting this. And you always check all the quadrants. This is just an illustrative video which I have taken from a scleral buckle to show how the muscle tagging should be done in a specifically scleral wound. You expose the muscle insertions and then only pass the muscle hook with the 2-0 silk and tag the muscle so that you do not enter into the vitreous cavity with your muscle hook itself. The suture that you use usually is 7080 viralreel, interrupted, never continuous. Intent is 80% depth, and better to use increased number of sutures rather than putting a longer bites. So in this photograph you can see better is to start closing from anterior to posterior. So close as you go because you do not know what is the posterior extent. Keep the cautery ready to dithermize those bleeders and avoid further incarceration of the scleral wound. So when it's a corneoscleral tear, first you take a limbal suture, then suture the cornea, and later followed by a scleral laceration. So it is always beneficial not to pass a suture in a single throw in both of the edges. Put your limbs on the first edge and then pass the suture so that you do not cause undue traction and more vitreous loss, which can be seen in this video where I am trying to do a surface vitrectomy so that I don't cause further more vitreous traction. Never enter with your vanas or vitreous vitrectomy cutter inside the wound. So don't engage the underlying retinal tissue. Sometimes retina can also come up with that, and a uveal tissue where you are passing the scleral sutures to limit the incarceration. So as per the literature, there is a thought of passing a silicone scleral belt of 240 belt when the tear is extending beyond 5 mm to support the aura. So I usually secure it with the help of a scleral tunnels, which you can see here, and this is the way we pass the silicone belt, which is usually done in a belt buckle surgery. So what to do when the scleral tear extends beyond or stops at the extraocular muscle? Either there has been previously done was a disinsertion of the muscle and reinsertion again, but now maximum surgeons are preferring to retract the muscle with the help of an assistant and complete the scleral tear repair. The difficulties you might face is a dehiscence of the scleral wound. So you might need a scleral patch graft which has to be ready. There can be uveal tissue prolapse. Better to abscise it if it is beyond 4 hours. And if you see any necrotic or exudates, better to send it for a microbiological evaluation. And very posterior wound, specifically beyond 15 mm from the limbus, are supposed to have a poor visual prognosis, and they usually heal on their own. So you just close them till the extent it is possible. So on the follow-up, topical and systemic antibiotics and steroids, peripheral fundus examination has to be done to rule out any retinal dilasis, retinal detachment in the future, as well as retinal incarceration. If there is no view, better to go for B scan, rule out endophthalmitis, rule out retinal detachment. If there is a retinal detachment, you should operate the patient within 3 to 14 days because it induces more PVR. So my take-home message will be, imagine the crime scene. It is very important to understand the nature of the trauma, the extent, the velocity of the object which has caused the trauma. A detailed history helps us to focus on this. If there are any signs of do not hesitate to just take a vitreous biopsy and give an intraocular antibiotic, obviously after ruling out retinal detachment. Then in doubt of an intraocular foreign body, go ahead with a CT brain plus orbit. In doubt, always explore and try to preserve anatomy, do not harm further. So every minute counts in a trauma patient. Like in this case, it was a corneal tear with a lens abscess. The patient has presented to us with 20/100 vision, a 23-year-old male mechanic, workplace injury. And in one day, just for the matter of time to get a CT done, the patient ended up in a hand movement vision with a traumatic endophthalmitis with an intraocular foreign body, which is being removed in this video. So if you treat it on time, and if there is any, as sir mentioned, intraocular foreign body or any nidus of infection, it is better to combine with the vitreoretina surgery. If you suspect RD and end-off, treat it faster, because every minute counts. And this patient did well. Yesterday only I saw him regained a vision of 20/20 with retina attached. Thank you.
Thank you, Dr. Bhageshri, for excellent videos. Certificate? Memento and certificate for her? So I'll request Dr. Purva to present the memento and certificate to her. Areva, congratulations. Very nice. Yes. So far as scleral tear suturing is, the next speaker is going to be Dr. Akruti Desai. Sorry, we missed your order. She's going to talk to us about orbital fracture cases her way. So far as scleral wounds are concerned, if they're very tiny and anterior and no tissue prolapsing, okay, you can go about it any which way. But if they are extending posteriorly, then the important thing is to minimize incarceration, particularly of uveal and retinal tissues. So there, Dr. Zivanovic's technique is extremely useful, where if you can imagine, this is the scleral tear. Instead of trying to get the ends together, which are already very frayed and jagged, you take bites on the sides just beyond the wound, so you actually get some kind of an invagination of the sclera, and the uveal tissue and the retina would actually go inside rather than get caught in the wound that way. And most of these cases will require a secondary vitrectomy. So be prepared for it. And whenever the open globe injury has been there for more than 6 hours, even if you feel that the media appear to be clear relative, I mean, there will be a lot of hemorrhage. But if in any doubt, it's better to inject antibiotics intravitreally rather than not do it. I mean, that's what I would prefer in our circumstances. And I even go ahead and give a shot of an IV antibiotic at the time of the primary repair itself.
As a plastic surgeon, oculoplastic surgeon, sometimes retraction becomes very difficult. So over time we have thought that when we take a suture, we leave the bite a little longer and the person can pull on that. That becomes very important when we are dealing with very posterior tears, because there all your spacers and all that is not going to work at all. So if you can have a long suture which is already on the sclera, for beginners or for residents, that makes, because students in science and all that, they will face a lot of suturing right in the middle of the night and things like that, when there are not going to be any staff who's going to be helping you out with that.
Please, Doctor.
Thank you so much, sir. After this lovely talk by Dr. Vidyashankar about medial canthal injuries, which are indeed challenging, I would speak on orbital fracture repair from an oculoplastic perspective. And since it's a vast topic, I would just cover the ones that need titanium meshes for correction. So I am a faculty at Shantilal Sanghvi Eye Institute. This patient had inferior entrapment of inferior rectus, sorry. And I'll just go back a bit. Let's just start. This is how a typical patient of orbital trauma presents, which we commonly see in which ecchymosis and edema. And when you get a CT scan done, we see there is a fracture of the floor. There is inferior rectus entrapment. There's a medial wall fracture as well. And once you go ahead and plan the surgery, the eyes look, you can see that the down gaze has improved, and after a check CT scan, the entrapment, the implant is well in place. But every fracture need not be repaired. The indications for orbital fracture would be a clinically significant anophthalmos, which is by textbook says 2 millimeters, but it may not be significant for a person and you can leave it alone. In case of large orbital fractures, which involve more than 50% of that particular orbital wall, in extraocular muscle entrapment, and in white-eyed blowout fractures, which are seen typically in children, wherein you have a very short window for correction. Also, there are chances of bradycardia and vasovagal attack. So those fractures need to be repaired early, as callus formation is also quicker in children. So I'll just present 3 cases quickly, which there are preform orbital implants, which are small, medium, or large in size for either just the floor or floor medial wall. There are also 3D orbital floor implants, which have a better contour, and patient-specific implants are also available with 3D printing. So the case 1 presented with an axe injury to the right eye with ptosis and severe enophthalmos. Globe was almost thiacical, so functionally there was not much that could be done, but there was also floor and medial wall fracture. And here you could see that there was just a depression of the maxillary wall, like not just the maxillary rim, inferior orbital rim, which has caused it to move down. The patient could not afford a higher maxillofacial surgery, and so we just decided to give him a lift as he just wanted a better cosmetic appearance while he was going back to his hometown. Inferior conjunctival infiltration is done. Lateral canthotomy and cantholysis is required in the cases in which the space is limited to insert an implant. And it's easier in your earlier cases to release the lateral canthus as well as do inferior cantholysis. While approaching the inferior conjunctiva, in trauma cases, invariably the orbital septum has already ruptured. But if possible, if it is not, then you can enter just below the inferior tarsus so that you avoid rupturing the septum and the fat coming in your way. Once, as you can see, the inferior orbital rim is reached, you try to go a little beyond the inferior orbital rim so that you make your periosteal incision at that level and lift the periosteum, since your implant should ideally be placed below the periosteum of the orbital floor. I'm using a periosteal elevator to retract the contents superiorly, and the periosteal elevator is used to lift the periosteum. The contents which are prolapsed in the inferior orbit are gently teased out with the help of forceps and the suction cannula to take care of the hemostasis and better visibility. One must ensure that all the contents are brought out into the orbit or brought into the orbit and out of the maxillary sinus. But one must also be careful of the inferior orbital canal and not cause any traumatic injury or not use any sharp instruments there. One can check for which size of implant fits the best. Here I'm using a smaller size implant as the large one was too large in size for the size of the defect. And a gentle lift is given at the orbital rim to compensate for the depression that has been caused. And 1 or 2 point fixation can be done at a fixed point with the help of self-tapping and self-drilling screws so that the implant stays in place. A force duction test should be done before and after insertion of the implant. Canthus needs to be reformed. There was dystopia of the lateral canthus, so it needs to be reformed and placed at a comparable height to the other eye. With the help of 4-O-proline or even 6-O-proline would be fine. And conjunctiva is then closed. Ptosis was also corrected for him, and this was his post-op appearance with which he was reasonably happy. Case 2 was a patient which came with hardly any changes. You feel that this eye looks almost normal. On Hertel's and Nepziger's, there was 2 millimeter enophthalmos, and you can see there's a large floor fracture with no support posteriorly. So any porous polyethylene or any such kind of implant wouldn't find support. So a titanium implant would be the implant of choice. Like in the previous case, although this time I didn't go ahead with canthotomy cantholysis, and just an inferior orbital floor approach was done through the conjunctiva. You need a radiofrequency cautery. When you're closer to the nerve, it is better to use bipolar as it is neuroprotective instead of reusing the cutting cautery. Move ahead. And carefully retract the contents posteriorly and the lower lid needs to be retracted either with your DEMARs, but you need to have right angle retractors as well. I'll go ahead. Likewise, periosteal dissection is done, and once you've reached the orbital floor, you see the size of the defect. Most common site of injury is posteromedial in orbital floor fractures, and you give a gentle lift by molding the implant with your fingers itself and place it such that the posterior globe is lifted up and the enophthalmos is corrected for. If you do not have self-tapping, self-drilling screws, you would need a drill bit to make the drill hole and then fix your screw in place. Now this Patient had a mild inferior rectus palsy as he came late after about 4 months of injury, and a mild, some amount of inferior rectus resection had to be done so that his down gaze improved. A betaine wash is given to take care of the asepsis, and he had a very good post-operative outcome. The conjunctiva is well healed, and his ophthalmos is also very well corrected. So this was a straightforward case. This is a check CT scan, which shows even the posterior limit of the floor is well in place. The third case was the most challenging. This was like sir was just mentioning a bullhorn injury, just 1 day old injury, and you could not see the eyeball. You can all you see is the socket, and the globe actually was lying in the maxillary sinus. So to approach this, a Cadwell lock was done along with our maxillofacial surgeon, and the globe had to be pushed up, retracted, and muscles, with the help of muscle hooks, the globe was brought back into the socket, fixed in place, and the rest of the lid suturing was done. This was her appearance at 1 month, but unfortunately no visual prognosis. So to summarize, titanium implants are needed in absence of posterior support, or when there is loss of inferomedial orbital strut, or in rim abnormalities. The conjunctival approach is definitely more aesthetic, and it does not leave an external scar. Canthotomy and cantholysis should be done for larger implants, and we should involve an oculoplastic surgeon in your team. That's all. Thank you very much.
Wonderfully done surgeries that you have documented here. You mentioned about the titanium.
Yes.
Are there any other implants that you would also suggest?
Steel implants are available, but those are not really recommended. For smaller size fractures, I have used porous polyethylene, like Medpor or Biopor were the trade names. But also I've used osteopor, but that was a couple of years ago, wherein for children, for white-eyed blowout fractures, the callus formation is so quick, and it undergoes lysis in 2 to 3 months, 2.5 months. So osteopor also has worked well according to me. It's just a little more expensive than Biopor or Medpor. Yes.
Lovely videos. I wanted to ask you, you showed the floor involvement in all the 3 cases that you showed. Would you also want to have an ENT surgeon do a check scopy through the maxillary sinus and...
Suppose there is, so for the last case, the globe was in the sinus, so that's different. But other cases, if there's a hematoma, usually it resolves on its own, unless there's a foreign body. So we don't have a maxillary surgeon. I've never called somebody on board. But I do have an endoscope through which since I do endoscopic DCRs as well, I use an endoscope to just do a check scopy and also do suction under visualization, because anesthetists don't always see via, they themselves are happier if we do suction by ourselves under visualization up to the nasopharynx.
Generally, we don't require an ENT person for a check scopy. The reason being because the graft or the titanium or whatever implant we are putting is generally a little larger than the opening. So it is on the side of the orbit. Second thing that I'd like to make a note is wherever it is possible, we were going through the periorbita. So we are going between the periorbita and the bone and putting the implant. Many times we will not require to put in a screw over there. We don't like putting a screw basically because the eye is a mobile structure. If the muscles get incorporated into the screw, then there is a chance that the screw may be avulsed. A moving screw in an orbit is like a torpedo without a target. It can. I have seen screw which is impinging on the globe, almost going to go inside. That is something that we would definitely not like to happen.
Also, titanium does cause orbital adherence syndrome because it has pores, and it can, if you don't have a smooth surface on the superior, it can cause orbital adherence. So composite implant would be ideal, but then that would hike up your expenditure as well. Composite is Medpor, porous polyethylene over titanium. So that would
like I think some of the composite dental implants. Why did the eye not have vision?
Yeah, I had pictures but due to short of time, the patient had retinal whitening and retinal edema with hemorrhages. Probably there is, as the optic nerve is stretched, there must be some ischemic damage to the
avulsion of the optic nerve. Okay.
In terms of your inserting, are they lifelong?
Yes, ma'am.
After say 6 months or 2-3 years, you want to remove, you're keeping it there.
No, ma'am. Unless there's an infection or touch wood, unless there is some such eventuality, they would hopefully stay forever.
We generally use titanium because when we do an MRI, it's not contraindicated, because MRI and metal is something that is the metal going to move? That's not going to happen. But it will give rise to artifacts when we are going to do, especially when we are going to look for something in the brain, probably an SOL, things like that. Later on, it will give rise to an artifact.
I request Dr. Vidya Shankar to please hand over the memento to Dr. Akriti.
Thank you.
Is Dr. Supriya Sharma here? Yeah. We request her to give her talk. She's going to speak on turning tears into triumph.
So while Dr. Supriya sets it up, Dr. Manish Sharma, in these trauma cases, what are the medico-legal aspects? Can you please highlight some of them?
I think we have to look at it two ways. One is, like a lot of speakers covered it also, that we need to have very good history taking and documentation, preferably with photographs. More so because, injury to the eyes come under the grievous hurt. And in the old system, I think it was IPC 320, where you could be punished by up to 10 years of imprisonment if it's an injury inflicted. So you have a lot of legalities that come into it. Besides that, in cases where it is an injury which has happened on work, the compensation aspects, all of those come into play. So proper history taking to actually assess how the injury has happened, whether the safety was adequate or not, is a very important thing. If we are taking photographs, informing the relevant authorities, and it becomes extremely important. And beyond that, it is also important from your own perspective, if you are operating the patient, that the blame does not land upon you. So taking a proper informed consent from the patient is important, and documenting all of that and incorporating details of the surgical procedure would also be important.
What if it's a case of suspected assault, or and the patient and the relatives refuse to go and make a police case? How should you protect yourself, the ophthalmologist?
I think the history would be important. If you are suspecting it, and if they are not giving you that history, we would probably say accidental, because that's where wording is important. That accidental, if that history is not there, you do not really have the, you're not culpable or liable for that. But if we describe the mechanism that yes, it is an injury which has happened, and then the mechanism is up to them, so probably your legal liability would be limited in that case.
I think we also mentioned that who is the informant. Yes. Please.
All right. A very good afternoon, everyone. At the outset, I would like to thank Dr. Karubi and Dr. Natarajan for this opportunity. So I'm Dr. Supriya. I'm a faculty in the cornea and anterior segment services at SSCI in Vadala. So managing corneal tears is extremely challenging because the spectrum of presentation can vary. In fact, the tears which appear to be smaller are the ones which are most complicated to treat. In the armamentarium of a corneal surgeon to manage these tears, I think the most important is the preoperative assessment. We need to pay attention to identify if there is underlying any systemic conditions. Always examine the contralateral eye. For example, there's a history of trivial trauma and you see that the patient has a limbus to limbus tear. It's important to rule out keratoglobus. Other ocular conditions, identify what is the extent on clinical examination. Presenting visual acuity actually is a very important criteria for prognosticating such cases, and also determine the type of anesthesia, whether you can perform the surgery under a local or a general anesthesia. Need of imaging has already been highlighted by the previous speakers. If there is any corneal tear and you see an underlying iris defect with cataract, always rule out presence of an intraocular foreign body. So the commonest site of rupture is the limbus, followed by any area of weakness, that is surgical sites either in the cornea or the sclera and just behind the intraocular muscles. So quickly moving on to a few case scenarios. For example, if we have a If you have a non-perforating lamellar corneal tear, it's always important to perform a Siedel's test. 4 Siedels in fact, and if you feel that the globe is tectonically stable, just place a BCL to promote epithelialization and treat with antibiotics to prevent infection. However, even if it appears to be a cell seal tear, but there is iris incarceration or the wound looks infected or there is presence of tissue loss, then you need to intervene surgically. Linear corneal tears are extremely common but pretty straightforward to treat. You need to freshen up the edges, remove any kind of debris or loose epithelium. The first suture needs to be placed at the angle so that you divide the complicated tear into simple multiple linear tears, and then you just go on putting interrupted sutures. From the anterior chamber can be formed with saline or with viscoelastic, whatever as per the convenience of the surgeon. So this was like a scissor injury in a 7-year-old girl. This was a pretty straightforward case with simple linear tear not involving the limbus. The edges looked non-infected and multiple interrupted sutures were placed. The AC was formed with air bubble in this case. This becomes a little challenging, so either you can put an ACM that will form the AC continuously because air tends to repeat, there can be repeated air loss in these cases. All right. But it's always important to replace the air with saline at the end of surgery so that you ensure there's a watertight closure. So like already discussed, the ideal depth should be 90% because if it is very superficial, then there can be gaping of the posterior wound and there can be iris incarceration. If it's a full thickness tear, then there is a risk of infection, epithelial ingrowth, and that is not recommended. It's important to understand why interrupted sutures of ideal length should be placed, because there's a compression zone formed around each interrupted suture that we place, and it is important that these compression zones overlap each other. For example, if you take very short sutures, then there will be some gap in between the two, there will be some gap between the compression zone of the two sutures, and there's a tendency of wound leak in these cases. Triangular flaps, it's important to oppose the apex first, like as seen over here, where if you start repairing the linear edges, then there is a tendency that there can be gap at the edge of at the apex of the tear. So it's always important that you put an interrupted suture at the apex of the triangular flap and then go on repairing the linear ends. So this was a triangular flap created due to axe, and as we see, the first suture is placed at the apex of the triangle. So once the flap is opposed, then you start repairing from the two ends and then go on putting interrupted sutures just like a linear tear repair. Limbal tear repairs like these are again very common. Often they are associated with incarceration of the iris in the wound, and it is important that you explore the extent of the tear in these cases. So as we see, a limited conjunctival peritomy should be performed to assess the extent of scleral involvement, and whenever there is iris incarceration and abscission is performed, do not pull the iris out. Whatever is out can be just excised, and always if there is limbal involvement or there's involvement of sclera, there's always a risk that there may be some amount of vitreous, as could be seen over here, and it is important that we perform a vitrectomy, a limited vitrectomy in these cases, so that you do not suture the wound with the vitreous in the wound. So this is a vitrectomy being performed, and once you are sure that there is no residual vitreous in the wound, then the apex of the flap can be sutured. So limbal and corneal tears ideally are repaired using 10-0 nylon sutures and followed by scleral tear repair with vicryl. There is always a chance that once you do a scleral tear repair, you may have to come back and repair a few corneal wounds, and that should be done. Stellate tears are the most challenging, often occur due to blunt trauma, due to cope countercope injuries, and there are several techniques which have been described: purse string sutures and the Aiken method. Purse string, we suture it like multiple sutures are passed through the stellate edges, and then they are tied at one end. In the Aiken method, this is very similar to the multi-layer AMG, where multiple box sutures are placed over the entire radiate edges of the stellate tear. So this was a blast, this was a corneal tear post-blast injury. We can see there was tissue loss, there was iris incarceration. So when the exposed iris is removed, first the limbus is sutured so that the anatomy of the globe is, you come to know somewhat what is the extent of the tear. It's very important that if there is presence of cataract, so cataract should be left undisturbed. If there is no cataract, there's no cortical matter that is coming in the wound, it should be left like that and can be taken up as a secondary procedure. So here the 3 flaps were first sutured at the apex, and once that was done, multiple interrupted sutures were taken at the end. So the primary aim is to achieve tectonic stability. Counseling is very important in these cases so that you and the patient are on the same page as to what do you want and what the patient expects. It should be ensured that the patient is explained clearly that the primary aim of surgery here is the anatomical closure to prevent complication and not visual rehabilitation, which may require a multidisciplinary approach later on. Always examine the unaffected eye pre-op as well as post-operatively, because there's a risk of sympathetic ophthalmia in these cases. Be extremely cautious of infected wounds and wounds with tissue loss, and whenever in doubt, always prefer the multi-stage approach. Thank you very much.
Thank you so much for a wonderful talk. Would you like to give any specific info on how you would take care of astigmatism surgically before or after to reduce astigmatism?
So first of all, to reduce astigmatism, we need to be sure, so surgery starts right from the time we are repairing the wound. So you have to ensure that there is no override as well as underride of the edges. So like I said, optimum depth of closure, so 90% is what we prefer. If you tend to take very superficial, then there can be wound gape, or if there is too deep, then there is an override which leads to astigmatism. Once the wound heals, usually in children we would, depends 2 to 3 months is the ideal time when you would go ahead with suture removal. If the patient is improving with glasses, so the challenge lies when it is involving the visual axis. So in those cases, either with glasses or with contact lenses if the lens is clear. However, if there is involvement of the crystalline lens, then you will have to perform a cataract surgery, which will be at a later stage. But contact lenses, RGP lenses do pretty well. Otherwise, we have mini-scleral lenses that can also be given to these patients. But the challenge lies in the mini-scleral lenses, like the patient needs to practice a little bit, and the cost of the lens. So that is something which is a limitation in the...
Do you feel that the tightness or the looseness of the stitch, when you are taking, does it play a role in astigmatism?
Definitely, ma'am.
Some sutures are
yeah, yes. That's why it's recommended that we, for seasoned people, like very senior seasoned people, we can do it under air, but ideally it should be under saline. And there is always, it's okay to revise a few sutures if you feel that they are tight or loose at the end of surgery, rather than to have take up the patient, again for a wound revision. So, and always never close the air, like this is what I feel, that you should never close the case under air, because we feel that air would, prevent this to escape, but the air is going to get absorbed within a period of a week, and there can be wound leak in these cases. So always make sure that it's watertight. However, sometimes if we are forming the AC, if we make it too tight, there might be some amount of ooze, which is normal, because we've seen, like even during my fellowship in the earlier phases, there's a tendency to revise these sutures, but that will settle down once the globe IOP stabilizes. So we should not go ahead and be extremely aggressive to even go and repair those small oozes.
A very small tear where the anterior chamber is well formed and it's in the central area.
Yeah.
Anterior chamber is very well formed. It's a very small tear, maybe 1 millimeter long, maybe half a millimeter. How would you manage?
So if it's not infected and there's, like you said, there's no tissue loss, you can place a BCL, just allow epithelialization, and I mean, it does not need to be intervened surgically.
Thank you so much. May I request Kirit sir to please hand over a memento to her. Our next speaker is Dr. Shubham Atal, who's going to talk about case of polytrauma with eye injury. Shubham is a orthopedician.
ये नहीं है आपके पास टाइप सी?
He's from Sion Hospital.
टाइप सी नहीं है? नहीं है? I'll get it now. Yes.
As Sion Hospital faces lots of trauma patients, it falls on the highway. I mean, it's the first hospital, and we get lot of trauma patients coming from Konkan side, even Central or Western Railway side. So our orthopedic department is the first who meets. They are always stationed. So Shubham is one of them, and they are always there in the casualty EMS and surgical area, which is just facing the main road. So these patients are, they are first seen by them, and their life saving, it takes precedence over the eye saving. So many times it is possible that the call does not come to the ophthalmology. But the things have improved over years, and our ophthalmic resident, Mrudula and Mumbai, are also here. So 24 hours they are on call, and immediately they go and see the patient. So I would thank ortho department, surgical department. Vinit Kumar was also here for this cooperation towards treating all the patients of trauma.
Thank you, ma'am.
Good afternoon, everyone. I am Dr. Shubham Atal, Assistant Professor, Department of Orthopedics, Sion Hospital. I thank the Ophthalmic Society and Dr. Chaya Shinde ma'am, HOD Department of Orthopedics, Department of Ophthalmology, Sion Hospital, for inviting me. My talk will be basically about the polytrauma patients, how we handle the polytrauma patients in casualty, because these patients, they don't only have a single injury that is related to orthopedics or to general surgery, they have a multimodal injury. So polytrauma means a syndrome of multiple injuries with systemic reactions which may lead to dysfunction or failure of vital organs and system. Polytrauma managements require a multimodal approach comprising of surgeons and physicians. These surgeons are both general surgeons, orthopedic surgeons, ophthalmologists, ophthalm surgeons. Multiple fracture does not mean a polytrauma. Even a single fracture associated with head, chest, pelvic injury or any other injury will comprise a polytrauma. Orthopedic injuries are generally not that life-threatening, so unless they have a hemodynamic instability. The identification of eye injuries is a challenge in polytrauma patients. There are multiple reasons. Primarily, it is due to the presence of life-threatening injuries and evident injuries which receive the priority, that is the chest injury or head injury. Secondly, the patients are unconscious, brought in a debilitated state, so they cannot say what exactly the trauma they had faced. Other causes could be periorbital swelling, all these facts are based on a study which was conducted in association of orthopedic department and ophthalmic department. So ocular or orbital injuries are present in almost 7 to 15% of polytrauma patients. Most of these polytrauma patients are young age group people. Road traffic accident is the most common cause of polytrauma. Also, it is the most common cause of associated ophthalmic injuries. Other causes are fall from height, assault, workplace accidents. So orbital wall fractures are the most common associated eye injuries in polytrauma, followed by periorbital hematoma, subconjunctival hemorrhage, ocular adnexal injuries, optic nerve injuries, perforating globe injuries. Majority of patients associated with eye injury have associated head injury, facial injury, or both. So this is a basic algorithm which we follow for management of polytrauma patients. So first thing is we have to resuscitate the patient, that is we have to take control of airway, breathing, circulation. Then when the patient is primarily stabilized, then we do a secondary survey for other injuries, that is the orthopedic injuries. In this also we assess for ENT injuries, ophthalm injuries. If we suspect some eye or orbital injuries there, then we consult to ophthalmologists and plastic surgeons. These are some basic absolute indications for ophthalmology referral. You can add to this list because this is the basic what we think is important, like open globe injuries is there, ocular foreign body, some chemical burn injuries there, children's eyelid injury with tissue loss or lacrimal injuries, orbital wall fractures with eye injuries. I have been here since half hour. I have seen all the presenters presenting the cases related to trauma. These are some pictures. I don't know how useful are this for you, because this is basic eye injuries which I have in my record, which we have managed in association with ophthalmic surgeons at Sion Hospital. Okay. Thank you. So, if any questions you have.
Very nice presentation. Thank you very much. Just a couple of things for your team, which is managing polytrauma, as well as for the younger ophthalmologists who might be coming, to visit the casualty. That any eye where there is anything, any subconjunctival hemorrhage or any unexplained chemosis, even if it's an unconscious patient, please do suspect an open globe injury. And while you're repairing all the periocular tissues, do not forget about the eyeball, because even apparently no PL eyes can sometimes be saved, and we can bring back vision in those eyes.
Yes, sir.
So do not, forget about the globe itself.
Basically, sir, working at a trauma center. Yes, sir.
Other problem is most of the trauma patients are treated by the eye department exclusively. So they don't have a general hospital. And that is why many a time they miss general hospital patient.
Yes, sir, but sir, Sion Hospital is a very renowned institute and a trauma center. So this institute, if any patient is coming to casualty, all the departments are actively involved in the patient management, be it general surgeons, be it orthopedicians, be it ophthalm department, be it ENT department. So there, I assure you that there is no neglect to the patient treatment from our side.
No, we are not saying as a neglect.
No, sir, not neglect, but I am just assuring to the society, this is for a general society.
Many of us are from Sion only. We have done our this from Sion. So the second thing is where a patient in orthopedic is generally going to be there for a pretty long time. Many times it is such that we find the patients may not be directly in orthopedic, but with ortho and neuro. There is a corneal involvement because of an exposure and things like that. Those are sometimes where you can involve, let the residents come and have a routine probably every 2-3 days just to look at the cornea and things like that. That's all.
Sure. Thank you.
Thank you very much. I'll request Dr. Natarajan to present the memento to Dr. Atal. Dr. Natarajan, please present the memento and certificate to Dr. Atal.
I have met you, ma'am.
Next speaker is Dr. Mridula Kole, IOB following trauma causing double perforation of globe corneal tears.
No questions.
This one, no? Wait. Give me a second. Where's the pointer?
Our next speaker after her is going to be Dr. Ashish Vaidya, so the audiovisual department can keep his slides also ready.
Good morning, myself Dr. Mridula Kolle, junior resident from LTMMC Sion Hospital. I will be presenting a case of post-traumatic intraorbital foreign body. We'll go towards the case history. There was a 37-year-old male presented to us with laceration over right cheek extending to right eye and forehead due to steel blender blade trauma at workplace. Patient was vitally stable and there was no history of head injury or loss of consciousness or convulsion or vomiting. There was no history of previous ocular surgery or spectacle use, no history of any systemic illness, and there was no treatment taken for the same elsewhere. On torchlight examination, right eye vision was denying PL. There was full thickness upper lid laceration extending to forehead. Full thickness scleral and corneal tear with volume loss was present. Foreign body was noted lodged in orbital bone. Left eye vision was finger counting 3 meter bedside. An anterior segment and fundus were within normal limit. On CT orbit, there was loss of volume of right globe with multiple hyperdense of averagely 1500 Hounsfield unit. Foreign bodies with largest measuring 7.1 millimeters by 21.2 millimeter in size. Comminuted displaced fracture of lateral wall of right orbit was noted. These are CT plates showing the intraorbital foreign body. First is coronal view. This is the foreign body lodged in lateral wall of orbit showing the fracture of lateral wall. This is the sagittal view showing giving us more clear picture of orientation of intraorbital foreign body lodged in the lateral wall of orbit. This is the 3D view of 3D view which gives a more clear picture of orientation of intraorbital foreign body in orbit. This is the clinical picture. Management, we managed this case by right eye sclerocorneal tear repair followed by removal of foreign body. Right eye lateral wall of fracture repair was done with eyelid tear repair. We took this patient on emergency basis in OT. So take home message was retained foreign bodies may give rise to cellulitis or abscess or fistula and impaired vision and motility. Prompt detection and accurate localization of intraorbital foreign bodies or intraocular foreign bodies are essential for optimum management of patients to enable surgeon to plan the most traumatic method of removing IOFB. CT scan is very useful in determining size of foreign bodies and localizing them as intraocular, extraocular or retroocular. CT is generally considered the gold standard in evaluation of IOFBs because it is safe to use with metallic IOFBs, excludes orbitocranial extension and is also able to diagnose orbital wall fractures and orbital sepsis with high accuracy. Other potential complications excludable by CT are abscess formation in orbit, bone or brain. MRI is generally not recommended for evaluation of foreign bodies because of risk associated with magnetic metal. Thank you.
Thank you, Dr. I request Dr. Manish Sharma to present the memento and certificate to her. Dr. Ashish, please come. Our next speaker is going to be Dr. Natarajan himself. So the audiovisual people can please keep his presentation ready.
While Manish is standing here, I have an apology to make to him in public. I had given him a topic of medico-legal counseling, but I had forgotten to add it in this, so that's the reason why he's not speaking today.
He can still speak, no?
Yeah, he can speak, but he said that he would like to do it well.
Between the talks, they're discussing about the medico-legal aspects, so you have done justice.
We did discuss some bit of it, and we'll leave it for another occasion.
Dr. Ashish Vaidya is a senior vitreoretinal specialist and an excellent vitreoretinal surgeon.
So I'm going to talk about something else for a change. Yeah. Thank you. At the outset, I would like to thank Karobi and Dr. Natarajan for inviting me here. So my talk today is going to be something which is very simple, but I think something which the residents especially can go back and do it in their OTs, because this is something which is a common problem. So my case is a 59-year-old female who was enjoying a holiday in Kerala in a picnic in a coconut grove along with her friends. Suddenly there was a sea eagle who got a fish and was perched on the top of the tree, and a friend asked her to look up and see it. She looked it up and her world changed. The moment she looked up, of course she didn't hit the tree with the axe, but a coconut fell and it struck her eye. So she had a blunt trauma on the eye, and what happened with that was that the vision was PL, there was total hyphema. The B scan showed a lens dislocated in the vitreous hemorrhage and superior retinal detachment. By the time she came to me from Kerala, she was a Bombay resident. It was about 4 to 5 days after the initial injury. And that is when the superior retinal detachment was there. We did treat her, and here you can see with the bubble of vitrectomy with a gas bubble, and she did recover quite well. The IOL was not put at the primary surgery because this was a patient who had a severe trauma and we were not sure whether the retina would remain attached or no. Maybe the retina would have got detached later on. And then this was a patient's vision was 6/6, N6, patient had aphakia with a huge traumatic mydriasis, and now we were wondering how to rehabilitate this patient. This is something which we see very often in a patient with blunt trauma. So first we tried and gave her some contact lenses. She used the contact lens for about 3 months, then she gave up. Then she tried using glasses intermittently. That was obviously not going to work because the other eye was plano for distance. And then she was lost to follow-up. Then she came a couple of years later and she said that, well, I'm not doing anything with this eye. So we said, okay, fine, let's give it a try. And that is when we decided to go ahead and do this surgery. Here you can see the patient has traumatic mydriasis. So what we are going to do is we are going to suture this by Dr. Amar Agarwal's technique. Here you can see I'm taking the needle, passing it through the iris, we'll railroad it afterwards. Now I'm taking a 26 gauge needle, passing the needle through the iris. And this is something which you as residents can definitely do in the OT. It's not a difficult technique to do. I'm showing it purposefully step by step. Here you can see that the needle is gone through and come out. Once the needle is out, you pull the needle all the way through. Now there is a suture which is going from the one side limbus through the iris, again through the iris. Now we are going to hook the suture and get the suture out and then try a slip knot. So with the help of a hook, I am just getting the suture out. It didn't come out. So you have to have all the instruments at your command, and with the help of the forceps I got the suture out. And now we will do a 4-throw pupilloplasty. So here you can see that with the help of the needle, I am passing the needle through that loop. 1, 2, 3, and 4. This is something, as I said, very easy to do, not difficult at all. And then we pull the suture so that the 4th row comes over here and it zippers up the iris and closes it off. Now following which you can cut it. You can either cut it with a MVR blade or you can cut it with a scissor. So here I am cutting it with the MVR blade. So we'll just run a little bit faster on this video. So similarly, what happened? ये क्या हो गया? वापस स्टार्ट नहीं बीच में हो नहीं रहा, आगे आगे और वापस स्टार्टिंग से ही जा रहा है. No, so similarly we take 2 sutures on either side so that the pupil comes down, and then we put an iris claw lens. I was going to show you the iris claw lens for the residents, but it's okay. Yeah. So this is the post-operative picture. Post-operative on day 1, patient's vision was about 612. The pupil is still a little more dilated. Over here you can see the nice round circular pupil with a vision restored back to 6, and 6. Thank you.
Excellent video. We request Dr. J.Moses to present the memento to Dr. Ashish sir. Dr. Natarajan, will you please come to the podium? Audio visual, please keep Dr. Natarajan's presentation.
Here, sir. Memento. मेरा स्लाइड डाल रहे.
Thank you, Dr. Ashish.
At the outset, can I have the slides? I think this slide is, this presentation is a company-sponsored presentation, and we all know that we need funds to run the organization, and trauma does not get any funding. So thanks to Roche for supporting us, and I've signed a lot of agreements with them for giving this talk. Can I have the slide? Right. So in the meantime, the slides come. I want to tell thanks to Dr. Lahiri for totally running the show, even though she keeps calling me and asking me, but I told her, please do that. So all of you are sitting for a long time. Can you give a standing ovation to Dr. Kerubi? No, you don't have to stand up. All others stand up. So they're sitting for a long time. Thank you, Kerobi. So me and Kerobi are working together from 1987, later in 89 in Bombay Hospital, and continuing to do so. Please take a seat together. So we are happy to create a team. So it's not Aditya Jyot or Kamala Sundaram or any of the organization, but I want to announce, it's already come. Okay. So announce on March 18th is a Tuesday. We are going to do a mega CME with Dr. Ferenc Kuhn, who's one of the pioneers in ophthalmic trauma. But he started his career in, I think, 1977, he told me. But 80s, the vitreoretinal surgery was not well developed, and he was not allowed to do vitreoretinal in Hungary that time. Maybe he also started in 82 or something. And I started in 1984 with Dr. Badrinath. And after that, Dr. Badrinath was kind enough to bring Dr. Jovanovic through because of Dr. Kinney that time from Boston said, if you want to know what is vitreoretinal surgery, Boston is nothing, you have to go to Rotterdam. And that's how me, Dr. Ferenc Kuhn, Dr. Klaas Eckhart, and many others in Cesare Forlini, Thanasis Nikolakopoulos in that age group, they are all grown old, but I'm growing young. Thanks to Kerobi also looks young. So with this, so March 18th, please make a note. I want to do live surgery. I think Boston Lom is here. Hope to get that C-Luma microscope, and you will sponsor and we'll transmit the images to the world, their surgery, because now Aditya Jyot, we are doing every 3 months some surgery and showing to the rest of the world. Recently I did for Cairo, a few months back to Verona, Munich meeting in Verona, because Dr. Eckhart is retired now. So thanks to Roche for asking me to speak this, and I'm glad I introduced the Webismo even before the Government of India approved. So I don't know how many ophthalmologists know that when the drug is not approved, the companies don't give the drug to you. So Government of India has got a rule where if the ophthalmologist recommends or any doctor recommends any treatment which is approved in FDA or CE in Europe, the patient can import with your prescription. So we had a patient who wanted, we was treated with Eylea for long, and then he wanted, because he was recommended on a teleconsultation with Moorfields to Webismo, and my friends in Europe are already using and said, it's a fantastic, you should try. And the patient was ready. That time it was 2.5 lakhs for getting one injection, and the patient took every month. So thanks to my patients who are affording. And now I think the idea was using this drug is the importance of targeting angiotensin II and VEGF-A with faricimab for additional clinical benefit in the neovascular AMD and diabetic macular edema. And this presentation is intended for eye doctor. That's what the Roche wants me to tell. And does more anti-VEGF improve anatomic outcomes? And what is our current understanding? The main thing is this is a READ-3 study and a photon. Increasing the dose of anti-VEGF by 4 times did not further improve fluid control. So I think that's where you have to titrate, and we need not do any trial which has been approved the rest of the world, which is going to be different. One for economy in India, second the patient, but plus we have all strata of public, the richest of rich, and also the poorest of poor. That's why we have the sophisticated private hospitals, and now we are starting a charitable vitreoretinal unit in Chembur. So how do you see the clinical impact of angiotensin II inhibition based on improvement in clinical biomarkers with faricimab versus aflibercept? For example, fluid reduction, macular leakage, epiretinal membrane. So elevated angiotensin II contributes to vascular instability, and you can see the vascular stability in the healthy tissues, and this is altered by the increase in the angiotensin II. And only faricimab suppresses angiotensin II in patients in phase 3 neovascular AMD and DME trials. We all know that even steroids work in diabetic macular edema, but you have to know the pathogenesis of both ARMD and the diabetic macular edema. And improvement in clinical biomarkers with faricimab, dual pathway inhibition with faricimab, the anti-angiotensin II plus the anti-VEGF-A. You can see here the greater reduction of fluid on OCT in diabetic macular edema, and greater resolution of intraretinal fluid in diabetic macular edema, and the greater reduction of ERM development in diabetic macular edema. So greater resolution of macular leakage. So recently, one of VIP patient I'm treating from 2005, he developed a ERM. I told the treating surgeon Neil Bressler he actually gave opinion in Johns Hopkins, and I said I would like to switch over from Eylea to faricimab, and he was saying no, Eylea has more number of years follow-up and we'll wait. But actually he started with ranibizumab in US, and then I started with Lucentis that time and switched over to Eylea, and now even though Dr. Neil Bressler did not agree, I have shifted the patient to Vabysmo. The reason is there is no financial interest, and my point is the patient is important for me, and the disease control with faricimab was anti-VEGF monotherapy, and it's extended durability beyond Q12. And improved fluid control with faricimab versus aflibercept during the head-to-head phase in diabetic macular edema. This is a Yosemite-Rhine pooled post-hoc analysis. Targeting angiotensin 2 in combination with VEGF improves fluid control versus anti-VEGF alone. And I like to keep the macula dry, and for that patient compliance is important. Unfortunately, anybody can give injection, but some of my patients want only me to give. So this time I took a patient to Johns Hopkins, and he said, you both have to adjust the timetable, and I travel every week, but it's a tough time to manage that. But better to do when the vision is good, and even if the fluid is there, sometimes the patients get improvement, but I should not stop the treatment till it's dry. And reduce macular leakage area with faricimab with aflibercept in the head-to-head dosing phase in the diabetic macular edema. And here you see the initial dosing phase. Faricimab 6 milligram, and this is a median baseline macular leakage area is about 24.6 square millimeter. So greater anatomic improvements with faricimab with aflibercept during the head-to-head dosing phase in neovascular AMD. This is a Tenaya and Lucerne pooled post-hoc dialysis. You have the central thickness change from baseline and absence of subretinal fluid and intraretinal fluid. So greater reduction in the HRF volume in the total retina with faricimab versus aflibercept is in the Yosemite-Rhine study. You see the original B scan and the post-process results of the HRF segmentation. And this is the end phase view. You see the red, which is the HRF is about 50, less than equal to 50 micron. And through week 100, faricimab Q8W led to a 52% reduction in the risk of ERM formation with the aflibercept in the Q8W in the DME. So I think this part, I'm not having personal experience. Based on the study, we are observing the patient, and that's why when we do a OCT every month, sometimes patients are tired. No, sorry, there's a fluid. Why do you want to do OCT? And they think we are doing OCT for charging. And I think the whole thing, the patient has to understand that we are doing the OCT for really knowing what's happening in the layers of retina. And among patients with PED in any location, around 20% of PEDs at baseline were predominantly serous. And this is the post-hoc dialysis, the 647 patients with the faricimab and 638 with the aflibercept. You see the predominantly fibrovascular in 41% in faricimab, and predominantly serous in 19.3, and fibrovascular only in 38.9. And in the aflibercept, you see 45.5% by fibrovascular, 14.7% serous, and fibrovascular only is 30.7%. So the presence of serous PD at week 12 and serous PD thickness from the head-to-head phase were reduced with faricimab versus aflibercept, and you can see here this is week 12 and the difference versus the aflibercept. And promising data in PCV, faricimab for treatment-naive PCV, the Salvin trial. The faricimab for treatment-naive PCV, week 16, results from the Salvin trial, which is presented in the recent Singapore Asia-Pacific APVRS. The key ocular inclusion criteria was confirmed diagnosis by the investigator of active symptomatic macular PCV defined by macular polypoidal lesion showed by the ICG angiography and presence of exudative or hemorrhagic features involving the macula, and BCV of 78 to 24 ETDRS letters, 20 by 32 to 20 by 320, approximately Snellen equivalent. Recruitment of participants with more than 73 letters will be capped at 20%. And these are the exclusion criteria for PCV. and the salve design is adapted from tenyl and leucerin trial design. And here you see the faricimab, the initial dosing phase, then the disease activity assessment and primary endpoint. And treat an extended period faricimab Q8W to Q20, that's 20 weeks. So robust BCVA increase from baseline through week 16, and you can see the week 16, the plus 7.8 letters. Clinically relevant CST decrease from baseline through week 16, it goes to minus 145 micron. And 80% of patients with absence of retinal fluid at week 16. And I think that's about 135 patients with faricimab. And majority of polypoidal lesions were closed or inactivated at week 16. And polypoidal lesion, you can see complete regression in 51% and inactive lesions in 86%. And faricimab is well tolerated through week 16, and these are the adverse effects through week 16. The serious ocular in about 4 patients, and special into the intraocular inflammation, iridocyclitis in 2, retinal vasculitis in 1. And this is comparable and probably better than the other anti-VEGF available. The real-world evidence in the neovascular AMD and DME, this is a prospective observational study conducted on 22 eyes from 22 treatment-naive patients with NAMD, and PD was defined as the PED exceeding 400 micron, and participants were administered intravitreal faricimab at baseline and days 30, 60, and 90. So the reduction in the PED volume, treatment with the faricimab resulted in significant reduction in mean PED volume. And the study also showed a statistically significant improvement in the best corrected visual acuity correlating with the reduction in the PED volume. So that's why the optometrists are very important in evaluating the refraction and the vision, as well as the OCT study. So faricimab is well tolerated with no serious side effects. And this is a loading phase with the faricimab retrospective analysis. Patients with active neovascular AMD and DME treated with 4 monthly intravitreal injections of faricimab, both naive and previously treated, 16 eyes of 15 patients with the neovascular AMD and 15 eyes of 12 patients with the DME, and mean best corrected visual acuity changed from 0.68 to 0.53 and from 0.51 to 0.32 at week 16. A statistically significant mean CST reduction was reported in both groups at last visit. 75% and 33% of eyes with AMD and DME respectively achieved a complete retinal fluid resolution at least in the end of 16 weeks. And this is a mean best corrected visual acuity, which there was no, again, significant adverse effects. After safety concerns with brolucizumab occurred in 2020, data suggests increased awareness and reporting of retinal vein and the ROV. So faricimab has a favorable safety profile, analysis of the Western database to improve the understanding of anti-VEGF safety with respect to retinal vasculitis with or without occlusion in a real-world setting. If you tell all this to the patient, patients are worried, and particularly brolucizumab. As a surgeon, I was worried, so I was not willing to do it, and I completely avoided, and when faricimab results were good, I switched over even for most of the patients to treatment naive in case the patient can afford the faricimab, and they also come out with some patient benefit program where you first injection, second injection, some cost, all that my counselors take care, and I don't get involved in that. I only talk the medical science to the patient. Faricimab should be preferred choice in treatment naive and neovascular AMD and DME patients as per the study which I presented, as well as my personal experience. Phase 3 trials in AMD included the treatment naive AMD patients, and I have treated many treatment naive patients. Phase 3 trials in DME included treatment naive DME patients and previously treated with anti-VEGF agents and last treated less than 3 months before, but limited to 25% of total enrollment. An improvement in clinical biomarkers with faricimab was aflibercept. Real-world data further reinforces the importance of targeting anti-angiotensin 2 and VEGF-A for better outcomes. robust evidence suggests faricimab as a first line and first choice treatment of neovascular AMD and DME. So this is the Vabysmo, and so I suggest that even you listen to a lot of pharmacology, pharmaceuticals supported talk. That's why you, from the US, you every pay, I think you have to write the financial disclosure, and otherwise you can't even present. So the reason is the ophthalmologist, treating physician should know what is our involvement, and you should know the real truth, and then we should tell the truth to the patient, because for me, patient is God, and I think when they improve, I tell them thank God. Even when they don't improve or don't, the reduction in vision, I tell them thank God. So I have my consent form for the last maybe 35 years, saying that with any treatment, including anti-VEGF, because I introduced anti-VEGF in 2006, and then I introduced Lucentis, the aflibercept, Eylea, and now Vabysmo, and before that even 25 gauge and 27 gauge. Every time I tell them there are three things possible: improvement, no improvement, and deterioration. Only one thing you will get. So if you are ready for results for three, then only comes. So the patient will say, sir, if the vision goes down, what to do? I said, that's the question I'm asking you. If the vision goes down, what to do? You answer me, then I will start the treatment. Because pathology can progress and reduce the vision. How can you blame the surgeon or the injection? An injection per se can have vasculitis or retinal vein occlusion or any of these vascular problem, inflammation, endophthalmitis. So I think everybody, if the patient reads the total truth, many are not ready. But I tell them, if you don't know the truth, I will not treat. And thanks, Roche, again, and thanks for everybody for a patient listening. And thank you very much. And Kerobi, the last part, you put group photo, and then the finished. Now the new group have come. Okay, one more group photo, and then high tea is waiting for everybody. And whoever can stay back for the inaugural program, we are inaugurating 5 things. This is my. So we can have all of you can come here, yeah. Some people can come to the stage and.
Thank you so much for the talk, sir.
Thank you. Parito, you want to say something?
No, sir was asking, is there a memento for you?
No, I already got. Thank you. And so the main thing is we'll have a stand for group photograph. So some people can come in there.
Thank Dr. Kirit Modi sir, Dr. Usha Johri madam, Dr. Manish Sharma, Dr. Vidya Shankar, Dr. Purva, Dr. Karobi for having all of us over here, and Dr. Natarajan for organizing such a wonderful
No, it's our program. So that's what I'm trying to mingle. So I'm happy. Yeah, thanks the audience. And I'm happy. I'm an emeritus professor in Sion Medical College, and Sion Medical College supports me.
Chaya Shinde and a wonderful team.
Yes, and also, so I think we have many others, and my dream is we should do more programs, and I will be in the background, and all of you do it, and I will get the funding. That's how, this is what I'm doing. So when the pharmaceutical pays the foundation, they tell me to dance, I dance.
Sir, I have a slightly different view. I think all of us are rich enough to afford our own lunches. We should not be asking for sponsors. We should sponsor our own lunch. And
I agree. I agree. But we have to pay the audiovisual. We have to pay the audiovisual. We have to pay the.
No, we can afford it, sir. All of us earn enough to afford it. We should just have pure science, sir.
So, Kerobi, you like to come up or stand down? Okay. So, all of you can, whoever are entering, can you come here for a group photograph here? Purva, you can come up. Madam, you can come up. Even the postgraduates and all others who are sitting here, can you stand in the front row? We can stand here, madam, on this row, because easy for the photograph. All will be. Come. Yeah. So I am very glad Dr. Kirit Modi was, Kirit Modi, even though I didn't study in Bombay, Dr. Kirit Modi was referring patients to me from 1984, and he was the one who conducted my wedding also. And a special thanks to Dr. Navendu, and he was a quiet observer today from morning, and he hosted the faculty dinner and Aditya Jyot alumni dinner yesterday. So from now we are going to have, where is Vidya? Vidya? Abhi aao yaar, photo ke liye. Ask somebody. Hey, all of you come here. Can you come to the here? Please stand. Jyoti. Organize them here, no? नहीं सबको इधर आने के बोलिए नहीं ठीक है ना हेलो doesn't matter यार don't remove anything यार let them stand here बस all of you come here all of you come in the front here you yes all of you come yeah I didn't see your voice. No, I come between. I'll come between. Yeah, all of you come here. Please come. Hello, last floor. Come to the front. Join us in the group photograph. Please come. Sir, all of you clap. Sir, Ramdas. Sir, please come, sir. Hey, come in, sir. Joseph, bring sir in the seat. No, you come, sir. No. Sir, photograph will go. We'll have another photo later. From a concern college. Don't come here. Yeah, one more and leave them. You see, you can do the volunteer.
Then I have to take the permission from my wife.
Huh? No, but Lord Muruga has two wives. Please come and join here. Come. Hey, Sachin, come here. You gave money to them now. Where is Vidya? Ready? Yes. And you also smile, yeah?
Yes, ready. Smile, please. One more.
Take two more, yeah. Okay, thumbs up, एक.
Yeah, thumbs up.
सब लोग आ रहे हैं? Okay, and the Korean love.
प्लॅटफॉर्म मिळतोय. येस